Everybody, I'd like to welcome you to our meeting of our Medical Affairs Subcommittee this morning. Thank you for your patience. Is one thing we've learned with dealing with the COVID. We've learned how to deal with virtual, but there's also some problems that come with that, making sure everybody's online and everybody can see everything. So I want to thank y'all for being here and the members of the subcommittee. I've got Senator Corbin to my left from Greenville. I'm Shane Martin from Spartanburg, Greenville and Union counties. And then to my right is Senator Tom Davis, and from Beaufort, and from Colleton, Jasper, and others, Senator Margie Bright Matthews. They're on the subcommittee, and I think Senator McLeod from Richland is coming with us. Also joining us today on the Medical Affairs Committee, joining virtually, is Senator Marlon Kempson from Charleston, and he's muted, and thank you for that, Senator. No. So anyway, we've got also our minority leader, Brad Hutto from Orangeburg, Senator Billy Garrett from Greenwood, Senator John Scott from Richland, and the chairman of our full committee, Senator Danny Verdon. And we have Senator Josh Kimbrell in the audience with us today. Out of senatorial courtesy, we're going to ask you, Senator Kimbrell, you wanted to say a few words to address this subcommittee, and I'd like for you to step forward now. And while you're coming to the podium, I do want to say a brief moment. Last week, we heard from folks who've dealt with situations with loved ones or their personal experiences in dealing with COVID and getting treatment. We wanted to hear from all of those folks last week. This week, we're going to hear from DHEC, medical professionals, hospitals, other doctors from that standpoint of how we're dealing with COVID and how we're getting treatments to the constituency we represent. So appreciate everybody's patience and realizing why we wanted to break it up into two groups. And also, just for everybody's knowledge, on the 29th, the same time, I have this room reserved, but it'll be at the call of the chair whether or not we have another subcommittee meeting. So I wanted to let everybody know that. So anyway, Senator Kimbrell, thank you for being with us.
Mr. Chairman, thank you, and members of the subcommittee, thank you for the chance to speak to you. Mr. Chairman Verdon of the Full Medical Affairs, y'all are the busiest committee in the Senate this year, I think, and it's good to see everybody again, although unfortunately not under great circumstances as we're dealing with the new surge of COVID, Delta variant and other mutations or variants of the virus that may be coming down the pike. I wanted to take just a moment, and Mr. Chairman, of course, you and I represent the same county. Part of your district is Spartanburg County, of course, my entire district is Spartanburg County. And we have seen a significant surge in Spartanburg and a significant rate of transmission of this new Delta variant. And the response, I think, has been a little discouraging. So that's why I'm here today to speak on behalf of many of my constituents with whom I've worked directly. My office has worked directly over the past few weeks and months and share with you our kind of observations and what I think, hopefully, together as a Senate, we can do better. You know, I've heard before that, I've never seen a virus this politicized, right or left. We've never seen a response to a virus in my lifetime, at least, this politically driven. And I think that's unfortunate because we start to miss what works and doesn't work in the name of politics on both sides of the political spectrum. And I'm not here to add fuel to that fire, but just simply to tell you what we've witnessed back home. We've heard this largely described as a war on COVID, fighting a war, fighting a battle. And if that's true, then I hate to say I think it's become a lot like Vietnam in terms of the quagmire that it's now become. And largely for the same reason, because it's being driven, the response unfortunately is not driven by doctors on the front line as much as it is by bureaucrats, by agencies, and by folks who have less experience on the front line than they do working in an agency. Let me give you an example so it's real world and I'm not just talking theoretical. The number 2 guy at my company, I'm CEO of a private company back home, and my number 2 guy, my right-hand guy, he and his wife both moved here from California last year, and they're healthy, young, mid-30s folks, and they contracted the Delta variant back around Labor Day. And it's been a saga ever since then. It's been a very difficult situation for them to get adequate treatment. So they came to, of course, knowing me as a coworker and as a friend, came to me and said, hey, look, can you reach out to somebody and get us some help? Because they could not get any kind of immediate treatment and their condition continued to worsen. The wife particularly developed viral pneumonia, and we reached out to a local clinic, Mr. Chairman, in your neck of the woods, and we asked for monoclonal antibody treatment, the Regeneron treatment that was scheduled, but because of a bottleneck coming out of DHHS, there was a 72-hour delay before they could get in from the time we called about an appointment. And during that period of time, the wife's condition began to deteriorate to the point that she went to the hospital in Spartanburg and went into the emergency room. And then things really, truly began to spiral. She was diagnosed, and she forwarded to my office copies of the diagnosis with viral pneumonia. They said that she could be admitted and put into a bed, and they could do the BiPAP or things of that nature. She didn't want that. She didn't want to be admitted. She didn't want to stay, so she said, I'm going to leave. Can you do anything for me? She was sent away from the hospital without even so much as a prescription. Her office, she called my office and said, can you do anything? We literally had to call a medical college to get her into a private practice so she could get a prescription for antibiotics for a diagnosis of viral pneumonia. I find that to be truly amazing. And then a few days later, she was able to go and get the monoclonal treatment from Regeneron, which ultimately began to reverse her conditions, and she is now better. She no longer has COVID. Her and her husband both now are COVID negative, and the symptoms of viral pneumonia are being remedied by virtue of the prescription she was provided by a family practice physician. And that shouldn't happen. But I feel like it goes back to the idea that the protocol is being driven by bureaucrats and by a prescription, no pun intended, from folks at the national or state agency level. And in reality, the doctor should be able to make that decision on his or her own and what's best for that patient in that moment. And I believe here in South Carolina, we've had debates even in the last session about expanding right to try legislation, about giving doctors freedom to make decisions. And I believe we need to continue to push for that because in addition, another family I represent, and this will be the last story of this, lost two family members back to back. One was a 36-year-old former high school classmate of mine, and one was his father. So a mother lost her son and her husband in 2 weeks. The dad they were begging for them to try anything other than just putting him on a ventilator. No one would hear those cries, even though the family said, we'll sign a medical waiver. We'll get a lawyer to sign a waiver. Just give us something, an alternative. Give us ivermectin or hydroxychloroquine or anything you can try because he's going to die anyways. Nobody would hear of it, and he was put on a ventilator, and he is now deceased. Ladies and gentlemen, I respect our frontline doctors. I respect our clinicians who are doing the best they can under difficult circumstances. But I think it is incumbent upon us to ensure that they are given the ability to try what's necessary in circumstances, not just be prescribed a course of treatment by the CDC or even just by DHEC. And I also believe, at least in my neck of the woods, and Mr. Chairman, I'm sure you've experienced this also, the most effective treatment we've seen with folks, even who have been vaccinated, and I'm not one of these folks out there advocating against the vaccine, I've personally taken it, but that can't be the only solution. And even folks I know who've been vaccinated have gotten sick, and the only thing that's reversed their symptoms has been the monoclonal antibody treatment, otherwise known as Regeneron, at least in our neck of the woods. And Florida's had to go around DHHS to go direct to the manufacturer to get supplies of that. I understand we have the similar choke point here in South Carolina. And I certainly hope we'll look at not only expanding the right of doctors to do what they need to do for their patients, to pull back the bureaucratic layers, but also to improve access to those life-saving treatments that are being bottlenecked out of Washington. So I appreciate your work. I appreciate the work of this committee, and thanks for the chance to address you today.
Thank you, Senator Kimbrell. There's going to be a question for you, if you'll stay there. Okay. I did want to recognize, I mentioned Senator McLeod earlier, but she is with us virtually. So, Senator McLeod, thank you, along with Senator Kempson, once again, for being with us. Senator Davis, you have a question?
I do. An observation more than a question, but Senator Kimbrell, I appreciate the way you frame this issue. Absent from your presentation was any discussion of the relative merits between vaccines and therapeutics, and more toward empowering doctors, empowering patients, and recognizing that we're in a fluid situation where medical norms may change, as we've seen it change in regard to Regeneron. I mean, it wasn't so long ago that it was being discouraged or discredited, and now we have the federal government rationing it because it's in such demand. So I think you're exactly right that we go down rabbit holes when we start to try to pit therapies against each other, against the vaccine, and I think we're on the better track when we talk about the physician-patient relationship and empowering physicians and empowering patients to an extent that they may not be empowered right now. There may be institutional pressures, whether it comes from a DHEC or the CDC or insurance companies or any number of institutions may exhibit pressures or biases that take away from what I consider to be the primacy of that relationship. Is that what you're getting at here? Is that recognizing that the fundamental building block upon which public health ought to be founded is between the doctor and that patient? And I've made this case in the past in regard to medical marijuana. I mean, you've got the FDA, you've got various federal agencies that, say you can't use it. You got the South Carolina Medical Association saying you can't use it. And the argument that I've made, and I think it's the argument you're making, is that institutions ought not trump that individual relationship between a physician and a patient. Is that a fair characterization of what you're saying?
Senator Davis, that's a perfect characterization of what I'm saying. And to your point, this notion of institutions trumping the primacy of that doctor-patient relationship is exactly the problem. I have many constituents. This is probably the number one issue I'm getting phone calls and emails about in my office. That's probably true for you and many members of this body. And a lot of my constituents back home are no longer going to the hospital. They won't go to the network because they're afraid that their voice won't be heard and what they are asking for in dire circumstances will be ignored. And that's even to the example I gave of the young lady who chose not to be admitted and was sent home without a prescription, and then we had to send her to another primary care doctor out of network just to get a prescription for antibiotics. That shouldn't happen. I think that's exactly to your point. The doctor-patient relationship is primary and should be prioritized in this medical crisis.
I thank you for that, Senator Campbell. I appreciate you bringing it this way. Senator from Orangeburg, Senator Hutto, and then I believe I hear Senator Kempson. We'll come to you next, Senator Kempson.
Thank you. Senator, I was listening and I think heard the outcomes, but where was it that the doctor was not allowed to do what the doctor wanted to do?
Well, I can't say what I don't know what the doctor's decision was, so I don't want to sit here and say that the doctor wasn't allowed to do what he or she wanted to do. I'm saying what the patient was not allowed to do.
I know, but what you're advocating is that the doctors be able to prescribe and do what they think is in their patient's best interest, but I didn't hear in your story where that didn't happen.
Well, I've had numerous doctors make that claim to me and call me about it. I'm not going to divulge their names or the facility for which they work right now out of fear of retribution. They were intentional in saying, please don't use my name. But there's a large number of doctors with whom I've spoken back home who've had that concern.
Okay.
Senator from Orangeburg, if I can also segue on that, because I'm also represent Spartanburg County. I've had a couple of doctors reach out to me as well, stating that they have been warned if they speak to us or speak out that there's going to be consequences. So I can't. I mean, I know that seems weird, but
aren't doctors like among the most powerful people in our society? And you telling me that they don't want to speak to us?
Well,
I mean, how are we going to address their problems if they're not going to tell us what the problem is?
They don't mind speaking to us, but they don't want their names shared. I think that's the point he's getting at. But I think you'll see.
Well, my only point to him was it sounded like unfortunate situations that eventually got dealt with, but I didn't hear where the doctor couldn't do what the doctor wanted to do.
Well, Mr. Chairman, may I address that a little more specifically?
Campbell.
So, Senator, one conversation I had yesterday, again, the name will be left out, it had a private independent practice, later became affiliated with the network, was openly told by a member of their staff that DHEC had flagged them for prescribing medications they didn't think should be part of the typical regimen for treating COVID, was concerned about the potential loss of their practice relationship, having their contract suspended for making decisions on a case-by-case basis that may not agree with the orthodoxy prescribed by the agency, and was even concerned about the status of their medical license. That was a conversation I literally had last evening.
Thank you. Senator Kempson from Charleston.
Yeah, first of all, Mr. Chairman, let me thank you and applaud you for convening the Medical Affairs Subcommittee, and to Chairman Verdin as well. I think it's very important that we hear some responses to these questions from the hospital CEOs and the doctors. So I'm not going to take much time. I just did have one question for the senator. Were in any of those cases you mentioned, were any of those constituents you represent, were they vaccinated?
Yes.
So these were vaccinated individuals who had to check into the hospital because they later contracted COVID.
Not in every case, but in several instances, yes. And they still contracted the Delta variant and still had significant symptoms.
I'm talking about the cases you mentioned today.
Yes, one
The
was
three
and one was
cases.
not.
Okay, all right. Thank you.
Thank you.
Thank you, Mr.
Senator
Chairman.
Kimball, I appreciate it. Next up is going to be Dr. Annie Andrews from MUSC. Doctor, thank you for being with us today.
So good morning. My name is Dr. Annie Andrews. I'm here on my own behalf today. I'm not representing MUSC. I am an associate professor of pediatrics. I have a bachelor's degree in pre-medicine. I completed 4 years of medical school at the University of Cincinnati. I completed 3 years of pediatric residency at Cincinnati Children's Hospital. I then came to MUSC where I completed 2 years of additional fellowship training in academic pediatrics. I got my master's degree in clinical research. And that means that I spent 2 additional years learning how to design, run, and interpret clinical research. I am board certified in both pediatrics and pediatric hospital medicine. I've been caring for hospitalized children in the Low Country since 2009. I'm also a clinical researcher. I've published over 45 peer-reviewed papers, and I'm the deputy editor of the Journal of Hospital Medicine. I hold an elected national leadership position in the Academic Pediatric Association. In the community, I'm an active member of the South Carolina chapter of the American Academy of Pediatrics, the Charleston County Medical Society. I serve on the Charleston County Medical Society School Health Committee, and I'm an appointed member of Mayor Tecklenburg's Health and Wellness Committee for the City of Charleston. But perhaps my most important qualification to be here speaking with you all today is that I've been practicing medicine in South Carolina since 2009, and I have been on the front lines of this pandemic. Also, personally, my children attend public school in the Charleston County School District. I have no disclosures today. I'm only paid by my employer to do that work that I do, and no one limits or restricts how I take care of my patients. It has been an honor to serve the state of South Carolina in my capacity as a pediatrician for the past 12 years. I have the privilege of caring for children and their families during some of the scariest moments of their lives. Particularly during the pandemic, I was pleased to be able to serve my community as a medical doctor. As a pediatrician who cares for hospitalized children, I am an expert. Community pediatricians rely on my expertise to care for their patients when they are sick enough to require hospitalizations. Surgeons rely on my expertise to care for patients in the postoperative period. However, one of my most important skills that I use every day when I practice medicine is to understand the limits of my own expertise, when I need to call someone with the knowledge, experience, and expertise beyond my own, so that I can provide my patients with the absolute best care possible. Fortunately for me and for everyone in this room, I practice in an area where I have access to such expertise. Pediatric critical care physicians, pediatric infectious disease physicians, pulmonologists, cardiologists, etc. We are all very fortunate to have access to these expertise in our own communities that we need to navigate this pandemic. So understanding the limit of your own expertise and how to recognize expertise in others is a basic and necessary skill for any leader. When considering clinical decisions like how to treat COVID, it is imperative that we rely on expertise and data and not get distracted by anecdotes or online theories. Any implication that the state's healthcare community has been withholding treatments or is motivated in any way to do anything less than provide the best evidence-based care to each and every one of our patients is frankly an insult to our profession and threatens public trust in the work that we do. The goal of these hearings, of course, is to discuss COVID treatment, but as a pediatrician, I would like to stress that many of these treatment options are not available to children, and for children, prevention is much superior to treatment. We must not abandon the basic principles of infection prevention, which includes hand washing, physical distancing, masking, particularly in the schools, and vaccination for all who are eligible. All of these prevention strategies are supported by strong evidence, and we have so much work yet to do in South Carolina to get our vaccination rates up, particularly among youth aged 12 to 17 and all eligible adults. This is the best way to get back to normal, the best way to keep our children in school, which is the goal that we all share, and the best way to avoid preventable death among South Carolina's adults and children. In my role in the Charleston County School Health Committee, I've watched up close the incredible dedication that school nursing, local pediatricians, and DHEC have put into keeping our children as safe as possible. This work may continue to be undermined if children are not protected in the classroom with masking. Children will continue to get unnecessarily sick, requiring trips to the emergency departments, hospitalizations, and ICU stays. Children will be quarantined and isolated and will miss out on in-class learning. The injection of politics into the pandemic response, as was just mentioned, has been detrimental to the health of too many South Carolinians. So I urge you to separate issues related to politics from the expert advice you're going to receive today. Let's shift our focus back to doing everything in our power to stop the spread of COVID. Thank you.
Thank you. Dr. Andrews, I have a question for you. My question is, if a doctor prescribes one of those therapeutics that has been mentioned here in this committee, should that professional decision be able to be made without interruption?
So I can speak to my own experience, which is that I'm prescribing things that have been recommended by the evidence and things that are evidence-based. And so it has never been my experience as a physician that some treatment that I deem necessary for a patient, that I am not allowed to prescribe that in any way. There has never been that sort of interference in my practice.
But you wouldn't want that for any other physician in another area, say Orangeburg or Spartanburg, if in their expertise they recommended one of the therapeutics that have been mentioned here, you wouldn't begrudge that doctor for using their expertise to recommend that.
So I'm not going to speak about hypotheticals and begrudging specific physicians, but I will say that, as I mentioned in my background, I'm very proud to practice evidence-based medicine, and I let the evidence guide the decisions I make. And if that's what the physicians are doing and they're using the evidence to inform their clinical decisions, then yes, it should be up to the physician to make those decisions.
Thank you, ma'am. And Senator from Colleton.
Thank you, Dr. Andrews, for being here. I heard you talk about the schools, and that's when my ear especially perked up. Have you heard the complaints of some of the it's hard for me to concentrate with the conversation. I'm sorry.
Senator from Colleton, I think we've had a technical difficulty with one of the members, and they're trying to talk to him on the phone, so
That's why I was wondering if I needed to stop.
I'm sorry about that. We can. Go ahead, Senator from Colleton.
And I think it's very important, so I apologize for stopping. I have received numerous calls from and concerns from pediatrics offices after we started the school year, because the number one complaint I'm hearing is that many of those pediatricians are concerned that they aren't able to provide the necessary care to their patients that may have heart conditions or very serious other conditions because of the backlog caused in their office when someone in the school, when the school nurse calls and says a child has tested positive. And so then the entire class basically quarantines, or either they rush into the pediatrician's office just to get tested, to make sure, and which is the normal thing that any parent would do if their child's been out playing. And so the complaint I'm getting from those offices is that they would like to figure out a way to provide the testing outside of their local offices. Is there anything that the State Medical Association is doing in collaboration with DHEC, where they could say, like for instance, at Whale Branch in elementary in Beaufort, we had the problem where a lot of students couldn't go to school in middle school and elementary, and the parents, there aren't many local pediatrics offices in Beaufort, so they basically went to those offices, and the offices shut down. So do you see a need for us to collaborate with DHEC to help these school nurses, to help these local doctors' offices to provide testing to determine if a child has COVID?
Yes, and I'll always support helping school nurses do their job. And there's lots of experts in the room today who can talk to you more about plans for accessible testing, but I couldn't agree more. We need readily accessible testing. Fortunately, where I live in the Charleston area, I've had to get my school-age children tested many times, and I have had easy access to testing outside of our pediatrician's office through the MUSC system, where I can schedule it online, drive up, and get tested. Because I am very worried about my colleagues throughout the state who are in private practices who are being overrun. I've never been more worried about my colleagues in private practices, my partners and colleagues in intensive care units, because we've never seen this level of one disease affecting so many children at the same time. And so yes, offices are getting overrun, and children who have been exposed to the virus who don't otherwise need medical attention should be able, and in many parts of the state are able, to get tested outside of their doctor's office. And that is the model, in my opinion, that we should be striving for.
Do you think there's anything, because this committee, from what I understand from our chair, we're looking for other options. Do you think this committee should be looking at options whereby when a school has an outbreak, where we partner with MUSC or partner with the DHEC or whatever agency could come to those schools to offer the testing for those students too, so that they'll know whether or not their child has COVID, and thereby making sure that those local offices still have the resources they need, the manpower they need to treat the really, really sick children in their practice.
Yes, I think I agree completely with you. I'll let the representatives from those agencies speak more about this later, but that is what we need to do. We need to unload the burden from the school nurses and the private practice pediatricians in our community who are being completely overrun. But I will also say that if we don't have more masking in schools, there's going to be outbreaks everywhere, and there's not enough manpower in the state to do what you're proposing and go to the school and do the testing because there's just too many outbreaks right now.
And your children go to public schools in Charleston?
Yes.
Do you realize that at the beginning, when we put the proviso in regarding no mask mandates, do you realize that at the beginning of the pandemic, Charleston County put a considerable amount of money into putting in plexiglass protections, especially in those schools?
Yes.
But this summer, after that no mask mandate was implemented, they took up those plexiglass,
Yes.
knowing that there was a Delta variant. Did that happen anywhere else in the state?
I can't answer that, but that happened my son was in kindergarten last year with plexiglass, and that gave me some great sense of comfort. And then when we started this school year with Delta, which I knew he was at greater risk for because of how Delta is affecting children, there was no plexiglass in sight.
And then they
Senator
basically.
McCollum, can I add one thing there? I'm gonna bring my engineering mind in here. I had a lot of conversation with our school district who had the plexiglass. They worked with engineers and HVAC folks. They've got all these systems in place that filter the air, and the plexiglass was actually preventing the airflow from cleaning the room. So the plexiglass was actually becoming counterproductive, and that's why those schools took that plexiglass out. I'm not trying to be argumentative. I was confused at first why they're taking it out, but that's exactly why they took it out, because the schools were telling me that their experts with the filtration systems were telling us that the plexiglass was preventing that system from operating correctly.
Well,
So I wanted to let
Mr.
everybody know that.
Mr. Chair, I'm not an engineer, but I am married to an HVAC, commercial HVAC technician, and he was one of the ones removing for Charleston County a lot of this. The answer would have been especially in these elementary schools where students aren't good with keeping on masks, the answer would have simply been to lower the plexiglass to the height of the child. But no, they took out all of those plexiglass separators that cost a lot of money and sent them to somewhere to be refurbished to use and sold elsewhere outside of the state of South Carolina. To me, that made no sense whatsoever. Just throw it away. Makes no sense. And then we say we're going to leave it to everyone else on whether or not you wear a mask. And then the hospitals, and then the local doctor's offices get overrun. That was a concern of mine.
Yes, ma'am. Senator Corbin has a question.
Thank you, Mr. Chairman. Thank you, Doctor, for being here and for all you're doing for your patients and for South Carolina. You stated earlier that you pretty much stick to evidence-based medical treatment when treating your patients. I'm going to give you a hypothetical situation. If somebody comes in to see you, are you strictly pediatrics?
Yes.
Okay. If a patient comes in to see you and they test, let's just say their symptoms are chest pain, hard to breathe, feeling poorly, maybe some flu-like symptoms, and then they test positive for COVID, what sort of evidence-based medical treatment do you do at that point?
So I work in the hospital setting, so I would be caring for that child in the hospital. And what we're able to offer them is supportive care primarily, which includes supplemental oxygen, being placed on monitors, IV fluids to help with dehydration. And in some patients, we're able to give them remdesivir, which is an antiviral medication which treats COVID.
Okay, so you are, we're pretty well sure that COVID, the virus, is causing the symptoms. So you're treating the symptoms, but you're not treating the virus.
Remdesivir is a treatment for COVID.
Is that the only treatment that you all offer?
Right now, for the patients that I care for, which is not in the critical care setting, but in the hospital setting, that and sometimes steroids.
Okay. What about like azithromycin, things like that?
So that was used early on in some of the patients at my institution, but as the evidence came out that did not support the efficacy of that medication in treating COVID in children, right now we are no longer using that.
Okay. I have two studies in front of me, and for full disclosure, I didn't get them till late last night in the mail, but this is supposedly a peer-reviewed study from the American Journal of Therapeutics about the efficacy of ivermectin. Have you read anything in regards to ivermectin to treat COVID?
I've read a lot about it, yes.
Okay. According to this, the conclusion says the meta-analysis based on 18 randomized controlled treatment trials of ivermectin in COVID-19 have found large statistically significant reductions in mortality, time to clinical recovery, and time to viral clearance. Furthermore, the results from numerous controlled prophylaxis trials report significant reduced risk of contracting COVID with the regular use of ivermectin. If you, and I'll be glad to give you a copy of this, I mean, I'm sure it's out there. So if you read this study, would you feel comfortable possibly using that against the virus?
Are there children included in that study?
Well, that's what I said. I'm not sure.
Yes,
because
so I
just got
believe
this
the
late
one you're
last
looking
night.
at, there's no data on children in the meta-analysis you're looking at. And the two meta-analyses that I have seen that have been published on ivermectin, there is a lot of concern for bias in the studies that contributed to the meta-analysis. So meta-analysis is when you combine data from multiple different studies, and the authors of the meta-analysis assess the level of potential bias in the studies that are in the meta-analysis. And there are significant concerns about the studies that are in that meta-analysis, including bias, and also there are no children in those studies, so unfortunately that cannot inform my practice.
Right, and like I said, I don't know if there were children involved in this one or not. I just got it late last night. I didn't have time to read through it, so I was just going off the cover page here. But my problem is, what I'm finding from patients and the people I serve is, when they contract COVID and they're getting sick and they go see the doctor or go to the hospital, whatever, they're not getting any treatment for the disease, what's making them sick. Maybe they're getting some treatment for the symptoms, but a lot of them are being told to go home and isolate and call us if you get, in dire straits. And if we have medications out here that are working or seem to be working, I think it's absolutely horrible that we're not trying them.
I'll just comment that any implication that any of us would do anything to withhold effective treatments from our patients is really insulting to our profession. And, I've spent decades of my life learning how to care for hospitalized children. I am at the bedside every day, and I see them take turns in the good direction and the bad direction, and it is heartbreaking to look at a parent in the eyes and tell them that their child is going to have to be transferred to the ICU. So any implication that I would withhold a treatment that I would feel to be effective for that child, I just have a hard time accepting that.
Well, I didn't do any implications towards you. I'm talking about the industry as a whole, because
Right.
that's what I'm hearing from my
Sure.
constituents. That was the protocol for what happened to my wife. My wife contracted COVID, ended up in the hospital, basically got a bolus of fluid for dehydration, went back home, ended up with a pacemaker. Nothing to help treat COVID, nothing to help treat the underlying disease that was causing the other issues.
I'm sorry
So
to hear
I
that.
appreciate that, but that's why I have a passion about this topic. But
And I think there's a lot of other experts in the room who are probably very anxious to answer these questions as well, so I don't want to take up all the time.
I appreciate it. Thank you for being here. Thank you for what you're doing.
Yes, thank
Thank
you.
you. Senator Davis has a question, then Senator Verdon.
Yeah. Thank you, Dr. Andrews, for being here. And I completely agree with what you said in your statement, that we need to get politics out of this. We need to put physicians and evidence-based therapies at front and center. So I appreciate you stating that. Is it in terms of COVID and in terms of the therapies and in terms of what we've learned, a lot of this, kind of has been on the fly, hasn't it? I can remember last year, we were sanitizing surfaces and we really weren't worried about airborne, and then we learned more about it. So as we moved along, I mean, we've learned about this virus. I want to direct your attention to monoclonal therapies or therapeutics. Is it fair to say that the medical consensus regarding the efficacy of that particular therapeutic has changed over time as more evidence-based cases have come to doctors' attention or physicians' attention or the medical community's attention? Is it fair to say that there's been a shift in opinion over time in regard to that particular therapeutic?
So I would just say that, number one, I'm a pediatrician, that therapy is not approved for the patients that I treat, and there are other people in the
Okay.
room who are far more
Okay.
equipped to answer that question, but science does evolve. This was a novel virus, and we were working with the best evidence we had at every stage and trying to do our best to combat this pandemic.
I just say, and maybe, do you think I'm correct when I say, and I'm a layperson, I'm an attorney and trying to learn about these things, and certainly don't have the expertise that you do. But from what I read and what I perceive is that over time, in regard to Regeneron, for instance, there's been a shift in a medical consensus in that regard, in that a few months ago, it really wasn't, focused on or talked about or recommended as much as now, where you've got, I think, the federal government recognizing that there is significant demand for it and significant evidence of efficacy, so that they're now trying to ration it out in ways that are equitable. So am I right in thinking that as we learn more about this virus and we learn more about how patients respond to therapeutics, that sort of there's been a shift of opinion of sorts in regard to Regeneron or a monoclonal therapy?
I mean, again, I think I'll defer that to other folks,
Okay.
but data and science evolves over time. That is
Okay.
the nature of science, yes.
Okay, thank you. I
Mr.
appreciate
Chairman.
that, Doctor.
Thank you. And Senator Verdon has a question.
Thank you, Mr.
Then I'll
Chairman.
get to you, Senator Kempson.
Thank you for being here, Dr. Andrews. I want to get a little bit of a feel for how your practice, how you blend your time. So academia is a component of your profession, I believe, and then not emergency medicine.
Hospital medicine,
Hospital
pediatric
medicine.
hospital medicine, yes.
How about in clinical setting, any component there? So
No, I'm a hospital-based pediatrician.
hospital-based, okay. I'm interested in what's going on in the hospital, but you're not speaking for the hospital. I'll let others give the data. But maybe you can share with us the caseload that you're serving on a, say, average daily basis or weekly.
So I would say the best way to
In that hospital
right.
setting,
So the best
but
way
not
to
critical.
summarize what we've seen on the regular units of the hospital where I work. At the beginning of this pandemic, I did not care for anyone with COVID because there were so few children with COVID that they were isolated to the intensive care unit just as a way to keep them all in one place. But when I was seeing patients a few weeks ago, half of the patients on my census on any given day were there for COVID. And so as a pediatric hospital medicine physician, there are 3 of us who are seeing patients on these 2 units at any given day. And yesterday I saw 12 patients and then met a few new admissions in the afternoon.
Okay, thank you. Thank you, Mr. Chairman.
Thank you. Senator Kempson?
Mr. Chairman, all I was going to simply say is that we got a lot of experts on here, and many have to get back to the hospital. So, Annie testified as a pediatrician, but you got people that can answer these questions. She did a great job, by the way, but you got a lot of people who are treating adults who can answer some of these questions. So,
Yeah,
just
I
keep
agree,
that in
Senator,
mind.
but I didn't want a member not to be heard, so
And now he want to run the show.
thank you. Senator Scott?
Yeah, thank you so much for you coming and sharing. In moving forward, to avoid the kind of conflict that we've been able to see, especially with young children in school, mask requiring, no, not mask requiring, that there's a more proactive role that the pediatrics community along with the educators take as we move forward in making these type of decisions, whether it's permanent law or just a proviso. It is important that we get your input. We know that you have representatives here before this General Assembly, but in order to avoid what we're going through, especially with these young children, and because there was not a proactive role, and I can't point fingers at anybody, nobody knew that the Delta would be the way it is. But I'm just asking a more proactive involvement, and so that we can get this under control. We're a long way out from solving this problem. And we're going to have to begin at the conclusion of hearing from all of those in the medical community, have to begin to listen to what y'all are saying. We recognize there is difference of opinion in the medical community, and that's an issue that y'all going to have to work through. But we're dependent on y'all to point us in the right direction. This mask or no mask requirement should have never been at the forefront. And now we're coming behind trying to fix a problem. So I would hope that in moving forward, we can see the medical community really help us get through some of this.
Yes, and I think we're eager to do so.
Thank you.
Thank you, and thank you for your time
Yeah.
and being here today.
Thank you.
Next up, we've got Gene. Who do we have on the phone?
Mr. Chairman, we'll attempt to call Dr. Pierre Corey. Let me apologize to the committee. This will be a little noisy, but we will not lose any of our virtual participants.
Thank you.
Okay. Dial 9 to get out there, right? Okay, we got an old number in there. Do that. Okay. Okay.
I don't think he's available.
We have another number, Senator.
Hello, Dr. Corey.
Dr. Corey, this is Gene Hogan with South Carolina Senate Medical Affairs.
Hi.
Hi, our committee is ready for you, sir.
Okay, I have a lecture I'm giving in Hungary in 15 minutes.
Yes,
so
sir.
I'm not sure what you'd like me to do on the phone. Do you want me to answer questions? Do you want me to, I mean, I had a talk prepared, but somehow the telecoms just didn't work.
Just go ahead and speak, sir.
Okay, so I think you wanted to hear me speak about early outpatient treatment for COVID-19.
Yes, sir.
Is that correct? Okay. So then I'll just hit the high points. What I'll say is that there is at least 15 different compounds that have been found to be effective in treating COVID-19. It's probably one of the greatest lessons I've learned in my medical career, which is having been taught for decades that we don't really have a specific therapy for a viral syndrome outside of Tamiflu for the flu. In the pandemic, many researchers and clinicians around the world have discovered a number of molecules that have worked. The most profound impacts have been demonstrated around ivermectin. The evidence base for ivermectin is massive. It has now 64 controlled trials. 32 of them are randomized controlled trials. There's at least 15 double-blind randomized controlled trials. And unfortunately, the thing about ivermectin is that it's surrounded in controversy, but that's because it's surrounded by corruption. And I'm just going to speak plainly. I've had a front row seat to this corruption. It is one of the most highly effective drugs in COVID. In fact, I call it the penicillin of COVID. As it's not what you would believe if you listen to just about anything that's out there. Those of us who know it and have used it know how effective it is. There are dozens of countries around the world who have used it to great effect. And in fact, something that should be front page news all around the world, and it's not, but the Indian state of Uttar Pradesh in the last 2 weeks, there have been numerous newspaper articles in Indian major newspapers. The state of Uttar Pradesh has 241 million people in it, and they have eradicated COVID. And they did that with a massive public health program centered around the use of ivermectin. Now, they did very close surveillance. They used 70,000 health workers who went to all the positive tests. And what they did over the last year is they learned to prophylax all healthcare workers with ivermectin. They used it in early treatment of all mild to moderate cases. So as soon as there was a positive test, they treated everyone with ivermectin. And they gave ivermectin to all household members. And by doing that, and I could share with you all of the newspaper articles and all of the interviews with all the health minister officials, but they've eradicated COVID. They have 33 districts out of 67 that have not had one case. Their last 186,000 tests, they've had 21 positive tests, which is effectively zero. It's a 0.01% test positivity rate. And it is one of the most, I think, one of the greatest historic healthcare or public health achievements in history, and you don't hear about it. So that's all I'm going to say about the corruption around ivermectin. I could spend an hour showing you numerous health ministry programs that have been reported from various places around the world, including Mexico City and several states in Argentina that have very carefully utilized it. But I think Uttar Pradesh is the best example. And then beyond that, we have a number of other molecules that have also been shown to be quite helpful. And, you know, we have a protocol. In fact, we've had a challenge coming up with protocols because there's so many effective medicines of different mechanisms, and you can't treat someone with 17 medicines, nor is it necessary. And so we've boiled ours down to what we think are the most complementary, synergistic, and potent. And so some other things that are on our protocol, which I think it's important for people to know, because there's really a blockade on ivermectin right now, which is pretty ferocious to see what's happening to it. It's been nothing short of absolutely disgusting and distressing to see what really is a humanitarian crisis unfolding around this corruption. There's at least 500,000 lives that have been lost through the suppression of early treatment. But what's important, some studies have come out is just simple nasal oral pharyngeal sanitization, like with Viricidal, which is mouthwashes that kill the virus. Because all the viral burden, especially early on in the first days, it's all in the nose, nasal pharynx, and oral pharynx. And so if you use something like povidone iodine that's diluted, and you do nasal drops 4 to 5 times a day, along with mouthwashes, you can actually eradicate the virus and decrease the viral burden to minimal, and like almost no one goes to the hospital. The trials around that, there's at least 5 trials, really profound reductions in need for hospitalization, with something as simple as that. And so it's been a really exciting and really sort of eye-opening journey, learning about all the therapeutics. Because the last thing I'll say is, that's really all we've done. So myself and my colleagues, from the first day before the first case hit the United States, that's all we did is start reading. Reading and reading and reading, sharing articles, learning everything we could, talk to doctors around the world. We've been doing that since March of 2020. We have a huge global network of frontline clinicians and researchers. And, we've developed some of the most effective treatment protocols in COVID. But, our expertise and our insights have been suppressed throughout society. And history will not be kind. And I think I'll just stop there.
Thank you, Dr. Corey. I appreciate you being here today. So do you see any reason why, would there be valid reasons for doctors to prescribe this medicine that you mentioned, the ivermectin?
Valid reasons. There's 26,000 patients in 60 controlled trials. There's health ministries that have been eradicating the disease with ivermectin. Valid reasons. In fact, to not use it is I would say, would be really, it's not malpractice because so many doctors are ignorant of its efficacy, because I think so many doctors are being led to believe that it doesn't work. There's a lot of disinformation out there, and it's sad.
Well, Dr. Corey,
valid.
Dr. Corey, what do you think would be the reasoning that would cause some doctors not, even if they believed in this, what would their reasoning be for not prescribing it to patients?
Well, at this point, let's go back to the first point. If they believed in, I don't like the word believe, if they understood its efficacy and really delved deep into the trials and saw how efficacious it was, there would be no reason for them to not use it. In fact, they would have to. It's one of the safest medicines known in history. It's safer than an aspirin, a Tylenol. You can take huge amounts of it without getting sick. It's extremely safe, very cheap. There'd be no valid reason to not use it. Right now, is there a reason to not use it? Well, I'm sorry to be so cynical, but what you've seen in the last 3 weeks is an all-out war on the public health by pharma, and I call it Pharmageddon. You've seen this concerted and action against ivermectin, and you've seen lies conflating it with horse paste. It is a human drug that the discoverers won a Nobel Prize for eradicating 2 globally endemic diseases. And one of the greatest public health achievements in history was the eradication of 2 disfiguring parasitic diseases. And so it's a human drug; it's not a horse drug. But the CDC and the Departments of Health telling everyone that there's no evidence to use it, and Dr. Fauci going on national television last week and CNN, he says he said it was ineffective. There is no evidence to show it works, and that is an absurd and easily disprovable lie. I could bring you a stack of 60 papers.
And Dr. Corey, one of my neighbors is still with us because of it. Talked to her yesterday, but I know time is of essence. I'm going to yield to Senator Corbin for a question, then Senator Bright Matthews, and then Senator Hutto.
Thank you, Mr. Chairman. I think my question was answered. I just want to know a little bit about its safety, and I had heard that it was as safe or safer than a Tylenol. And so Now you validate. That's all. Thank you.
Yeah, just one thing on that. It's been distributed across continents to children, elderly, everybody, all sorts of comorbidities for 4 decades. 4 billion doses have been distributed. And so if there was any safety signal or lack of one, we would know it. It's not toxic to the liver, the lungs, the kidneys. It has an incredible safety profile.
Thank you, Doctor. I know you're short on time. Senator Bright Matthews and then Senator Hutto.
Dr. Corey, thank you for offering your testimony. Do you practice in a hospital or in a private setting?
So I'm a pulmonary and critical care specialist. So I'm a lung and ICU specialist. I've practiced in both throughout my career. Right now, I'm only doing hospital work. I run an ICU and a pulmonary service in a hospital 2 weeks a month.
In what state?
In Wisconsin.
And What is the positivity rate in Wisconsin presently?
You know, I haven't kept up, but in general, the positivity rates that I see where there's surge, I mean, it's 5 and 10%.
Okay. And currently, I just looked at your curriculum vitae. It looks like you're the president of the Frontline COVID Critical Care Alliance.
Yes.
And when did you begin that alliance?
So that's a nonprofit organization that we did what we were doing before we formally established nonprofit. I think our nonprofit status was established in August or September of last year.
And you started out by saying that you were asked to be here. Who reached out to you to ask you to be here?
I haven't kept, that I didn't keep track of. I'll have to ask my assistants.
And what do you think South Carolina can do to increase the availability of this, the alternative treatment that you've referred to in ivermectin? Because I think I heard you say that it is not readily available as it used to be.
Well, no, there's plenty of supply. It's just that there's blockades, right? So there are doctors getting investigated by state departments of health for prescribing it. There are pharmacists who are refusing to prescribe it because they've been told not to.
Is that in South Carolina? I'm sorry about that.
That's everywhere.
Okay.
It's everywhere.
Okay.
And so there's a lot of, they're injecting fear and controversy around that drug, one of the safest in history.
Okay.
And one of the cheapest.
And so it's your position with your alliance that you'd like to educate people about the efficacy of ivermectin?
Absolutely. So when I was the chief of the critical care service at the University of Wisconsin early on in the pandemic, the Department of Health would have weekly updates and lectures, and I would lecture last year for the state on different things that we were learning about the disease and therapeutics. And I think those are effective. You know, a lot of the doctors tune into those, and I think that's a really impactful way of disseminating knowledge and guiding treatment.
Thank you, Doctor.
Senator from Orangeburg, Senator Hutto.
Thank you, Doctor, for being here. I know your time is short, but you at the hospital you work at in Wisconsin, y'all actively prescribe ivermectin now?
So I have been for quite a while until last week when the hospital shut it down. They no longer have it on the formulary or allow it to be filled.
All right. So what percentage of the patients were using ivermectin before that?
Oh, I use it on every patient with COVID. In the hospital alone, it generally, hospital disease is much more involved, and we use combinations of therapies. The outpatients, though, well, I don't know, 100 to 200 at least, outpatients that I've treated with ivermectin. Generally, you can get away with that, especially if you treat it early. In the first couple of days, they get better quickly. If it's later or they're sicker or older or comorbidities, generally need more components of our protocol.
All right, so you're saying that the hospital that you work at no longer prescribes it?
As of last week, after the Pharmageddon that was unleashed, yeah, they've shut it down. And I will tell you, many hospital systems across the country had already shut it down months ago.
All right. What about you? Just you prescribing it? Do you prescribe it still?
I can prescribe it as an outpatient. I can no longer. So I have I have a large network of people who reach out to me for care, and so I do sort of telehealth with them. I don't charge a dime, by the way. I've just been helping people. That's not how I make money. I make money when I'm in the hospital, but in the hospital I can't prescribe it. Outpatients I can. It's just getting harder because many pharmacies are refusing to fill, many pharmacists are refusing to fill, and it's becoming really burdensome, laborious, and it's leading to delays in therapy. And it's one of the saddest things. And now people are dying because they don't have access to a life-saving drug.
All right, I'm just trying to understand, though, but as far as your ability as a doctor to prescribe it, you have that ability now?
Yes, it's an FDA-approved drug that we're using off-label. 20% of all medicines in the country are prescribed off-label. Off-label use is legal, it's appropriate, and there's no restrictions on it.
Okay.
At least historically.
I think what we were hearing earlier is that somehow doctors were being prevented from doing this, but what you're telling us is that there's, to your knowledge, no restriction on a doctor doing that.
No physical restriction. I mean, there's no legal restriction. However, there are blockades and barriers, and there's fear. I'm sure some doctors have stopped prescribing because they're afraid of getting investigated.
Okay. Thank you.
Thank you. Dr. Corey, I appreciate you being here.
All right. Hopefully that was helpful.
Yes, sir, very helpful, and we got you out right on time.
Okay. Thanks a lot.
Next, who's up next, Gene?
Okay. Bye now.
Dr. McCullough, right?
Yes, Dr. McCullough. Yes.
All right.
Dr. Peter McCullough, he's with us virtually.
Dr. McCullough, are you with us?
Yes, I am. Can you hear me okay?
Yes, I
Can you
hear
hear
you. I
me
don't know,
okay?
do we control his volume or does he control it? You might need to turn your volume up a little bit
Okay.
or speak a little louder. Thank you for being here.
Okay, I'll speak louder just to help us get through. I'm also on a tight timeline, and I'm Dr. Peter McCullough. I'm an internist and cardiologist in dialysis. I maintain my boards in both of those specialties. I am in a practice. I see patients every day, but I'm also academically very involved. I edit 2 major journals. I'm the president of the Cardiorenal Society of America. I've spent the last year and a half focusing on COVID-19. You've heard about publications from one of the speakers. I have over 45 publications in COVID-19 itself and over 650 publications overall in the National Library of Medicine. To my knowledge, that's the academics of anybody who's opined on COVID-19 anywhere in the world. I'm here to tell you that I've always treated all of my high-risk patients as outpatients with early multi-drug therapy designed to reduce hospitalization and death. I've published the 2 seminal papers teaching doctors how to do that in the American Journal of Medicine in August of 2020 and Reviews in Cardiovascular Medicine in December of 2020. It's those protocols that are the basis for the Association of American Physicians and Surgeons Home Treatment Guide, and in concept, it supports what Dr. Corey mentioned with the FLCC Math Plus and IMath protocols. What we've learned is that COVID-19 is responsive to therapy if we address viral replication, inflammation, and thrombosis or blood clotting in high-risk adults. That means about 25% of adults should receive high-risk therapy, in my view, supported by these organizations. And that involves, in the highest risk patients, monoclonal antibodies, Regeneron monoclonal antibodies that are pre-purchased and should be made available to your residents of South Carolina. This weekend alone, while on a family trip, by phone, I had 4 of my patients who were in their 70s with heart and lung disease presented with COVID-19. They were treated with monoclonal antibodies within the first day or 2, supported by randomized trials and observational studies. And it allowed me to sequence other drugs that were very easily managed. We used prednisone, aspirin, and in some cases we used blood thinners called Lovenox, and we were able to keep people out of the hospital and without having complications. I've managed people up to in the 90s to prevent hospitalization and death. To my knowledge, the only patients being hospitalized in your state and any other state are those who do not receive early ambulatory treatment or they receive inadequate treatment before the hospital. No 2 doctors agree on anything, just like no 2 lawyers agree on anything. You heard from one doctor who's an inpatient pediatrician who really doesn't think there's really any drugs that can treat COVID-19 outside of managing the symptoms. Other doctors would strongly disagree. I can tell you in Japan, a first world country, a sick child with COVID-19 would instantly receive ivermectin. That would happen in Bangladesh, in India. It happens, there are home treatment kits passed out in Central America, just south of us here in Texas, that involve combinations of drugs. So in our paper in December of 2020, we listed 30 countries that give out home treatment kits to high-risk individuals. And the sequence multi-drug therapy does involve the use of monoclonal antibodies in the highest risk, but after that, we fall back to hydroxychloroquine, supported by over 250 studies, ivermectin, supported by over 60 studies. We use doxycycline or azithromycin because they cover an overlap syndrome of what's called atypical pneumonias with mycoplasma or chlamydia pneumonia. We use inhaled budesonide, supported by 2 randomized trials. We use oral prednisone or dexamethasone, supported by over a dozen trials and studies. We use colchicine in adults, an anti-inflammatory drug supported by the largest clinical randomized placebo-controlled trial in all of COVID-19, over 4,000 patients, the COL-Corona trial. And then lastly, adults need, in my view, full-dose aspirin based on analyses from multi-center studies, as well as anticoagulation in those who have a low oxygen saturation, and that can be subcutaneous enoxaparin or oral anticoagulants. In total, it's about 4 to 6 drugs to treat COVID-19. No single drug is essential, and no single drug is sufficient. So we know this is a dangerous viral infection. We must use drugs in combination. In my view, we've always looked for a signal of benefit and then acceptable safety and put drugs in combination. This is supported by 4 organizations, including the Association of American Physicians and Surgeons, the Frontline Clinical Care Consortium, you just heard from Dr. Corey, the American Frontline Doctors, and the Truth for Health Foundation. Now, we recognize that the NIH, the CDC, the FDA, the AMA, and the Infectious Disease Society of America actually have no protocols for outpatients. It's a giant gap. And so the 4 organizations I mentioned have filled that gap. And we have basically kept mortalities between 600 and 700,000 in the United States. And the CDC had us scheduled to at 1.7 to 2.1 million Americans lost. And so I feel very strongly that every high-risk American needs to have access, and their doctor should provide for them. If the doctor is unwilling to do that, to provide a referral for that patient in order to receive high-quality care. So those are my comments.
Thank you, sir. Do we have any questions? A senator from Orangeburg, Senator Hutto, has a question.
So all of these different drugs and protocols that you talked about, is anybody preventing you from doing those?
I have personally witnessed what's considered administrative blockades. So if I attempt to have a patient get a monoclonal antibody infusion, I've witnessed really a perverse form of vaccine discrimination. So if a patient had previously had a vaccine and they've had a breakthrough infection, I've seen urgent care centers, and this happened to my pastor who had COVID-19. I sent him specifically for an antibody infusion. He was told if he had the vaccine, he wouldn't get the antibody infusion. He'd actually get remdesivir, and I wanted him to get the antibody infusion. So that's an example. I've seen examples where patients get prescribed hydroxychloroquine or ivermectin, and then the pharmacist doesn't dispense it, and they say they have to call the doctor to clarify the dose. And if they can't get the doctor, if we're busy in the hospital with another patient, they can't get a hold of us, then the pharmacy blocks that prescription to patients. This is happening. I think the South Carolina lawmakers ought to immediately put into place a prohibition on any pharmacist blocking a legally prescribed drug to a patient.
Well, but I didn't hear you say that there was any impediment to you prescribing what you thought was best for your patient.
No, I make the prescription, but I have to ensure the delivery of the drug to the patient. And so I have to catch up with the pharmacist's call and then demand that the pharmacist dispense the drug to the patient.
Right, but that's not unusual. I mean, my wife's a doctor. Many times the pharmacist calls and says, we need to clarify what the dosage is. That's not, I mean, there's nothing unusual about that, is there?
It's unusual that it's targeting these simple drugs that have a standard doses like hydroxychloroquine 200 milligrams twice a day. If I prescribed it for a patient with rheumatoid arthritis, it wouldn't be delayed at all. And I prescribe dozens and dozens of drugs per day. COVID-19 is a illness that is singled out where there's intentional attempts to administrative delay or block dispensing of drugs.
Well, what percentage of your patients that you prescribe drugs for actually get the drugs?
They 100% of them get the drugs, but with tremendous effort.
Okay, so if I understand what you're saying, nobody's impeding your ability to prescribe it, and 100% of your patients are getting it, right?
No, people are impeding the ability for people to get drugs, and that
I didn't ask you
those
that.
impediments.
I didn't ask you that. I said
Yeah, you did.
nobody's
Yeah, you did.
impeding
You said
your
impeding, and I
ability to
said
prescribe
yes.
it.
No, I listened to the question very carefully. People are impeding the delivery of drugs, and those impediments must be overcome.
Is anybody impeding your ability to prescribe the drug?
Yes, as I then answered, pharmacists are impeding my ability to prescribe the drug, and I must overcome those impediments.
All right, that's a filling of the drug, but nobody is telling you you can't write the prescription, right?
No, I have the authority to write prescriptions, and I write them.
And 100% of the prescriptions you've written have been filled?
Yes.
Okay, thank you.
Thank you. Senator Verdon, do you have a question? Thank you, sir. Are you going to remain on, or do you have to leave?
to go.
Thank you for being here, and I
Chairman,
appreciate your
Mr.
testimony.
Chairman.
Oh, hold on, we got one question. Senator from Charleston.
Yeah, I'm just listening to this, doctor. Where do you, I'm sorry, where do you practice medicine?
I'm on staff at Baylor University Medical Center and Baylor Heart and Vascular Hospital in Dallas, Texas, and I'm employed in a private practice.
Okay, and I heard you talk a lot about everything else except vaccines. What's your position on vaccinations?
My position is I don't discriminate if someone is elected to have a vaccine or not have a vaccine. We have data from the CDC, from Havers and colleagues, from the COVID-Net Network, which is representative of the United States, and then separately by Fillmore et al. From the VA, showing through June that 23% of Americans in the hospital with COVID-19 have been vaccinated. So we know that proportion is substantial. We'd expect a vaccine to keep almost everybody out of the hospital, but it's not. And I anticipate those proportions are going to grow in July and August as we get full Delta shading in. We know in Israel, where they have large population vaccinated, that in fact, that same exact proportion, over 80% with COVID-19, have been fully vaccinated or even with boosters. So I've never recommended the vaccine, or I've never not recommended it because it's an elective program. About 70% of my patients in my practice in December, January, and February got the vaccine, but I have been concerned about vaccine safety and lack of efficacy through the late spring and now into the summer and fall.
Yeah, and so in your view, just looking at the data in the hospitals you're associated, and I heard you say Baylor University, you work in the Baylor University Hospital, is that correct?
I'm in a private practice. I'm on staff at Baylor University Medical Center and Baylor Heart and Vascular Hospital, but I do not have access to Baylor's COVID data.
Okay. Well, in your community, you observe the COVID rates in your surrounding community. Wouldn't that be correct? Do you know the percentage positives? Are you aware of the hospitalizations? Any data in your local community you're aware of?
I mean, I can tell you that Senator Bob Hall has held town hall meetings with doctors, both inpatient and outpatient, to get a sense of the degree of vaccine failure that we're seeing of those sick with COVID-19 in the hospital. And that proportion is estimated to be about 40% of COVID-19 patients have been partially or fully vaccinated. And that's true in my practice. I can't prove it, but it's my clinical experience that those who are vaccinated who get COVID-19 are easier to treat than those who are unvaccinated.
Okay, so so in your view, the vaccination, at least with respect to hospitalizations and treatment, it's better to be vaccinated than not to be vaccinated. Is that correct?
That's my professional viewpoint. I can't prove it with the data. The FDA has been very clear on the August 23rd meeting that did not approve Pfizer. That meeting was clear that there was no hospitalization or mortality benefit from the randomized trials of the Pfizer vaccine.
Okay, thank you.
Thank you. Senator Corbin has a question for you, Doctor.
Thank you for being here, Doctor. Someone made a comment to me several weeks ago, and not being a medical professional, I wanted to ask a medical professional who has been immersed in COVID, such as yourself, and done a lot of research. And the comment that was made to me was that they had read some papers where they felt like that the vaccine and those who had been vaccinated may be contributing to these mutations and these new strains. Can you speak to that?
That concept is supported by a paper at Mayo Clinic in Boston. The first author is Neeson and colleagues, with over 1 million patient sequence. We've always had about 12 to 14 different strains in the United States, including Delta, by the way. We've had Delta all the way through, but it's always been 1 or 2%. But what Neeson and colleagues found, and this is supported by a second paper by Acevedo from South America, that once we get to about 25% vaccinated, we allow a dominant strain to come forward because it can easily thrive in the vaccinated population. And that's what's happened with Delta. We went in the United States from 2% Delta to 99% Delta because Delta can be acquired and carried and transmitted by the vaccinated. And our CDC director has told us that in a press briefing about a month ago. A paper by Fahrenholt and colleagues clearly demonstrated that with Delta. And now, alarmingly, a paper by Chow and colleagues from a unit of Oxford in Ho Chi Minh City, Vietnam, has shown that those fully vaccinated can carry the Delta variant at 251 times the viral load of someone with a different variant from the unvaccinated era. So there's a great concern that those who are vaccinated, some actually get sick with COVID and their vaccine failures, but in fact, they may, in the pre-symptomatic phase, spread it to the unvaccinated.
Thank you, doctor, and I'll take that as a yes.
Thank you. Any other questions? Doctor, I appreciate you being here today and sharing your testimony, and hopefully you'll be available if we have any more questions. Not today, obviously, but if we need to reach back out to you.
I'd be happy to.
All
Thank
right,
you.
I really appreciate your work, and thank you.
Thank you.
All right. Next up, we have Dr. Elizabeth Mack with MUSC. Thank you.
Thank you. Good morning, Mr. Chairman and Subcommittee. My name is Dr. Elizabeth Mack. I'm speaking to you today on behalf of the South Carolina American Academy of Pediatrics. I'm a board-certified pediatrician and a pediatric critical care physician, and this means I work in the pediatric ICU. I was born and raised here in Columbia. I went to USC for my undergrad, for 4 years of med school, for 3 years of pediatric residency, and then I went to Cincinnati Children's for 3 years of pediatric critical care fellowship. And there, as well, at the University of Cincinnati, I also earned a master's of biostatistics and epidemiology, focusing on disease spread, informatics, and data analysis. I then returned and have been working here in this state ever since. And I was in the Midlands for 5 years, and now I'm in the Low Country for the last 7 years. And I serve as the vice president of the South Carolina chapter of the American Academy of Pediatrics. And I also serve as the American Academy of Pediatrics section on critical care chair. Perhaps most importantly, I've had the privilege of caring for our state's most critically ill children for the last 2 decades. And in terms of disclosures, I receive no payments from any drug companies or agencies or sources other than the state and the university, my employer. And I'm not incentivized to give any particular medicines or therapies or vaccines to patients. And in fact, I lead quality and safety for our children's hospital, and I aim to provide the highest quality care based on data-driven best practices. And as we sit here today, yesterday's South Carolina Children's Hospital collaborative data showed us that we had 30 children hospitalized with COVID, 9 children requiring critical care, 5 on ventilators, and 3 requiring what we call ECMO, or extracorporeal membrane oxygenation, so that's a lung bypass machine. And, in the course of the entire pandemic at our institution, we have had 0 children hospitalized with COVID that have been vaccinated against COVID. And about half of those have been eligible for vaccination. So it is not true that children don't get sick. And none of these therapies are a guarantee, including the lung bypass machine. It's really unacceptable to have any child hospitalized requiring the most extreme forms of life support, such as continuous renal replacement therapy, ECMO, or others, due to a preventable cause. And for perspective, we have never had 3 children on ECMO for the same reason in this state.
Doctor, can I stop you? You
Yeah.
said preventable cause. Well,
Yep.
Can you explain that?
Sure. This surge, this phase is preventable.
What is preventable?
COVID, the spread of COVID.
And how do you prevent that? When they just testified that the vaccines, people still get COVID, transmit COVID. Now you're telling us we can prevent COVID. Can you
Sure.
explain
Absolutely.
how we're going to prevent it?
Vaccination is the #1 way to prevent the spread of COVID-19. It's safe and it's efficacious, and it is indicated for children that are 16 and up, and it's available by EUA for children 12 to 15, in addition to masking, in addition to testing, in addition to quarantine and isolation.
So you're telling me that what we've been heard testimony yesterday and today, that people that get the vaccine, it doesn't prevent COVID, it doesn't prevent the spreading of COVID, it only reduces the symptoms? Or-
No.
So you're telling me that if you get the vaccine, you cannot get COVID? Is that what you're saying?
No.
Then what do you mean by preventable? How's it
The
preventable?
vaccine's primary, when we study the vaccine, we look obviously at safety and efficacy. The primary endpoints that we examine are hospitalization and mortality.
Right, when
It
you said
also helps
preventable-
reduce the spread of COVID, and it's not sufficient alone. We do also have to have masking where children are together, and we also have to have testing, isolation, and quarantine.
But you said preventable.
This is preventable.
I'm really totally confused when there's doctors that have testified that the vaccine does not prevent, and there's people that take the vaccine and still get COVID. So how are you able to say it's preventable?
It does reduce the infectivity of the virus.
That's
It
different than
also
preventable.
This is
It's not
preventable.
100%, but it still prevents.
Right.
We can shut down this pandemic.
Okay, well, when I hear preventable, that means it's preventable. Okay.
They
This
have
is
prevent defenses and somebody still scores. I mean,
Right,
it
but I mean,
happens occasionally.
when I heard preventable, it makes me, seems like it's contradictory to the rest of the testimony.
This is preventable.
So,
Yeah. May I continue?
yes, you can
Okay.
continue.
So we've never had 3 children on ECMO in this state for the same reason. We've never had half of our ICUs in this state filled with the same preventable illness. And a small percentage of a large number is a large number. So when you talk about there's a low number of children that are hospitalized or a low number of children that are infected relative to the rest of the society, that's a large number, and I'll share more about that in a minute. But in terms of the COVID therapies, the topic of this hearing, this is a short discussion when it comes to children. Children are not little adults. Remdesivir the use of it is based on the FDA EUA for the treatment of those requiring hospitalization and oxygen therapy and those that are 3.5 kilos or greater. And of note, there are inclusion and exclusion criteria so not every child is eligible for that therapy. Additionally, as Dr. Andrews mentioned, dexamethasone is recommended for those who require oxygen or other more advanced respiratory support. And as you know now, monoclonal antibodies are not as readily available and are only an option under the EUA for those who are 12 and up. So in other words, it's not an option for those who are less than 12. And they also have to be at least 40 kilos with specific risk factors in the treatment of mild to moderate acute COVID or post-exposure prophylaxis. Thus, it is not an option for hospitalized children or for children without risk factors who can still progress to severe disease. And at least in adult studies, it hasn't been as well studied in children, but monoclonal antibodies, the number needed to treat is 20. So you have to treat 20 people to see the benefit in one. And multiple evidence-based guidelines, including the Infectious Disease Society of America, recommend against the use, specifically in children I'll speak to, of convalescent plasma, hydroxychloroquine, ivermectin, vitamins, and mineral therapies, and a variety of approaches suggested in the hearing last week because of either the lack of efficacy and or the risk of harm, depending on the specific therapy. And I'll just mention we are not hamstrung by drug companies or other external forces. It is true that we practice based on the most available evidence, and that evolves over time. We don't practice based on anecdote, and we uphold our oath to do first no harm. Mostly, we utilize supportive therapies, and this, by the way, is not unique to COVID. So there are many other viruses out there that we rely on supportive therapy for. We also have available some last-ditch therapies for children that are in the ICUs, such as baricitinib or tocilizumab, but those are also hard to obtain just based on supply issues. Antibiotics do not treat viruses, and these are desperate times. So we practice based on the evidence. I would just mention that prevention is the best medicine. We have all the evidence we need right now pointing to the answer. So my colleagues around the country, many of them are not experiencing what we're seeing here in South Carolina. South Carolina tops the charts in terms of COVID in children right now in all the wrong ways. As of September 9th, the most available data from the American Academy of Pediatrics and the Children's Hospital Association, we are third in the country in terms of the percent of total cases being children, which is 22%. of our total cases are children. We are second in the country in terms of COVID cases in the rating. So we have about 13,000 cases per 100,000 children. And we have seen 18 deaths and 565 hospitalizations as of September 9th, which that number is much bigger now, in the children aged 0 to 20. And this number will continue to rise if we don't alter the course in terms of prevention. Only 25% of our children 12 to 19 are fully vaccinated against COVID in the state, and children less than 12 are completely dependent on all of the other mitigation strategies: masking, distancing, hand hygiene, testing, quarantining and isolation when appropriate, and then those around them being vaccinated. So what is our priority? I think it's important to consider many of our children are not eligible for COVID therapies and thus are relying on prevention measures. Let us do all in our power to protect our children, and I'm happy to answer questions, and I really appreciate all that you do on behalf of kids.
Senator McLeod.
Thank you, Mr. Chair. Thank you, Doctor, for your testimony here today. I want to go back to a few of the things that you mentioned because I think that they are critically important. One was the fact that children, I think you said children under 12, are not eligible for the monoclonal antibody treatment. Is that correct? Okay. And you also mentioned another treatment that I have not heard of, and you said that it's unprecedented that 3 children would be taking that treatment. What treatment was that, and what is that?
Sure.
What are the details of that?
So it's called extracorporeal membrane oxygenation. So it is a machine. We put a cannula, typically for older children, we put a cannula in the child's neck. It's pretty large. It goes in the body and sits in the vein. We pull out their blood. We take it through a machine. We filter their blood. We pull out the carbon dioxide. We oxygenate the blood. And we return it back to their body. There's no guarantee with that. Depending on the study you look at, the survival with that would be about 30 to 50%, and of course that's survival. So there can be many other problems associated. And this is the most aggressive form of support that we can provide. We only offer this at one center in the state, and it breaks my heart to look at these kids and see all that they're going through and know that they didn't have to be in this situation.
Thank you for expounding on that, because I had no idea. One of the things that the gentleman before you, I think it was Dr. McCullough, spoke about, and I'd just like to hear what your perspective, your professional perspective is about. He mentioned that those who are vaccinated can transmit the virus at alarming rates. I don't remember exactly what those rates were, but what is your medical or your professional perspective about that particular comment?
Sure. I'll speak based on the evidence and my experience as well. So in my experience, as I mentioned, we have cared for 0 children vaccinated against COVID in the entire pandemic who have been hospitalized with COVID. 0, none. So you've seen the infographics that hospitals have shared, and the dots and the colored, the colored ones being, indicating vaccine status or not. In children, that looks different. It's not the case. We're not seeing the vaccinated children. In terms of the evidence is clear when it comes to vaccination. It's absolutely clear. There's not question about that. And in terms specifically, related to some of the other therapies, there's a Cochrane review, which we actually uphold as one of the most critical and trustworthy sources relating to ivermectin, which hasn't been looked at in kids. We use it for scabies, for strongyloidiasis, for head lice, body lice, pubic lice, but it hasn't been looked at in children. And the data is, there's a good Cochrane review on that. So, but vaccination, there's no question. This is our way out. It's not sufficient. To your point earlier, we have to do a variety of other things, but it is key.
And I want to thank you for those comments, because when my chair asked you to kind of expound on the word prevention, and I know that he had some concerns about that, I will just say to you and to him that, as someone who lives with sickle cell disease, I am vaccinated. And for me, it's important to be vaccinated because I've been vaccinated for just about everything. I mean, immunization records are key to being able to go to school in this state, or they were, at least before COVID. But here's the thing. I've been vaccinated against the flu, and I've gotten the flu after being vaccinated, but the case was so mild that I didn't have any, any major issues. The same is true for COVID-19, and I'm fortunate that I have not been exposed to COVID-19 because I try to, in addition to being vaccinated, I try to practice the social distancing and hand washing and all of the other guidelines and recommendations that we've received. But to hear us talk about ways that we know and have been scientifically and medically, proven that we can really manage the spread and control the spread and prevent the spread of this deadly virus, and to not, to just kind of gloss over that and overlook those key points is, I think, something that I hope this committee will not overlook the efficacy of the vaccinations. Thank you so much for your testimony.
No, I mean, I think your point is particularly salient in that, we are not just doing these things to protect ourselves. We're doing them to protect the children, those that are immunocompromised. So the kids don't have a lot of options when they're less than 12, and they really are relying on us to make the right decisions.
Thank you.
Dr. Mack, one thing that I hear from constituents, and you get a lot of emails, you talk to people who are nurses, you talk to people who are in schools, you find some that say that my child never goes anywhere, my child always wears a mask, but my husband and I, or my wife and I, we got fully vaccinated, and all of a sudden that child has COVID. There's people that come to me and tell me that child too young to be vaccinated. And again, this committee here today is not here to talk about vaccinations. We're here to talk about the therapeutics, and they're mainly for adults. So I don't think anybody on this committee's claiming to do these treatments on children. That wasn't the purpose of these hearings. Still appreciate you being here. But what do you feel about that? That could be a way that they're catching COVID, right? From their vaccinated people in their household.
No. The vaccine is not a live virus. It's not possible to contract COVID from the vaccine. We do have vaccines
No, that ain't what I said. I said, could they, it's been testified in here in this committee that people who get the vaccine can still pass and transmit COVID. My question to you is, could those children who wear masks everywhere, including school, and they don't go anywhere and they're only around their parents and their parents both got vaccinated, their parents could have transmitted COVID to that child, correct?
Anyone could have transmitted COVID to that child.
But their parents could have. There's nothing that's saying that their parents couldn't have that they're vaccinated.
There are certainly breakthrough cases, absolutely. Thankfully, they're milder. Thankfully, they're less likely to result in hospitalization or death. And we have we have excellent data on the breakthrough cases specifically.
And all our testimony has been, the COVID shot is not to prevent COVID. The COVID shot is not to prevent the symptoms or passing it. I want to make sure that you're not telling this committee that somebody still can't transmit COVID from the vaccine.
No, we can. It will not come from the vaccine. I guess
Excuse me, a vaccinated person cannot still transmit COVID.
Yeah, there are breakthrough cases. Thankfully, they are milder, and the data supports that they are less likely to result in hospitalization or death.
But that's for the vaccinated person.
And they're less likely to spread as well.
So when a vaccinated person spreads it to an unvaccinated person, that could still be worse for that unvaccinated person.
No. They're less likely to spread, and there is no data to support that the disease would be worse because it came from a vaccinated person.
No, what I'm saying is, I think you missed my question.
I'm sorry.
If you've got a room full of vaccinated people, and then you've got 4 or 5 unvaccinated people that come in, those unvaccinated people could catch COVID from those vaccinated people. So,
Yes.
but their symptoms aren't going to be reduced or anything. They've just caught COVID from a vaccinated person, and their symptoms could be mild or severe, or the 99% of the people that get COVID and don't even know it. Right?
Certainly, it's much better to be vaccinated. You're less likely to get sick. Yeah.
No, I understand that, but there's nothing stopping the vaccinated people from transmitting COVID to the unvaccinated people.
The vaccine, they're less likely to spread it.
There's nothing stopping the vaccinated people from spreading COVID to unvaccinated people.
The vaccine. It
No,
won't stop. It will decrease the risk.
No,
and
what
it'll
I'm
decrease
saying
the
is there's
infectivity.
nothing stopping vaccinated people from transmitting COVID-19 to unvaccinated people. That's a simple yes or no question.
She's not on a witness stand. You can't make someone say
Well, I mean,
something.
I'm just trying to get her to- I
You
mean-
want her to say what you want her to say, and she is
You're out of
giving
order, Senator.
testimony. So are you. Because
Do you have an
it's
answer for that,
contentious.
ma'am?
Yeah, the vaccine makes it less likely for them to
I
transmit.
think you've answered my question. Thank you. Senator from Colleton.
And my
I'm sorry.
apologies.
I'm sorry. Senator Davis.
Yes.
I'll yield to my friend.
My apologies just a minute ago, and my apologies to you, because it seems that this is really contentious here, and I want to clarify one thing, at least from my understanding. In no way, there was an issue when we first had convened these meetings on last week, and to the medical community, that there was no particular purpose or particular reason for us having this other than to explore and hear opinions. And if anything that anybody on this committee has said, I would hope that you leave here knowing that we appreciate your testimony as it relates to the efficacy of monoclonal drugs and whether or not they could be used for our young children. So as I understand, and I'm sorry about the back and forth, as I understood it when I came as a committee member, we were trying to develop where we were going with having these public hearings. So I appreciate, if I don't want you to take away from this that we don't want to hear about pediatrics and what we're doing for our children, because as you know, we have our children are back in classrooms, and we have to protect them. That being said, my apologies to you, and we thank you for what you're doing for our community.
Thank you.
Mr. Chairman.
Thank you. Senator Davis, then Senator Verdon.
Thank you, Dr. Mack. I appreciate you taking the time, and just I'm going to share my thoughts and my opinions. What's discouraging to me sometimes about our discussions is that it seems like we're proceeding on a mutually exclusive basis. That if you believe in the efficacy of vaccines, which I do, and I believe that they are the primary means of stopping the spread, and I firmly hold to that opinion. I've expressed it. But the fact that I believe that doesn't preclude me from also recognizing, does it, that there are instances in which therapeutic options are going to be efficacious. I mean, I can hold both of those ideas in my mind at the same time. Is that not correct?
Absolutely. Yep.
And it seems to me, and this was stated earlier by your colleague at MUSC, that we need to get away from the politics in this debate and down toward empowering doctors and letting doctors, based on that relationship with patients, to develop what that doctor believes is in that patient's best interests. And I think you can hold that position, in my opinion, you can hold that position and at the same time believe in the efficacy of vaccines and believe in the efficacy of therapeutics in certain circumstances, that these aren't mutually exclusive ideas, are they? Is that correct?
Correct, sir.
And am I also correct that as we look at COVID and as we learn more about COVID and as frontline doctors are dealing with COVID, that it's of necessity and has been a relatively fluid situation, right, in terms of what works, what doesn't work, having to adjust expectations, having to adjust therapies. I mean, we're very much we're not in an area where you've got settled medical science based on 10 years. We're kind of learning on the fly. Is that a fair statement?
Certainly, and I think that's the case for many of our diseases. And to your point, we used azithromycin, we used hydroxychloroquine early on, and have abandoned those as kind of the science has evolved.
And is it, and I take from that, again, and I'm a lawyer, I'm not a doctor, and I don't want to be involved in medical decisions, but what I take away from this whole debate is in that there is nothing settled from an institutional perspective. In other words, we don't have any absolute truths as we learn about COVID, that it would serve us to give as much latitude to doctors and physicians as possible. Is that not correct?
I think it's important to be open to the science as it changes.
And even in cases, and I said this earlier about the monoclonal, the Regeneron, and again, just observing it from a layperson's perspective, it seems to me that in regard to that one therapeutic, that there has been a shift in the medical community as to its efficacious, has there not over the last few months? Not with children, I understand that, but in regard to adults, because
even with children,
okay,
I would say.
And I guess that's my point, is that it serves us well to be a little humble here and to have some humility here and to recognize we're not dealing with certainties. And I feel more comfortable in that situation giving latitude down to y'all, to physicians. And would you agree with that? That's the public policy response, if there is one from us, is to make sure that doctors feel empowered to do what they're trained to do, which is to consult with their patient, to understand that patient's condition, and then to have the latitude professionally to do what they believe is an evidence-based treatment. Is that a fair statement?
Absolutely.
Okay. Thank you, ma'am.
Thank you. Senator Verdon.
Mr. Chairman, I would ask to defer to the senator from Orangeburg and what other colloquy with Dr. Mack, and then I would ask you to come back to me.
Senator from Orangeburg. Senator Hutto.
I want to follow up on what Senator Davis was asking. I mean, nobody is prohibiting you from prescribing anything you believe might help your patient right now. Is that correct?
Correct. I practice according to the evidence, and the certifying bodies and my institution have been fully supportive of those concepts.
Okay, because I mean, it just seems to me we started off this process that somehow that people's hands are being tied. But I mean, you're free to practice based on the evidence in science and medicine. If you've learned it, and if you see a patient that you believe would benefit by something different than the last patient you had, you're free to change the prescription, the dosage, the whatever, as long as it fits within acceptable medical science.
Yes, absolutely.
Okay.
Thank you. Senator Verdon.
Dismissing Dr. Mack, or I'm finished.
Thank you.
Mr. Chairman, in response to the senator from Colleton, Senator, you and I have enjoyed tremendous collegiality, and I know we'll continue. Everything that's always passed between us has been with a smile on our faces. There was mischaracterization last week, both in print media and in comments from members of the committee as to the purpose of the meeting, purpose of the committee. It was clear in the memo that was sent to each member that the address of the availability of therapeutic medicine for sick South Carolinians with COVID would be the immediate focal point of this committee. I tried to blunt any swerving, veering through other subject matter, whether it be the budget provisos dealing with masking, whether it be vaccination policy, which I can totally concur with the senator from Beaufort, is a matter that we gladly receive testimony from expert witness, but is not the immediate focal point. And I'll continue to iterate what I think we all can give testimony to, is that in my 20-plus years of listening to the public, there's not been another subject more urgent that they have pressed upon us. So I will continue to thank you for your service on this subcommittee. As I said last week, there was not a resolution, not a House bill, not a Senate bill immediately before us. I hope that we can direct the legislature or anyone else interested based on the platform of information and the body of information that we develop here with our work. Again, last week said I don't think there's another entity within certainly the General Assembly and possibly state government more equipped or better positioned. And in conclusion and as a result of our work, I hope that we will give direction on statutory and regulatory direction for us to take. So thank you so much for your service here on the subcommittee.
Thank you. And just to be direct, Senator, and thank you for your comments. My specific questions at the beginning of the meeting was where do you want us, where as chair of medical affairs, where do you want this subcommittee's work to lead to? And you responded to that as you have done here today. And so I just wanted us to have a working framework so that it would, because if you will recall at the beginning of the meeting, I believe the senator from Charleston, Senator Kempson, was asking about the subheading on this where it said therapeutic options for individuals, and he inquired when would we hear from DHEC and other medical providers. And we're here to hear. It just concerned me because there was, at least from my perspective, an inference that because therapeutic options did not relate to children, that we did not need to hear from pediatricians. That was my concern.
Thank you. Thank you, Doctor. Next up, we have Dr. Michelle Hagenbu. I hope I pronounced that correctly. Hagenbu, I'm sorry. I was halfway there.
Close enough. It's been slaughtered worse, trust me. Well, good morning, and I appreciate the opportunity to come here and talk with you all today about COVID-19 specifically in rural South Carolina. I've been in private practice in Lawrence County for 25 years. My practice consists of myself. I'm an independent practitioner with one amazing nurse practitioner and an excellent support staff. Let's turn back the clock to the spring of 2020.
Will you pull that microphone a little closer to you?
Is that better?
Yes, ma'am.
Okay.
Thank you.
Okay. How's that? All right. Let's turn back the clock to the spring of 2020. At that time, we were seeing dramatic number of hospitalizations, ventilator management, and deaths, especially in elderly and those with comorbidities. I am an outpatient physician. My discussion is limited to outpatient therapeutics and practice. At that time, outpatient guidance from CDC, DHEC, and various medical organizations recommended symptomatic care only and go to the hospital if you just couldn't cope at home. I found that unacceptable. Practitioners in my community were doing some televisits. I found that a little bit difficult to evaluate someone's pulmonary status over the phone or over a televisit. I may be old-fashioned, but I still like to examine my patients. I began doing research not only in the United States, but on the international framework as well, and I read the entire study, not just the abstract, which is kind of the Cliff Notes version of a medical document. During that time, I found that there was a lot of interesting things. We can discuss that later. But so because of this, we chose to change the way we practice in my office. I actually was semi-retired. I came out of semi-retirement. My nurse practitioner quit taking a day off. We pretty much worked from 8 o'clock until the last patient's seen and through lunch if necessary, seeing between 50 and 80 patients a day. Not just patients within my practice, but unfortunately patients throughout the state of South Carolina who cannot manage to find a physician that will actually see them, evaluate them, and treat them. Well, we don't have a strict protocol, but what we did, if patients had mild symptoms, we treated them symptomatically. Then we recommended they be reevaluated in person in 2 to 3 days. If their symptoms worsen, we then discussed with the patient the options of Zithromax, steroids, hydroxychloroquine, inhalers, aspirin, as well as what I call immune support, which is vitamin therapy. Also, we told people not to lay around, get up and move, exercise those lungs, don't get a secondary pneumonia. We saw them back every 2 to 3 days until they either required hospitalization or got better. Now, fortunately, with the addition of monoclonal antibodies, that has changed a little bit. We are using more monoclonal antibody therapy over the last few weeks. There is some not resistance, but difficulty getting patients these therapies. In my patient population, I've seen between 1 and 5 days that it will take to get someone in to get therapy based on bottlenecks of the number of doses. They can only give so many doses in a day. And also, these people, they're taking all comers throughout the community, so they do try and risk stratify to give it to the sickest patients first, which I feel is appropriate. Let me make it clear, though, 75% of the patients I treated required only symptomatic care. Of the over 700 COVID patients I cared for, only 2% required hospitalization, 0% required ventilator management, and 0% died. Once again, I will say that 75% required only symptomatic care. Of the over 700 patients I treated, only 2% required hospitalization, 0% required ventilator support, and zero deaths occurred. I'll put those numbers up against anybody.
Mr. Chairman.
Oh,
And my passion, can I continue?
yes, ma'am. I thought you were,
Well,
I thought you were stopping for a
okay.
second. Go ahead, continue, please.
My passion stems from embarrassment. I'm embarrassed about my profession's poor handling of this medical situation. I'm embarrassed to see doctors abandoning their patients. I'm embarrassed to see a medical illness become a political pawn and a reason to foster more division. The genie is out of the bottle. We cannot cram it back in as much as we would like to. We have to think about the fourth quarter and what the end game is, as well as what we're playing right now. Now I'm done.
Thank you. Thank you for being here in your testimony, and I wrote your percentages down, but I'll yield to Senator from Orangeburg. Senator Hutto, you have a question?
Yeah, I do. So is the point, I mean, are you telling me that somebody is restricting your ability to practice?
I, fortunately, am an independent physician. I am not employed by a hospital system. However, several of my colleagues that I've spoken with said that they have been told that there will be disciplinary action and possible firing if they go outside of their protocol, and specifically pertaining to ivermectin and hydroxychloroquine.
Right, but I mean, that's what happens when you work for somebody.
Right.
You got to obey the boss's rules. And if
Well,
that's the boss's
unless you're
rules,
your own boss.
Exactly, and you are your own boss.
Yes,
and
I
so
am.
That's my point, is that nobody is restricting your ability to practice medicine and prescribe for your patients whatever therapies or drugs that you want to.
That's true. However, I have had one pharmacist on CVS in Simpsonville, South Carolina, that refused to fill a hydroxychloroquine prescription for me just a week ago. So, unfortunately, that pharmacist also inferred to the patient's wife that I was trying to do harm to him. Fortunately, she is a nurse. She was there for the evaluation and was 100% on board with the therapy that we had recommended. We had just
I assume they got it filled somewhere else, right?
Excuse me?
I assume they got it filled somewhere else.
Yes, I recommended that they go to another pharmacy.
Sure. So, I mean, basically, the treatments that you have chosen for your patients, you've been unrestricted, and the medicines that you have prescribed have all been filled.
However, I will say that early on, I would receive patients that would come back 2 to 3 days later for repeat evaluation that would have a handwritten note from the pharmacist say that they refused to fill the hydroxychloroquine. So this was 2 to 3 days later. The pharmacist did not notify me. We live in a rural community. There is an educational gap, and the patients didn't know what to do, so they just came and brought their note to me 2 to 3 days later, so that, pushed back the therapeutics. And I guess the biggest thing I've seen with this is the earlier the treatment, the better the result. So from that standpoint, I would say I may not be impeded, but my patient care has been impeded.
Well, I guess my point is this. I think it'd be bad for us to tell doctors how to practice medicine. I think it'd be bad for us to tell pharmacists how to practice pharmacy. What is it that we need? What is it that you think we need to do? I mean, if nobody's restricting your ability to treat your patients as you see fit, and all your patients have gotten the treatment that you think they should have, and you've demonstrated you've got wonderful results, what is it that are you asking us to do anything?
Yes, I think that there needs to be some changes that practitioners, even if you work for someone, need to be able to practice medicine. I don't know if that's the purview of this committee or this board. I don't know. I'm not a politician. I'm a physician. But I think that if your livelihood If you don't mind me asking, what do you do?
I'm a lawyer.
You're a lawyer? Okay. So if you were not allowed to prosecute a certain case or, say, do pro bono work, then you would have the option to leave
Which
your
I
livelihood.
could leave my law firm and go to another law firm.
Right. What if that other law firm had the same issues?
Well, look,
The same
I mean,
requirements.
that gets back to my point. If you choose to be employed by somebody, you got to follow their rules, right? If
Even if it kills people.
well, you haven't demonstrated, to my knowledge, that anybody's killed anybody.
Well, let's see. Let's talk about that. Okay, these are DHEC numbers. Where is that? Excuse me, let me get my other sheet of paper.
Sir from Lawrence.
Mr.
While
Chairman.
Dr. Hagenbu is referencing her materials, might I just share a point of embarrassment? Dr. Hagenbu expressed a point of embarrassment about the state of medical care delivery right now. I'm going to express my embarrassment of just having met Dr. Hagenbu a few hours ago. I thank you, Dr. Hagenbu, for coming. I thank you for your service to the citizens of Lawrence County, and it sounds like maybe every other county in South Carolina. I think you told me maybe states of Georgia and North Carolina as well. There's some great testimonial to the fact that you are seeing a 50 to 80 caseload workload per day and demonstrating the data of efficacy and success that you are. So behalf of the committee, thank you for appearing in person as well.
You're welcome.
Mr. Chairman.
Yes, sir.
As of, these are numbers from South Carolina DHEC website, 9/19/21. The number of tests in South Carolina for COVID-19, 10,588,960. Cases, 832,466. Hospitalizations, 28,089. Ventilators are not listed. Deaths, 11,828. That is a 42% death rate for people that enter the hospital with the diagnosis of COVID-19. So I feel that there have been deaths that have occurred from lack of outpatient therapy.
I mean, have you never referred anybody to the hospital for COVID?
Yes, none of them, mostly it was for IV fluids. None of them required ventilator support, and none of them died.
Well, I understand that, but you're not telling us if patient had seen you or somebody like you that we'd have no hospitalizations, are you?
No, I'm just giving you my
Right, and you're
small
not telling
little
us-
numbers.
Right, you're not telling us there'd be no deaths. I think what you...
No, I'm saying that I think that number would be significantly improved. I think the number of people that would go to the hospital would be significantly less, hence the number of deaths would be less.
So I'm going to just get back to my question, because we can only do what we can do. What is it that you would like, what law is it that you're asking us to pass, or are you asking us to pass a law?
I'm not asking you to pass a law. I am here to tell you what I am seeing in the medical community in the state of South Carolina and the frustrations that we are all seeing. Obviously, this has become a huge political thing, so then why am I standing here?
That's what I'm asking you. What is it that you'd like us to do? I mean, obviously, you can educate people, and I join with the senator from Lawrence. I appreciate what you're doing. You're on the front line. My wife's a doctor. She's seen, hundreds of COVID patients, and none of them have been hospitalized either.
Well, good.
Okay.
Then maybe we need to get together.
Well, maybe, but the point is, that doesn't mean that we don't need the hospitals there when we need them.
Oh, no, absolutely not.
Okay.
Oh, that's not the case at all.
Well, I
What I'm
understand.
saying, I'm trying to keep people out of the hospital.
Well, I understand, and so it sounds like you're doing that, and that's wonderful. It just seems to me that there's a complaint out there that doctors can't prescribe what they want to, but every doctor I've asked this morning has told me they can, and there's some complaint that people can't get the medicine, and 100% of your people have gotten their medicine, and the other doctor said 100% of his people had gotten the medicine.
Because those people will not stand in front of this committee and risk their livelihood.
Which people?
My colleagues, my physician, my
Right,
colleague
those are people, though, that you say work for a hospital system.
Correct.
Okay, well, again, they don't have to, that's their choice to work for a hospital system, right?
Well, if you looked at the numbers of independent practitioners across the nation, you'll find that that is going away. I'm a dying breed.
Yeah, I understand. Well, I understand.
So that means that the face of medicine is changing, so there will be fewer and fewer of people like myself that will do their own research and treat
I don't want to
independently.
belabor this, but are you asking us to dictate to the hospitals what their rules ought to be?
I think that, I don't know what this body can do.
Well, we can do a lot. The question is,
Okay.
are you asking us to rewrite the rules for hospital employment? I mean, you think that we, a group of non-medical folks, should be determining what hospitals and what the arrangement hospitals and doctors have with one another is?
Can I help with the question, Mr. Chairman?
Because I think I'm
I think
confused.
we could do that. I don't know.
well-
Why would we want to?
Would you
Yeah,
allow me?
sure.
Hold on. Senator,
Sorry.
Senator from
Sorry, Mr. Chairman.
Lawrenceburg does
Absolutely.
yield to the senator from Lawrence. Senator from Lawrence.
Thank you, Mr. Chairman. Dr. Higginboo, in response to the senator from Orangeburg, would you hearken back to the comments offered initially, very salient comment, and then reiterated by the senator from Beaufort, that anything we can do here within the legislative context to accentuate, amplify, consecrate the relationship between patients and their physicians should be paramount work for us.
Correct.
Without the various factors that the senator from Beaufort listed, whether it be regulators, whether it be examining boards, whether it be pharmacy boards, whether it be corporate pharmacies, corporate hospital systems, accentuating the relationship between the doctor and the physician and the patient is a good admonition for the senator from Orangeburg and the senator from Lawrence.
Yes, and making sure that these therapeutics are available. Sometimes the pharmacies have to order whatever, and that may take a day or two. So making sure that these medications that are in high demand are available, and the monoclonal antibodies are available earlier rather than later. So I don't know if that's more infusion centers, or I don't understand how this works. But making more.
We've been told that's more of a supply chain issue, that, I mean, when you put the orders in, they get filled. And as you said, sometimes they have to actually be, I don't like to use the word ration, but they at least have to be prioritized when there are not enough doses available, and you understand that and believe in that process. Obviously, if we had all the doses for everything available all the time, that'd be wonderful, but that seems to be a production supply chain issue that's beyond our control.
And the other thing I would say, that if a physician that, let's say, had been employed by a corporatized medicine decided, I want to go out and I want to prescribe XYZ despite what my boss says. So I'm going to quit my job, go out, find a place to practice, get a nurse, get a staff, set up all of the things that it takes to start a practice. That doesn't happen overnight, and as an attorney, I'm sure you're aware of that. So the startup process does take a little time. So it's not like they can turnkey, leave their office, walk out the door, hang their shingle, and start prescribing. It just doesn't work that way. So that's another little glitch.
But we have a proud history in South Carolina being a right-to-work state, which means if you don't like what the boss is doing, go get another job. And if the boss doesn't like what you're doing, he's going to tell you to go get another job. That's just the way it is. Okay.
Thank you. Senator Verdon, are you through? I believe Senator Kempson from Charleston has a question.
Yeah, Mr. Chairman, and I appreciate the comments. And maybe we're going to hear from some hospital officials and managing directors of HMOs. But you know, what we've heard is a lot of hearsay evidence with respect to what doctors are being told. And I'm just wishing a doctor who's been told not to prescribe or administer some type of treatment would appear like a man or a woman in a profession and testify to that regard. But be that as it may, that's what we have to rely on, hearsay evidence today. What I'm hoping to hear from the people in charge at these institutions is what incentive would any hospital or any doctor have not to administer protocols particularly if those therapeutics have been researched, clinical trials have been conducted, and the therapeutics are consistent with medicine or treatment that comports with the doctor's responsibility to not deviate from a certain standard of care. And so I'd be interested in knowing, I don't know who your next presenter is, but I suspect that some of these, and I'm a lawyer, I'm not a doctor, some of these treatments may not be, there may not be clinical trials to use these therapeutics to treat COVID. And if they do, then that opens a whole nother discussion with respect to the patient and the hospital facing potential liability. And so I'm curious who can respond to that line of thought.
Do you have any comments for the senator from Charleston? Okay, I have one question before the senator from Lawrence has a question. You mentioned earlier, and I don't know if you were here for the whole meeting, but
Yes.
I think I mentioned earlier that when Senator Kimbrell was here from Spartanburg, that I've had calls, as he's had calls and contact with doctors who do work, as Senator from Orangeburg said, they work in a hospital system, and they feel like that they're not being able to treat a patient the way they want to. And, we've tried to get those folks to come, but obviously they don't want to be here in person because they're afraid. They've told me they've been told, and I know that's hearsay, but they're fearful of their job. And you brought up a point that they alluded to, but they never came out and told me that, yes, they could go get another job, but they're going to have to open up a private practice, get insurance, secure a building, find staff. And I think that makes them nervous, although that is, to his point, that would be their right or prerogative to do that. Are you aware, have you seen anything firsthand of those people trying to maybe do what you're doing but not able to because of who they work for?
No. Not physicians, but nurse practitioners. Pretty much when I have spoken with my colleagues about the therapeutics that I've been doing, they are like, well, I can't do that. I'm not allowed to do that. And that pretty much ends the conversation right there.
So you're in the same boat I am. They're telling you they can't do that, and they're telling me they can't do that, but they're not able to come tell us publicly they're not able to do that.
Yes, they're afraid of losing their livelihood.
Okay, thank you. Senator from Lawrence.
Thank you, Mr. Chairman. Dr. Hagenbu, have I got the right term when I describe a focal point of medical school education practice, shared decision-making?
That's actually a new coined term.
That's new?
Yeah, I kind of like it though.
Well, you described something in your practice where you see a patient in person, hands-on, eyeballs, and then 2 to 3 days later, again, if necessary, and you said you described or you talk about, you consult with the patient the options.
Mm-hmm.
Is that
The risk and benefits.
risk and benefit? Is that within the description of shared decision making?
Yes, sir.
Okay, so we're talking about the patient and the physician. This isn't physician to physician. It's not.
No.
We're not talking about collaborative
No, sir.
practice. Okay. Do you think that COVID, as the COVID pandemic has been, the response to the COVID pandemic has been within the framework of this, as you say, newly coined description of practice, just shared decision making?
I've seen people more interested, they're more read. They come in a lot of times with opinions. Sometimes we agree, sometimes we don't. That's okay, but then also I see people, they just come in and they feel bad and they want to get better.
Okay, they just want to get better. Doc, do something for me.
Yeah.
Does that not harken back to maybe before shared decision making?
Yes.
I think it's described as paternal
Yes.
practice of medicine. Just do something, you know better, you know it all.
Yes. that element still is present, yes.
Do you think COVID and the response to COVID fits more the paternalistic delivery of medicine or the shared decision-making?
I think it's both. I think it's 50-50. I think it depends on.
And I know you can't characterize everything.
Yeah, I think it
There's been
depends
so much
on-
broad characterization, but
Right.
I'm just saying descriptively.
Yeah, I think, I think it depends on the interest and literacy of the patient. I think that has a tremendous amount to do with it. I think those that are more literate and learned, not always, but they're the ones that are going to be more likely to use the internet and, come to me with questions about things that they've seen or read or heard, whereas, a lot of people are just make me better, I feel bad.
Do you think that, say, 5 years ago, 10 years ago, the elevated respect or status, do you think a doctor sat on the same pedestal as a priest or a minister?
When,
10 years
10
ago?
years ago? I don't think of myself in that fashion, so I guess I wouldn't know.
Think about the professions in the world in your life that you. All right.
People
so
like nurses
let
better
me
than
throw
doctors.
the lawyers in
Set
with you over
aside
there.
lawyers, 'cause
Let
we
me throw
know-
him in
Okay,
there.
y'all are way down here.
Well, I know where I am, Dr. Hagenboo, as a politician. I know where I am.
Mm-hmm.
It's not fun anymore. This is work that we have to feel compelled to. I used to say you had to have a combination of a little bit of big heart and big head. Well, the big head is gone. Again, back to the urgency of our constituents and why we're here. So if the medical profession has been undermined, do you think that we as politicians possibly meddling in business that we have no business? You think the lowly politician has effectively knocked a highly elevated and regarded medical community off their pedestal? Or has the medical community themselves been as great or maybe greater a contributing factor for the lack of trust that seems to be manifesting?
I think there are a lot of physicians that have become politicized. I think it's twofold. I don't think it's one way or the other. I think politics has gotten involved in it, but there are also physicians are people too, and they have their own opinions and politics as well, and they've allowed that to become part of it in addition. So they'll, and I'll say, for example, they may just look at one or two sources. They may limit the sources that they view because this is what they know, this is what they're comfortable with, this is what they've been taught in residency and fellowships, or you can open the door and look around and try other things. I'll use an example. In my limited career, ibuprofen, back to my pediatric colleagues, I don't think y'all are quite as old as I am, but it was contraindicated to give to children under the age of 18 when I was in residency. Now it's over the counter. So there's a lot of things that change, but if we continue the dogma and don't look past the dogma, we're never going to progress. And there will be people in every field that stick with the dogma, and those people are important. There will be people that look past the dogma, and those people are important as well.
Dr. Hagenboo, you've demonstrated your appeal from the citizens of South Carolina at large when you told me that you were treating people from all over South Carolina. I can't help it, but I want to empower my constituents and the constituents of everyone in this room that feel confident through shared decision-making, and I would never look down my nose at their ability to help determine what is in their best interest. I want to get to the point where you're not carrying an 80-patient load.
Me too.
From patients all over South Carolina. I want them to stop 5 miles from the house and find their Dr. Hagenboo at home. And if I can do it with the help and the collaboration of my colleagues, I'm going to do everything in my power to empower those physicians and those patients to get to the point of shared decision-making without interference, but with the blessing and the assist. And that includes everybody from boards of medical examiners, national certification boards, federal agencies. I'm making that commitment.
Thank you. Thank you. Whatever you can do to help.
Thank you. And thank you, Dr. Hagenbooth. I'm going to wait before I call the next person up. Staff has to make an adjustment. Senator from Lawrence.
You can't do it because he's hiding, but our colleague from Dorchester is here. So just.
Oh, Senator Bennett, thank you for being here today. Next up, we're going to continue. I was going to move on, but we've got one more doctor, Dr. Robert Jackson. If you're here, oh, he was behind the screen too. Yeah. Thank you, sir.
Appreciate your willingness to have me here as your guest. I'm from the upstate, from Spartanburg. I practiced family medicine for 40 years, 38 years as an independent physician, and 2 years working for Spartanburg Regional Medical Center. I attended Clemson University, Medical University in Charleston, 3 years as a family medicine resident in Spartanburg, and 1 year as a surgery resident there also. I'm here to advocate for doctors in the state of South Carolina. I think it's a little bit odd that I have to advocate for physicians, but that's what I'm here to do. In the 1840s in Vienna, there was a physician named Ignaz Semmelweis who worked at a teaching hospital, the Allgemeine Krankenhaus. He was a young obstetrician from Hungary. His responsibility was to watch out and take care of postpartum female patients. The protocol in that day was for the attending physicians to perform autopsies on the patients who had died the previous night. And then they would take their students in tow, go to the postpartum ward, and examine all of the postpartum females on Dr. Semmelweis' ward. He noticed that the female patients who were not examined by the attending physicians did not acquire puerperal fever, childbed fever. Being an astute and observant young physician, he decided to institute a policy whereby the attending physicians would wash their hands before examining his patients. He deduced that there must be something that was being transmitted from the morgue to his patients. The older physicians held him up to scorn and ridicule and did not want to wash their hands, but it was his ward. He prevailed. They had to wash their hands, and the 40% mortality on his ward plummeted. He then perceived that there was something being transmitted from patient to patient because the infections continued, and he instituted a policy of washing hands in between patients. The older physicians violently objected, went to the hospital administrators, protesting this young physician's policy, and they prevailed. The hand washing was discontinued. The mortality went back to 40%. Young Dr. Semmelweis resigned in humiliation. He went to Czechoslovakia to a hospital in Krakow, instituted the same policy, obtained the same results. The same ridicule and scorn was heaped upon him by older physicians, and the same result. He ended up resigning. He died in an insane asylum because he could not escape the vision of his patients dying needlessly from infections. Less than 50 years later, hand washing in between patients became the standard of care. The truth is often ridiculed and scorned. It's then violently opposed, and then it becomes self-evident. And in medicine, it becomes the standard of care. Medicine advances due to observations of individual physicians and innovations of astute physicians who are willing to practice medicine and willing to try new techniques or new medications or new modalities, willing sometimes to go against the established order or tradition or existing protocols, often enduring ridicule, scorn, or ostracism. However, the truth, like the tar baby, is a sticky thing, and it's persistent. More than that, suppressing truth is like trying to hold a beach ball underwater. It's exhausting and nearly impossible. It eventually comes to the surface. The truth, when first presented, is almost always ridiculed. It's then violently opposed, but then it eventually becomes self-evident. And like I said, in the medical world, it then becomes the standard of care. Those physicians who want to be innovative and want to provide quality care for their patients by prescribing a safe and effective medication, such as the one we've discussed today, which is ivermectin, are not only being ridiculed, but are being violently opposed. And many of them are being threatened with the loss of their livelihood. Many who would like to be here today feel so threatened they are fearful to make an appearance. These things should not be in America, the home of the free, the land of the brave. Here's my concern. Physicians in South Carolina are being strong-armed by hospital system employers, insisting that they adhere to protocols for the treatment of COVID and not allowing them to innovate or try new medications. COVID has only been an issue for 2 years. Every treatment is new and untested. We should be trying all manner of medications, even repurposing old medications like hydroxychloroquine or ivermectin, as are our medical peers all around the world. Senator Hutto has left us, but I want him to understand that I am one of those doctors that he wants to hear from who has been instructed by his employer to not prescribe ivermectin. 2 weeks ago, I was informed by the hospital system at Spartanburg Regional that I was one of the highest prescribers of ivermectin in the hospital system and that I should cease and desist. There was a veiled threat that if I continued to prescribe ivermectin, that my employment there would end. There was nothing put in writing, but that message came to me through my office administrator. I want you to understand that the physician-patient relationship is a sacred relationship to me, and that when there is informed consent and patients understand the risk and benefit of a proposed prescription or medical treatment regimen, that I believe that hospital entities, insurance companies, or federal entities should not interfere in that doctor-patient relationship. I am a free American, and I'm not going to be bullied or intimidated by hospitals or insurance companies or federal entities. I have personal friends in the hospital, and I want you to understand that when I practiced medicine for 40 years, that my patients become my friends. They become like family. And they're in the hospital seriously ill with COVID, on ventilators, and their families are begging intensive care doctors to try ivermectin to treat their patients. My patients are not illiterate. They're on the internet every day, and they understand the benefit of ivermectin for patients that are being treated around the world with that very same modality, only to hear these ICU doctors look at them and say, that's not a part of our protocol. And these patients are saying, but everything you're using is not helping. My husband, my wife is dying. What's the harm? Why will you not even try it? It's safe, it's effective, it's inexpensive. It's not going to hurt my husband or wife. It can only help. And their only response is, it's not part of our protocol. As to the effectiveness of ivermectin, I would only share with you what Dr. Pierre Corey shared with you, the example of Uttar Pradesh, also in Peru. Peru had an epidemic just like everyone else in the world. Their administration decided to distribute ivermectin nationwide, and their pandemic disappeared entirely, almost to zero in Peru. A different administration came to power. They discontinued the ivermectin distribution, and their epidemic returned to the same as all of their neighboring nations. The administration realized their mistake, began to distribute ivermectin nationwide, and their pandemic disappeared once again. The same thing happened in Mexico City. Their hospitals were at, what's the word I'm looking for? Capacity. And within 3 months, their hospitals were down to 20 to 30% utilization, all because they were distributing ivermectin citywide in all of Mexico City, one of the largest cities in the world. I brought for you copies of these meta-analyses of ivermectin use around the world, randomized controlled studies. You gentlemen and lady can look these over yourselves, and I would encourage you to do so. And Senator Hutto asked, what would we like for you to do? Here's my suggestions. Number one, a magistrate once told me that no matter how thin you slice the piece of bread, there's always two sides to the story. You're going to have to do your own research. You're going to have to do your own investigation and come to your own conclusion. But be careful that you don't associate with the crowd that will have egg on its face when that beach ball of truth comes to the surface. And we find that ivermectin is safe and effective, and it works well in treating our patients. And it becomes, like hand washing, the standard of care. I would ask you to advocate for the sanctity of the physician-patient relationship and the right of patients to practice medicine unimpeded by the bureaucracy. And just so you'll know, I have had pharmacists call and question my judgment when I have prescribed ivermectin and refused to prescribe the medication, saying that their pharmacy did not approve of it. If I were king for a day, I would recommend that we prescribe ivermectin to all adults in the state of South Carolina, just like they did in Uttar Pradesh and in Peru and in Argentina and Mexico City. I think we would see COVID disappear in South Carolina. And we could be the first in something in the United States rather than last. Remember, the next very ill patient in the ICU could be your spouse, your parent, or your child. And when everything else fails, you could be the one looking at the ICU intensivist and saying, well, doctor, everything else you've tried has not worked. Why will you not try ivermectin? And he'll look at you and just say, well, it's not on our protocol. Thank you for your kind attention.
Dr. Jackson, I appreciate you being here today, and I also want to thank you just on your advocacy for the lives of children as well. I appreciate that. I know the senator from Orangeburg he's not on the subcommittee, but he's on the full committee, and he told me before the meeting he was going to have to be in and out, so he's probably listening somewhere. But I'm glad that we have someone like you who is telling us they have been threatened or coerced to stop their kind of treatment. I think that's what our committee's wanting to get at. It's like I said before, when I opened up the meeting, we're not here to debate masks and vaccines and things like that. We're here to get, once all the measures that are put in place to maybe reduce symptoms or try to get some level of prevention in place, we're here to talk about what happens to these people once they catch it, whether they're vaccinated or not. What kind of treatments are available to save them. I do have a question for you. We've heard about the ventilator, and we've heard that once something gets to the ventilator stage, and again, I'm an engineer, I'm not a doctor, or is there harm being done by putting someone with COVID on a ventilator, or is maybe that's not a fair question to ask? There's probably many steps.
I'm not an intensivist, but what I've read is that the last resort is putting folks on a ventilator. You try to avoid that as long as possible. But in some patients, it's going to be inevitable. Their pulmonary status, the inflammation in their lungs is such that they're going to end up on a ventilator.
And in your opinion, would you believe, when do you think the best time to use the therapeutic that you just mentioned? Is it right when symptoms start, or is it to where someone feels like, I've heard people that have been tested positive with COVID, they've gotten a headache, they laid on the couch, they never really knew anything was wrong, and they were back to normal in a couple of days. How do you know when the therapeutics are right for that person?
Well, see, you can't predict who's going to progress to becoming very ill. And my recommendation, and not just mine, but a lot of the folks that are much more competent and treated a lot more patients than I have, their recommendation is to treat everybody early so that nobody progresses to severe illness. Ivermectin is so inexpensive. I mean, it's 60 cents to $1 a pill. Why not treat everybody early and not allow anybody to progress to severe illness? That, to me, is wise.
And I believe we heard testimony today that ivermectin, did it receive a Nobel Prize or an award in 2015?
The founder of the chemical, the product.
The founder.
He received a Nobel Prize, yes, sir.
And how long has this been used in humans?
It's been used for 40 years. It came on the market initially for treating river blindness, onychopsoriasis.
But is there any, like, across a wide range, are there any things to look for to where it might be to where you wouldn't want to use that in somebody, or is it so proven and trusted over 4 decades that it's not a problem?
Annually, there's 1 death per year attributed to ivermectin. By comparison, there's like 500 deaths per year attributed to Tylenol. Okay? That's how safe ivermectin is.
And I think most people, including myself, if somebody told me to take Tylenol, I wouldn't think twice.
Nobody thinks twice about taking
that.
Tylenol.
Okay. I may have another question for you, but I know the senator from Beaufort has a question.
Thank you, Dr. Jackson.
And then we've got others.
Thank you, and thank you for the example you gave us up front about the hand washing and going against accepted practice, and then over time, it becomes the new standard of practice.
Yes, sir.
And you're talking about in terms of things that inhibit or constrain the physician-patient relationship. And one of those constraints I think you've identified is a physician's employer may suggest or state that if you engage in this particular form of treatment, that your employment may be jeopardized. And that certainly is a constraint and a deterrence. I want to ask you about what another constraint might be. Would a physician be constrained or reluctant to prescribe therapeutics to a patient because the prevailing standard of care, as articulated by the CDC or by whomever, doesn't support that particular prescription? In other words, would a physician be afraid of malpractice or be afraid of an allegation that they didn't follow an accepted standard of care? Is that a constraint on what a physician now, in determining what to prescribe to a patient, is that a factor that enters into the equation?
Well, medical associations issue guidelines for treatment of all manner of things like diabetes, hypertension, chronic kidney disease, and all physicians pay attention to those guidelines. But that's all they are, is guidelines. And for various extenuating circumstances, in any individual patient, you can't always follow the guidelines. A patient may be impoverished. They cannot afford the medication. They may be low IQ. They can't understand the regimen. They may be just defiant and unwilling to take any medication. So guidelines are just guidelines. The standard of care is always a guideline itself. And for whatever reason, you may not be able to follow the guideline or the standard of care. But again, physicians deviate from the standard of care or from the guidelines for various reasons all the time.
And I guess that's the reason for my inquiry here, because I'm trying to decide what an appropriate public policy response by this General Assembly might be. Right. And I'm just wondering out loud if, for lack of a better phrase, a safe harbor were created in regard to the context of COVID-19 and for a limited period of time, and recognizing that standards of care in regard to treating that virus are evolving as evidence-based things come back and forth. Would you view that as an appropriate public policy response by this General Assembly to recognize that this is an area where the standard of care is of necessity fluid because we're dealing with something new, and that an appropriate public policy response by us might be to give physicians a degree of comfort or assurance in regard to them exercising his or her best judgment? Would that be something that this General Assembly could do?
I would agree with that wholeheartedly. Yes, sir.
Thank you, Senator from Beaufort. Senator from Richmond, Senator McLeod.
Thank you, Mr. Chair. Thank you, Doctor, for your comments. My question and concern are pretty similar to what Senator Davis just asked about the standard of care, but I wanted to go a little deeper because in listening to your testimony and the testimony of the doctor, I believe from Lawrence, who came before you, and the testimony of the two doctors who are not here in South Carolina, all talking about the efficacy of ivermectin. As a layperson, can you explain to me why you guys are so in the minority in your position on that treatment option?
Well, I would submit to you that we're not really in a minority. You can't get ivermectin hardly anywhere in the United States because there's so many physicians prescribing it, so many patients demanding it. It's just hard to get ivermectin. There are a lot of doctors prescribing it, and we're not really in a minority.
Okay, but when I think about the standard of care as a layperson, not a public health expert,
Standards
not
of
a
care
medical.
take a long time to evolve. This has only been happening for less than 2 years in the United States.
Right.
Protocols take time to establish, standards of care, and you know, they keep hearkening back to controlled trials, randomized controlled trials, and all those sorts of things. They also take a long time for large studies to emerge.
Right, I get that, but isn't that exactly what we want when
Yes,
it
ma'am,
comes
we
to-
do, but listen, people are dying every day for the lack of effective treatment. And if you
Well-
wait on all of those things to come available, I'm looking in the face of people who are very ill and very sick, and people that I don't want to become very ill and very sick. And I've looked at real-world data from India and South America and Mexico and other parts of the world where they have practically eradicated COVID, and I'm saying, look, I know something that'll work for you, and they know it too. They've read the data, they've looked at it, they're not ignorant, and they're coming to me and say, doctor, why don't you prescribe ivermectin for my mama? And I'm saying, I don't know why I shouldn't prescribe ivermectin for your mama.
Okay, so you're saying that your hospital is stopping you, preventing you from doing
Well, they're
that?
trying to, but I still prescribe it.
Okay.
And I may not have a job much longer.
Okay. Of course, that's your prerogative.
And they should stick to administration, and they should allow me to stick to treating patients.
Yeah, I'm glad you made that point, because what I was about to ask you is, this seems to be patient-driven, and you described people like me, who are lay people, who read. I read as much scientific data and medical data from medical professionals as I can get my hands on. This is a new virus, but certainly, the standard of care that has worked in other states and possibly other countries doesn't seem to doesn't seem to be around ivermectin. It seems that we are, at least what I'm hearing, and correct me if I'm wrong, but it seems that we are talking about patients who are driving their own treatment options based on what they've read, not based on scientific evidence. And there seems to be, from the testimony that I've heard here today, just so far, that doctors who are insisting on this specific treatment option are willing to throw the standard of care out the window because ivermectin is supposedly a safe drug that has been effective to treat other issues. As you said, COVID-19 is new. So why not go through the proper protocols and procedures to make sure that we are not compromising patient safety as it relates to this particular drug?
In February, the National Institute of Health said they could not recommend for or against ivermectin until there were additional studies available. Since that time, there have been 4 quality randomized controlled studies justifying and validating the use of ivermectin for the treatment of COVID-19. And I'm just saying to you that there's plenty of good evidence justifying the use of a safe, effective, inexpensive medication that does absolutely no harm. Absolutely no harm. It's not going to hurt my patients for me to give them ivermectin. It's not going to hurt their pocketbook, and it might save their life. So why does anybody care? Why does anybody protest? What does the hospital care if I give my patients ivermectin? What does the federal government care if I give my patients ivermectin? It's neither here nor there to them. Just because it's an off-label use, let them stay out of the life of me and my patients. They shouldn't give 2 hoots and a holler if I give ivermectin to my patients. It's not going to hurt them, and it might just save their life, ma'am.
I hear you, but
Please hear me. Please hear me.
I'm trying. I'm trying to understand.
Please understand that we don't wait on protocols. We don't wait on standards of care when we're in the field treating patients in my office. The protocol and the standard of care is not a sacred cow. Do you understand that? It's not a sacred cow.
I'm not suggesting that it is a sacred
It sounds
cow.
like you are.
Well, I'm not. I'm telling you
Okay,
I'm not.
well, I beg your forgiveness, but it does sound that way.
Okay. What I am suggesting, though, is there's a reason that obviously you are not in private practice. You are
I am in
affiliated
private
with
practice.
okay, well, you're affiliated with a hospital that you say is tying your hands and not allowing you to provide the treatment that you would like to provide. But I am not convinced that the studies, the 4 clinical trials or whatever you've just referenced is enough. Like, you are, it sounds like you are, single-handedly speaking for the entire medical profession about the efficacy of ivermectin, and I don't think that you have the ability or the authority to do that. So I'm glad that you have a hospital that is overseeing doctors like you who, may want to go against scientific medical research or not wait for the results of the medical research that you would need to treat your patients.
If you can't get ivermectin anywhere in the country, somebody else is prescribing it besides me, and they all believe the same thing that I believe.
Okay.
Does that make my point?
No,
Okay, well, you and I disagree.
that's great. We
Thank you,
can do
Doctor.
that.
I believe what you're trying to say is if you were in the minority and it was just Dr. Jackson that believed in a 40-year-old drug that's out here, there should be ivermectin slammed on the shelves, walking in, anywhere grabbing it. But if a lot of your colleagues across the nation are writing prescription after prescription, it's kind of like when you have a shortage of fuel and people are lined up to get fuel. If nobody needs fuel or nobody's wanting fuel, then the pumps will still be full. But the ivermectin is off the shelves or behind the shelves because many doctors like yourself across the country, are you stating that to this committee that many doctors across the country are prescribing this medicine?
I'm not the only doctor prescribing ivermectin. I'm not the only one who believes in its safety and effectiveness.
Any other questions? Senator from Colleton, Senator Margie Brock Matthews.
Just one question. Do you know of any instances where people have had COVID and were treated with ivermectin but have also died?
No, ma'am, I do not.
Okay, thank you.
Thank you. Senator from Lawrence, Senator Verdon.
Thank you, Mr. Chairman. Dr. Jackson, so Dr. Hagenboo gave her statistical data on her caseload and her hospitalization rate and her death rate. You have your, can you share anything with us?
I don't have exact numbers, but I can say to you that the folks that I have treated with hydroxychloroquine and ivermectin, none of them had to go to the hospital for admission or ended up in the ICU, except for one. But she came to me very late. She had already been sick for 2.5 weeks, and I was already behind the 8 ball when she showed up.
Well, thank you, Doc, and I really appreciate you taking time to be here. When I see you and think of your generation of the practice of medicine, I think of numerous family members in my family. You and Dr. Hagenboo, she described herself as a dying breed. Mm-hmm. And no one's given to hyperbole more than myself. But did you know they had to rewrite the news coverage? They had to retype it just a few seconds ago of your presentation here. As soon as you came out with hoot and holler to make a point, it transcended the king for the day.
Oh, it did?
I know that you don't truly aspire to be king for a day. I know that you don't want to put the jack in my jaw and pour that ivermectin down my throat. But you know what? That's what's going to be presented tomorrow for your testimony for public consumption.
Well, I'm glad.
I regret that, but because all of us understand where you're coming from. I admire and I appreciate your passion, and I thank you for being here.
Thank you, sir.
Yes, sir, and I want to follow it real quick before Senator from Greenville. When I heard that, I thought I was telling one of my neighbors was just like a grandpa. He was my best friend's grandpa. And he would tell us all the time, I don't give 2 hoots and a holler what you think. So I went back to my childhood days when you spoke that, and I was like, so anyway, I appreciated hearing that terminology. Thank you. Senator from Greenville, Senator Corbin.
Before you go, Doctor, I did just want to thank you for coming and testifying. You are an extremely brave individual. I know in my heart there are probably hundreds or thousands of doctors in South Carolina that are in your shoes that believe in it, or at least want to try it because they truly care for their patients, and they're just afraid to come forward for fear of losing their jobs. And I get that. Maybe they're young, they're married, got family and a home mortgage and a car payment. I get that. But maybe by you coming forward, others will brave up, for lack of a better word, and come forward too. Thank you.
Margie, did you have one more?
No.
Okay. Thank you, Doctor.
Thank you, sir. Thank you kindly.
Next up, we have Dr. Edward Simmer from DHEC.
Chairman Martin, Chairman Verdon, members of the subcommittee and the committee, good afternoon. Thank you for having us here today and the opportunity to participate in this very important hearing. Obviously last Wednesday, this subcommittee heard from a number of citizens of South Carolina, a number of heartbreaking stories of the effect of this devastating disease on the people of South Carolina. We certainly put our hearts go out to those folks and the many, many others like them. We know we've had more than 11,000 people in South Carolina now die from COVID-19, and that is an absolute tragedy. So what I'd like to do is talk a little bit today briefly about what DHEC's role is in helping South Carolina get through this pandemic, what we've done so far, what we are planning to do, and then certainly, of course, take your questions. I'd also like to introduce some folks I have with me today. I have our Public Health Officer, Dr. Brandon Traxler, and our State Epidemiologist. Dr. Bell. And also we have our legislative liaison, Scott Gillette, brand new, and Ron Aiken from our Media Affairs Office. So that's the team that I have with me here this afternoon who will be supporting me with this. You know, we've had over 800,000 cases of COVID-19 so far in South Carolina, and that number continues to rise every day. We still have over 3,000 cases per day. Over the last week, we've had over 28,000 cases. So we are still not in full control of COVID. COVID is still changing the way we live, making us wear masks, doing a number of things, you know, that make life difficult for the people of South Carolina. We've given, so far, over 10 million tests, as you've heard. We've given more than 4.5 million vaccines to the people of South Carolina, and right now we are at 51% fully vaccinated of those eligible and 59% who've gotten at least one dose. That's good, but it's not good enough. We are starting to make some progress. The numbers are starting to go up faster, but obviously we still have a lot more work to do before we can defeat this disease. In terms of DHEC's role, from coordinating the initial distribution of personal protective equipment when this first began in March of 2020, to building a statewide logistics network to ensure hospitals, pharmacies, individual providers can get the vaccine, can receive the monoclonal antibodies that we've discussed here. DHEC's role has been clear. Our job is to help save lives, to help prevent the spread of COVID, and to provide the very best guidance and recommendations to the people of South Carolina and to our leaders that we possibly can. And also to ensure, as I said, that access to high-quality care for COVID is available to every South Carolinian. Now, of course, we do not do that alone. We rely on many of our private partners, some of whom are sitting behind me right now, but our hospitals, our pharmacies, our individual providers, community groups that have helped with vaccination and other efforts have been crucial throughout this effort. But let me also be clear on what DHEC does not do. DHEC does not license physicians. DHEC does not tell physicians how to practice medicine. Now, we do license for controlled substance, that's true, and we do have some impact on how physicians prescribe controlled substances, things like fentanyl or some of the other things that we know are potential drugs of abuse. But none of that is being discussed here today, I don't believe. None of that has widely been discussed as a treatment for COVID-19. We don't punish physicians or patients for clinical decisions, nor do we determine what are acceptable uses of available medications, again, except for controlled substances. But what we do offer is the best evidence we possibly can, the best scientific evidence regarding what is effective, both prevention and treatment for COVID. And we, as I said, work to make sure that people of South Carolina have ready access to those effective treatments and prevention efforts. And let me just briefly talk about what we mean when we say evidence-based. We've heard a lot about studies, a box of them right there, actually. So let's talk a little bit about what it means to be evidence-based. We look for well-designed research, high-quality studies, relatively free of bias, that have been peer-reviewed, published in reputable journals. We also look to recommendations from organizations like the CDC and the National Institutes of Health, groups like the Cochrane Review, which was mentioned earlier, which is a group of experts who review various areas in medical science and make recommendations based on their review of the literature. We also look to professional societies like the American Academy of Pediatrics when we are making our recommendations. Now, for those who do get COVID, despite our best efforts to prevent it, whether vaccinated or not, there are safe, effective, evidence-based treatments that we recommend. Monoclonal antibodies is certainly one of those. You may know that as of the 13th of September, the federal government has changed how they distribute monoclonal antibodies. It formerly was hospitals or providers could order them directly from the federal government. Because there is a shortage of supply, they now require the state health agency, in this case DHEC, to allocate those, and we are actively doing that. We are working with our many different providers. We have over 60 monoclonal antibody sites available across the state of South Carolina, and we are working with them to make sure they all have an adequate supply to meet their patients' needs. We are working very hard to make sure every South Carolinian who can benefit from monoclonal antibodies knows about them and has access to them, and that the providers know about them and can access them and can send their patients to where they can get them. because monoclonal antibodies do work. They work when before the patient's hospitalized but is moderately ill, and they have been shown so far. Of the 35,000 South Carolinians who received monoclonal antibodies, we estimate that has avoided approximately 3,500 hospitalizations and about 350 deaths. So that's effective treatment. And we want to continue to use monoclonal antibodies and encourage their use. We recommend remdesivir, a medication that has been shown to be effective in reducing the effects of COVID-19 in hospitalized patients. Steroids also have a role, which you've heard some discussion about that. And then, of course, supportive care, things like oxygen, ventilators, for children, the ECMO that our pediatric colleagues mentioned. All of these are very important. I know we have representatives from the hospitals and the Medical Association here who can discuss some of that in more detail. Now, there's also a lot of treatments that have been proposed for COVID. Because COVID is in part an inflammatory disease, almost any inflammatory treatment has been considered. Some of those have been studied. Many of these have been marketed, but many of them are also not supported by the reliable evidence that I just discussed. We do not promote or recommend the use of those things that have not been shown to be effective by reliable evidence, and we actively discourage the use of those that have been found to be harmful. So, because of this, we have an educational page on our website, the DHEC website, scdhec.gov, that talks about giving people the best guidance about the effects of various different medications for COVID-19 and educating them on the potential risks. Now, this is not intended in any way to replace the physician-patient relationship. Obviously, as has been said, it needs to be a collaborative relationship between patient and doctor to make sure what treatment is right for that patient.
Dr. Simmer.
Yes, sir.
Can I pause you one real quick?
Yes.
Senator from Greenville, Senator Corbin has a question, and
Yes.
he didn't want to forget it, so he wanted to ask
Please
you
do.
now.
Yes, sir.
I try to take notes here, Dr. Simmer. Sometimes
Of course.
I take good notes and I can't read my handwriting. How about that?
We are likewise, sir.
Right. You said that you dissuaded practitioners from using certain drugs that you felt were harmful for COVID. Could you tell me what those are?
So, well, let me correct that a little bit, but I will tell you what they are. So we don't tell providers what to prescribe or not. We do put information on our website saying that that certain things have been shown to be potentially harmful, and we discourage their use. We don't stop a provider from doing that. We don't have any authority to punish a provider for doing that, so let me clarify that. But there has been some evidence of harm with hydroxychloroquine in patients with COVID-19, that it actually can be harmful in those cases. That's why it has largely been abandoned for use. It was used early on. There was some suggestion it might be useful, but as the studies have been done, and that's why it's so important to do the studies, it's actually been found that in some patients it's harmful. Something called silver colloidal solution was early on proposed as a treatment for COVID-19, and that too has been shown to be potentially harmful in many patients. So we do not recommend those. Many of the things that have been recommended are not necessarily effective, but also not probably all that harmful. So, for those sorts of things, and I would say ivermectin falls in that group. Ivermectin in the human dose. Now, unfortunately, some folks have gone out and used the animal form. If you use the animal form, yes, we've had a number of patients in our emergency rooms with severe side effects from ivermectin when they use the animal version of the drug. The human form is relatively safe, and we say that on our
Make a distinction
website.
between those two forms for me.
The dose, the amount. When you're giving ivermectin to a horse or a cow, and I don't know for sure what the dose is you give to a horse or a cow because I don't do that, but the dose of ivermectin that you would buy at an animal supply store would be much larger than what you'd give than would normally be prescribed to a human being.
Right, because it's dosed out based on a weight.
In part,
to
yes.
kilogram
Yeah,
ratio.
and obviously that's a much larger, heavier
Right, exactly.
animal.
So let me be clear. So ivermectin is on the list of medications that you're dissuading from use?
What our website says is that that ivermectin is not an evidence-based treatment. The evidence does not support its use. We don't dissuade people from using it. We simply say
What
that the
about
evidence.
this evidence that I presented earlier from these studies? What about those doctors presented as evidence from all over the world? Is that not good enough for you? What kind of evidence do you need?
We need reliable evidence from well-done studies. The one that you
Well,
mentioned.
other doctors would argue these are well-done studies.
And I would disagree with them, sir. And I will tell you why.
Based on what?
Based on the quality of the studies that have been done, based on the fact there have been a number of studies that have shown that ivermectin is not effective, There was a study, a review of the studies just recently in the Clinical Infectious Disease Journal. They did a review of a number of articles, research studies about ivermectin, and they found their finding was that the overall body of evidence does not support the use of ivermectin, does not show that it's effective. There are some small studies that say that it may have a small beneficial effect. There are other studies that say that it does not. I think the best answer we have right now is we don't know for sure. The current evidence does not support its use, and that is what we say. However,
So which study are you citing now? From what journal?
Clinical Infectious Disease.
And that's a standalone journal. That doesn't fall under something like the Lancet or something like that.
I'm not sure who owns that journal exactly, but it is an independent journal, yes. It may be owned by, many journals are published by publishing companies.
Okay, because a lot of those studies were retracted for false data being purposely put in them. You understand that?
Yes, many of the ivermectin, well, I won't say many. Some of the ivermectin studies have had problems with false data and have been retracted. That is true.
Why do you think that is? Why do you think doctors, that supposedly scientists, would put false data in? Why do you think that is?
I think you'd have to ask them that, sir. There's probably many different reasons. Some doctors do it because they want to find something. Some doctors are frankly greedy, I suppose. I think you'd have to look at each individual case. I don't think you can give a blanket answer.
I just wanted to clarify to the committee your position on, or DHEC's position on hydrochloroquine and ivermectin. I think you've made it clear, so thank you.
Yes, sir. So the one thing I would say is that there are 2 large studies of ivermectin ongoing right now. We do not have results yet. I'm certainly looking forward to those results. I think we'll see. I think those studies will give us a much better picture of if ivermectin has any benefit or not. And we will certainly report those results once we have them. And if it shows it's effective, we'll say that. And if it shows it's not effective, we'll say that too. So anyway, if I just wrapping up, one of the things I'll say is that there's lots of questions, as we've seen today, and there's lots of differing opinions. As your state health authority, we are available to all of you, to every member of the legislature, and several of you have already called on us and asked us for help with this. If you're hearing questions from your members, if you are looking at some journal articles and you're not quite sure, call us. We're happy to come over, meet with you, do it by phone, whatever you would like, but we are more than happy to walk you through the evidence, let you know, take a look at what you're hearing from your constituents, and help you understand that and understand the state of the science. So we are a resource for you, and I hope you will use us that way. Just in closing, what I will say is we continue to work very hard to help the people of South Carolina overcome this terrible disease. We do recommend vaccination. The best treatment is prevention. And I'm convinced that the very best treatment for COVID-19 is vaccination, because if you never get the disease, you don't need any of these treatments we're talking about. So we strongly encourage vaccine. We continue to strongly encourage vaccine. I think you probably have seen our ads. We've actually run now more than 150 million ads encouraging vaccination in South Carolina. I was actually surprised by that number too. But we are doing everything we can to make vaccines accessible. Just this month now, we're rolling out 25 mobile units that will be taking vaccines into communities, giving people the opportunity to be vaccinated if they wish, so that those who have problems with transportation or access will have that opportunity. So in closing, again, vaccination we strongly encourage, but there are a number of effective treatments for COVID-19 as well, and for those who get COVID, whether it's a breakthrough case for someone who's vaccinated or someone who's not yet been vaccinated, I think the good news is there are some effective treatments that our physicians, our providers have available, and we certainly encourage their use. And with that, I will close and take your questions.
Thank you, Dr. Zimmerman. There's going to be questions. I do have a question for you. Are you stating that vaccinated people cannot contract COVID or spread COVID?
No, sir, but they are at lower risk for getting COVID. But
Right.
they
I'm
can't.
talking about
But the risk is
contracting
lower.
or spreading to others.
It is possible, yes. If a vaccinated person has a breakthrough case, they can certainly transmit the disease to others, yes.
Thank you. Senator Corbin has a follow-up, then Senator Davis.
Thank you, Doctor. Looking throughout history, going back throughout history, how many years does it typically take to create a safe and effective vaccine?
It varies with the vaccine.
Typically, would you say the average is around 5 to 7 years?
I'd say 5 years, yes, sir.
Okay. And this vaccine was created in 5 or 6 months and rolled out, correct? somewhere?
Part, RNA, the technology behind it, the RNA technology has actually been in development for 10 years.
Well, I understand that, but vaccine technology's been out there for years too.
Yes, sir.
So you're touting a vaccine that was created in a hurry-up offense and saying that that's okay. Well, let me back up.
Yes, sir, I am.
I think I understand. You've already said it. Let me back up and say this. The swine flu vaccine that first came out.
Yes.
You remember that?
I do.
I think it was a Fort Moultrie, but anyway.
Well, let me say this. I'm too young to have remembered it, but I have read about it. Yes,
Given
sir.
to the soldiers, okay.
Yes.
Because at 27 deaths, they stopped that vaccine.
Yes.
And there's been upwards of 10,000 deaths from the COVID vaccine. And I think that number is grossly low because the reporting system is overwhelmed.
Actually, sir, that's not true.
Yeah, well, I got it.
That is not true.
I got it from the CDC website.
No, sir, you
Those
did not.
numbers.
What the CDC website says is that after receiving vaccine, people die. But 8,000 people die, or more than 8,000 people die in this country every day. So naturally, if some people get the vaccine, they will then subsequently die, not because of the
I can say
vaccine.
that about COVID. People die every day in this country, with and without COVID.
That's true.
That's not a proper analogy, in my opinion.
Well, then we disagree,
Well,
sir.
how many deaths from the vaccine is going to be acceptable? If we're up around 8 or 10,000, at what number of deaths from that vaccine are people going to say that's just acceptable, unacceptable? We're going to stop it.
I am aware of 3 deaths related to the vaccine. I think 3, considering what the vaccine prevents. There are 11,000 just South Carolinians, more than 11,000 South Carolinians who've died. The vaccine is a much, much safer alternative than not getting vaccinated and taking your chances.
Are
with
you
COVID.
telling me that only 3 South Carolinians have died from the vaccine?
Three individuals are known to have died from the vaccine nationwide. Now, I don't know the numbers for other countries.
Nationwide, only 3?
That's my understanding. Now, again.
So I don't know where you get your information from, but
Now, again,
the statistics I looked at.
Lots of,
were-
if you look at the vaccine, the VA-ERS, the thing that the CDC runs, yes, people do die after receiving the vaccine. But dying after receiving the vaccine doesn't mean you died because of the vaccine. Doesn't mean that the vaccine
with
caused you death.
COVID is different from dying from COVID, doctor. Wouldn't you agree?
It could be. It depends. Right? You could die with COVID from another cause. If you are a mild case of COVID and you have a heart attack, sure, you died with COVID, but,
But
not
that's
from
listed
COVID.
as a COVID death, correct?
Not necessarily, no, sir.
Well,
No. The coroner should mark down the primary cause of death. I mean, that's not really what we're here for, but the coroner should note the primary cause of death. If the primary cause of death was a heart attack, that's what the coroner should document.
well, that's not what I'm hearing from loved ones who have died from similar situations. But anyway, I've heard enough. Thank you.
Thank you. Senator Davis.
Dr. Simmer.
Yes, sir.
Start by saying that I'm a big proponent of the vaccines. Let's just get that out of the way. I think that's
Thank you.
the most effective way of preventing the spread of COVID. But let me ask you this question. Of the therapeutics that we've been talking about, and I generally they're monoclonal, hydrochloroquine, ivermectin. There may be others, but those are the ones that I've written down. Would you agree that the best person who is able to assess what a patient needs with therapeutics would be the attending physician who is making an in-person diagnosis, and that judgment should be irrespective of what conclusion DHEC has reached? Or would you say that a physician who, after examining a patient, and as Dr. Jackson said, considering that patient's circumstances and the evidence-based as that physician understands it, should not prescribe ivermectin because DHEC has dissuaded it?
Well, I think they should do it in coordination with their patient. So I think they should
Correct.
be talking to their patients early.
But I guess what
Yes.
I'm asking is, if DHEC is saying, we've done a meta-analysis of these studies,
Sure.
we don't think this is a good idea, but a physician with a patient making that in-person diagnosis reaches the conclusion that that's in the best interest of the patient, that physician should not feel constrained, should he or she, by what DHEC has determined?
I mean, I think they should consider what the evidence shows and the standard of care, but at the end, they have to make the decision that they think is best for their patient, yes.
So at the end of the day, and that's what I'm getting to, at
Yes,
the
sir.
end of the day, it's that relationship, which has been described as a sacred relationship,
Yeah.
whether it's shared or paternal, whatever the method might be, that relationship ought to be respected, honored, and empowered. Is that correct?
Yes.
Okay, thank you.
Thank you. I believe Senator McLeod had a question first, and then I'll come to you, Senator.
Thank you, Mr. Chair. I do have a brief question. So, Dr. Simmer, thank you for your testimony. I'm still trying to understand why, when we know that children under 12, and I get that we're not here to talk about children, but I'm a mom, so I am concerned about this. When we know that children under 12 are not eligible to receive the vaccine,
Yes.
they're not eligible to receive the monoclonal antibody treatment, and possibly some other therapeutic treatments that adults may receive. What is, DHEC has some statutory authority to intervene in cases, I believe, like this, where we are grappling with an epic public health crisis. What is your position? What are your thoughts about what that intervention looks like as it relates to our most vulnerable populations and this virus, when the legislature is already intervening by proviso and other ways to prevent school districts and other entities and individuals from keeping our most vulnerable population safe? What are your thoughts about what DHEC can and should be doing in this instance?
Well, I think DHEC can and should and generally is doing a number of things. Clearly, one way to protect our children is get adults vaccinated. If most adults are vaccinated, then there's fewer people to spread COVID to our children. So that's one piece, and we're doing that. And also, obviously, we encourage.
Can you come a little closer?
I'm sorry. Yes, I can. And obviously, we encourage parents who have children between the ages of 12 and 17 who are eligible for vaccination to have their children vaccinated too. That's another big piece of protecting children in schools. It's no secret that our agency recommends that schools require masks for everyone in the school. And we also understand that the legislature has prohibited schools from using funds for that purpose. We respect that. Now, having said that, we do believe the science shows that when every child and every person in a school wears a mask, the risk of transmission of COVID in that school is reduced. So that's what we believe the evidence shows, and there's good research that says that. And masks are safe for children to wear. There's lots of research that shows that masking children does not harm children. Having said that, you're right. We do have public health order authority. We could order masks in schools.
Why aren't you?
Because for two reasons. Number one, I do not believe that it's possible to write a statewide order that would apply appropriately to every school district. Every school district is different. The conditions in every school district are different. So it would be very difficult to, if not impossible, to write an order that would appropriately apply everywhere. Number two is the enforcement piece. We respect the law. We have to. And the law says that school districts may not use any state funds to enforce a requirement for masks. I cannot think of any other good way to enforce a public health order that I would issue. If I can't enforce an order, I shouldn't issue the order. If I can't or my team cannot identify an effective enforcement mechanism, we shouldn't do that. Now, we have said that we would consider, if an individual school district approached us and we were convinced that the only way to help them require masks in schools was to issue that order, we would consider it. Not that we would do it, but we would consider it. But it would have to be the last resort. We think there are other mechanisms to achieve that goal that would be more effective. I think the Supreme Court has suggested some of those, Supreme Court of South Carolina. And so, we certainly would be willing to work, and we do work with many school districts across the state every day. And if a school district came to us and we thought the only way to protect the children in that school was a public health order, we would certainly very seriously consider that. But we have not been presented with that situation thus far.
Okay, briefly, I hear you. But if you're going to take an individual school approach or an individual school district approach, would DHEC not have the authority to do whatever is necessary to prevent further spread and possible exposures and deaths as a result of this virus? I mean, when I look at the number of students in different school districts, and I think we're on a cycle, who knows how long this is going to go on, but, you know, to see that in Aiken and Pickens and, you know, all these other school districts that have thousands of students who are quarantined, many of whom are not eligible or, you know, at an age where they can be vaccinated. Why have a law? And I know that I'm not asking you that question, I'm saying that rhetorically, but why have a law if DHEC's hands are tied and you can't do anything about protecting our children? I mean, we are, of course, giving our parents the freedom to decide not only their child's fate, but their child's classmates' fate and their child's classmates' family's fate. So can DHEC not do anything?
Well, and I will say, we hear from many, many parents every day that would like us to do more, that want their children to attend school.
You have the authority to do more. My question is, why aren't you doing more?
I think it comes back to the same issue. We don't have an effective enforcement mechanism. And I think schools actually have some of those tools already without a public health order. Public health order should be the last resort. I think that's what the law intends, is that when there's no other way to protect the public health, we issue a public health order. So, for example, if there's someone with active tuberculosis walking around spreading tuberculosis, we issue a quarantine order, of course.
Right.
Right? And we would do that.
What is different about this?
Well, again, because I think, you know, we've seen several school districts now have mask requirements using non-school officials to enforce them. We'll see if those are legally supportable. We'll see if they work. We don't know. But none of that required a public health order.
But that's not DHEC. I'm saying DHEC has the statutory authority to do, and this is my last, but DHEC does have the statutory authority to act and intervene on those students' behalf or any, you know, South Carolinians' behalf when the state is not, you know, is allowing a public health crisis like we're currently in to continue to fester. So I'm truly not, I'm trying to understand, but I truly don't understand why this is any different from tuberculosis or any other communicable and contagious disease, especially when we see now that it is killing our children and making them sicker than ever, and our hospitals are full, our ICUs are full, our children's hospitals. So, you know, we're here talking about treatments, but it's almost like we're putting a Band-Aid on the real issues and working around what we obviously have not been able to address. And so I really wanted to hear from you what DHEC can do. I mean, I know what DHEC believes. I see your guidelines and recommendations, but if South Carolinians were following them as they should be, we would have a much higher vaccination rate. We would have a much lower death rate. And so I'm not asking to be rude or, you know, to insist on the answer that I'm looking for. I'm just looking for an answer.
No, and it's a fair question, so absolutely. And again, I think the challenge for us is, and the challenge for me, since I'm the one in the end who has to make that decision, is that at this point in time, I don't see that issuing a public health order would for that particular issue at least, would achieve improving the health of the people of South Carolina, and specifically the children of South Carolina, very importantly, that we couldn't achieve in other ways.
Thank you. I just want to, we got a couple more members that wanted to talk, but I just want to let the room know that we've gone kind of way beyond our time, allotted time. After you, Dr. Simmer, we're going to hear from the Board of Medical Examiners. We're going to hear from the South Carolina Medical Association, then we're going to hear from the Hospital Association, and then we're going to be done for the day. So, Senator Hutto, you had a question?
I did, thank you. What, if any, is DHEC's role in informing, instructing, or telling doctors what they can and cannot do as far as prescriptions to their patients? Do you have a role in that process?
We educate, certainly just as we educate the public, we educate providers as well about public health issues, including COVID. We do not, except for controlled substances, and we do license physicians to prescribe controlled substances. Therefore, we do have a role there to monitor the prescription of controlled substances, make sure that they are being used appropriately, that, unfortunately we have had, rarely, thankfully, but rarely we've had providers who've been selling prescriptions for controlled substances. DHEC does have a role to intervene in those cases. But for non-controlled substances, which includes everything we're discussing here, DHEC does not have any role in controlling what physicians prescribe, what pharmacies provide. That is outside of our purview completely.
So would it be fair to say that DHEC has done nothing as it relates to these COVID drugs to prevent doctors from prescribing what they thought was best for their patient?
Yes, sir, that's correct.
Would it be fair to say that DHEC has done nothing to prevent pharmacists from filling whatever prescriptions they deemed valid?
Yes, sir.
Okay, thank you.
Thank you. Senator Scott.
Thank you so much, and thank you for all the hard work you and your staff and team is doing over there. Has any thought been given, and maybe y'all are already doing this, bringing the healthcare community together, the hospitals, the examiners, so forth and so on, doctors and others, in some type of support group to have some open dialogue? Because it appears that there are a lot of things out there being said that may not be true, and some might be true. I don't know. And I know that you've got your own fight in trying to control this epidemic, but having some real dialogue, because other than I think in what I've seen in the last couple of meetings, this is probably the only dialogue the state may have had, other than when the legislature call y'all together to talk about it, but some open dialogue to help get folk on the same page, because it appeared that DHEC is here, the hospitals might be here, we're all in the same fight, but there's no real dialogue to try to get us where we need to be. The object of the game is to win.
Of course.
And win with everybody understanding what we've got to do. And I think it'll show the community as a whole that we're all together trying to fix the problem. What's your idea in terms of what we might be able to do, and I'm once a month or something like that, what we might be able to do to try to get these discussions a little bit more under control in terms of a lot of false information that's out there, some that might be a little true but not all the way true, which creates more chaos than anything else.
So I think that's an excellent suggestion, Senator. We do regularly talk with both the Hospital Association and the Medical Association. Just about a week ago, Dr. Traxler and I met with the leadership of the Family Practice Group here in South Carolina. So we are working with that. I've gone out and met with a number of community groups, talked with individual hospital leaders, both on the administrative and on the clinical side. But there's always room for more of that. And I think we can always do better with communicating, sharing ideas, learning from each other. So absolutely, I will take that back and we will work on that.
Do you think you could get them to convene representatives from the various communities, be able to share what's out there? I think the committee did a good job in identifying folk who had different ideas and different viewpoints, but it's only shared in a small group. The others who want to participate can do it by Zoom or other ways that you want to put it out there, but at least some ongoing dialogue so we can clear up some of what's out there. Thank you, too.
I think that's a good suggestion. Thank you.
Senator Burton.
Thank you, Mr. Chairman. Dr. Simmer, certainly wouldn't want you or your team to not hear a point of expression of, and I'll just echo the Senator from Richland, appreciation for the indefatigable commitment that you and your team have made to the public health of South Carolina 20 months in, and not to mention everything else that goes on in the state within your purview on a daily basis. So, but I am I want to go back to the first moments of your presentation, and if you would elaborate on the bottleneck of the monoclonal antibodies and their availability, and then maybe project what the future looks like in regard to the bottleneck availability, and maybe even paint a picture for us of how DHEC will be a communicative entity for the various folks that can benefit. I know you're not going to go out on the radio like you're doing with the vaccine.
Right.
And
Well,
say,
you
hey,
might, actually.
well, I don't know. I want to know. I need a feel, because right now the genesis of this group's work really goes back to the fear that, especially that therapeutic, and then of course we've talked about others as well, but the real initiative for the meeting here a week ago, and then today especially, that monoclonal antibody availability. Take us beyond that bottleneck. Don't leave me at the bottleneck.
Yes, sir. All right. So, there has certainly been an increased demand for monoclonal antibodies over the past about month, perhaps 2 months, nationwide. And until recently, the supply was able to keep up with the demand. The supply has been relatively stable for a period of time. There's a certain amount being manufactured by the manufacturers, and that hasn't changed particularly. There are 3 different monoclonal antibodies currently available on the market, 2 of which are only supplied through the federal government, and they buy essentially the entire supply. And 1 of which is that providers can purchase independently of the federal government. Now, the ones that come from the federal government are at no cost. The one that you can buy directly is $21,000 per dose, roughly. So it's very expensive. At this point, because of the increased demand, it has now exceeded the supply. To give you an example, we had 13,000 orders pending across the state when hospitals were ordering directly. The recent allocation we got from the government was 4,465 doses, obviously not close to 13,000. Now, the good news is that we actually are using, at that point, about 5,000 doses per week. We were able to reallocate because some of our hospitals had a little bit of a surplus. For example, MUSC helped us out. They had a little bit more than they needed for the week, so we were able to redistribute that to some other facilities that were short. So we have basically been able to cover so far. But it has been, our staff has been driving around the middle of the night, driving doses from one place to another to make sure places had it. And as you said, our staff is amazing, and I greatly appreciate them. They're the ones that make this happen, along with all the providers who are giving these out and making sure patients have access to them. The problem is, at this point, we don't anticipate an increase in supply in the near future, is what we're hearing from the federal government, at least for a few more weeks. So we're continuing to work very carefully. We have an allocation system that we have shared with all of our providers. It's publicly available if anyone wants to see. We want to be very transparent about how we're deciding which provider gets how many doses. We are seeing a small increase this week. That's good news. We think we're going to still have enough, but it's going to be close. And let me check with my team. I think that's where we still are at, though, that we have enough right now that we should be able to meet the demand, but there won't be a lot of cushion. Certainly the manufacturers are trying to ramp up manufacturing. I think if you go out 4 to 6 weeks, to answer your question, sir, we will see an increase in supply, and I think this bottleneck will relax quite a bit. But it is going to be 4 to 6 weeks. So right now, our job as the state health agency is to make sure we're getting the doses to where they're most needed, where the patients are needing them. Right now, if you look at the map, we have about 60 providers that provide them across the state. But there are some areas like along the Georgia border where there aren't very many providers. So certainly our long-term goal is to increase the number of providers so that nobody has to drive more than a short distance to access monoclonal antibodies. The other piece of that, of course, is the education piece, right? We just recently issued a joint statement with the governor encouraging their use, both for patients and providers. And we are going to be going out with some media campaign. I'm working with my media team now that we will be advertising. We already actually have some advertisements out there encouraging the use of monoclonal antibodies. We also are trying to educate folks, make sure you're getting seen early because these are for folks who aren't hospitalized yet. So, if you wait too long, and 10 days, so, from the start of symptoms. So if you wait too long, it doesn't work anymore. So we are encouraging folks, get seen early, call your doctor early if you think you might have it. If you have a positive test and even if your symptoms are mild, call. Then you and your doctor can determine if that's the right treatment for you. But so we are going to be ramping up a bigger education campaign than we've had so far, encouraging folks to use them, encouraging providers to use them, and also helping providers know, hey, if I don't provide it myself, where can I send my patient to go get it and get a reliable supply? So that's what we're working on now. I think 4 to 6 weeks we'll be in a better place than we are now. Right now, as I say, I think we are meeting the demand, barely. It's a lot of work. I hope that we will be able to continue to do that. I think based on the numbers we're seeing of overall cases, that should be true. But every week I take a look at the numbers and I worry a little bit.
Thank you, Dr. Sinnerman. One final question, then we're
Yes,
going
sir.
to move on to the next person. Does DHEC have any policies, or are they issuing any directives that would prevent a doctor like the one that testified from Spartanburg
Yes.
from prescribing any therapeutic, including ivermectin?
Nothing for COVID-19. Again, we do have some policies on controlled substances, but for what we're talking about here, no, sir.
Okay, thank you, and I appreciate you being here today.
Thank you, sir.
And I also want to tell you, I know I put together a big email with a lot of constituent concerns, and I know it might have rambled a little bit because it was a lot of material that I received. I do appreciate you taking the time to answer the email. I do have probably some follow-up questions there, but now's not the time. But I did want to personally thank you for putting the time and effort that you did into actually responding and not just telling me thanks, but no thanks. I really appreciate that. So thank you for being here.
That's what we're here for, sir, and look forward to your questions.
All right. Next up is Dr. Ann Cook from the Board of Medical Examiners. And thank you for being here.
I'm height challenged.
Thank everybody in the room for still being here. I know it's gone longer than we expected, but thank you.
Thank you for the invitation to appear before you here today as a representative of the Medical Board. My name is Ann Cook. Currently, I'm president of the South Carolina Medical Board, where I've served in various capacities for the last 8 years. I'm also a practicing internal medicine physician, working in Anderson with the ANMED Family Medicine Residency. I care for patients both on the inpatient and outpatient side, and have been very active in the care of COVID patients during this time. I did have the opportunity to review the testimony presented last week and have tried to prepare my remarks somewhat to address some of the concerns raised there. I also appreciated from watching that meeting each of your comments and questions, and that you're truly engaged and wanting to do the right things to put this pandemic behind us. I also would hope that it's okay with you if in my presentation I switch hats from my Board of Medical Examiners hat to my physician hat to provide a little bit of what I see as some insight about the treatment of COVID. I must first say that I'm here as a representative of the board, but the board has not actually met specifically to address these issues. We have not had an in-person board meeting for some time.
And on the issues of therapeutics,
On
that's
the
what you're
issues
going
of
to talk about
therapeutics,
today.
right,
That's really
right,
all we're here to,
right,
okay,
right.
thank you.
Well, the question that I would think you're asking of me is, we're hearing a lot of stuff about people saying they can't prescribe because they're going to lose their license.
Yes.
And I want to lay that to rest.
Right, that's what we
Okay?
want to hear. Thank
Right.
you.
The medical board is a complaint-driven board, which means that we don't go out looking for trouble. And in fact, we have been criticized in the national press by not being aggressive enough to go seeking out bad doctors and finding them where they are. We are completely complaint-driven. Our physicians have adequate due process, and it's probably taken me my 8 years on the board to figure out what all those steps are. Since I'm not an attorney, I don't understand all of that entirely. But there's a lot of due process. There's a lot of room for physicians to argue their case if they have problems. We do our best to rehabilitate physicians when we can. We see a lot of physicians who have difficulty with substance abuse and mental health problems that we try to, help when we can. But unfortunately, there are times that because of the safety of the public, we have to sanction and remove some physicians from practice. That is never a fun thing to do. We always do that with lots of professionalism, with lots of attention to detail, I think, and we meet. We have very long meetings. The folks at LLR will tell you that we meet sometimes from 8 o'clock in the morning till 10 o'clock at night, trying to get it right to protect the health and safety of our citizens. We always ask, does this physician pose a risk to the public? Is this physician providing practice that is safe for our citizens? And those are our marching orders, and they will continue to be. During the pandemic, I think that our board has been very responsive to the public health need by trying to expedite licensing and do the things that we could to raise some restrictions from practice, specifically with regard to telemedicine, to address some of the opioid crisis and that sort of thing. I will say that as of today, I have received no knowledge that any physician, well, I know that no physician has been sanctioned, no physician has come before the board with any complaints related to prescribing or the care of COVID patients. Now that, whether complaints come later is up to the public, because that's where we get our complaints from. And as we do have folks from the pharmacy board here today as well. We did issue some guidance early on in the pandemic because we were seeing some of these supply side issues with hydroxychloroquine, and frankly seeing a lot of doctors writing prescriptions for family members and others that weren't necessarily their patients for hydroxychloroquine and azithromycin. Those medications, and we can talk about individual medications, but those medications do carry significant risk, and we issued a joint advisory opinion that basically said you should not prescribe for people who are not your patients, and you need to take into consideration some of these supply side issues for people with lupus, et cetera, who may actually need those medications. That guidance actually expired with the emergency declaration expiration as well. But I'll say again, there has been no discipline from this board to physicians with prescribing, with their prescribing practices in this pandemic. If I can kind of take a sidestep, because I don't know what may come before us. So I don't want to prejudge or say I will or won't, I can't speak for the board in that regard. What I can tell you, I can sort of lay out what the board has done in prior cases that I think would show some similarities to this. We had a complaint against a physician by a family member of a patient who went to this doctor to receive vitamin C infusions for their cancer. The family members were upset that the patient didn't follow through with their oncologist and their surgeon for treatment of their cancer. The patient decided to go to this doctor who did more holistic types of treatments. And again, as we talked about with joint decision-making, shared decision-making, decided to take this route of therapy. Her family wasn't happy with that, but the patient and the physician arrived at this treatment plan. We did not feel that there was any violation of the Medical Practice Act in that. There are some who would say vitamin C is not effective for treating cancer. There's no evidence that it is effective for treating cancer, but we didn't feel that that was anything that violated the Medical Practice Act. It was done with a patient and a doctor sitting down and coming up with a treatment plan. The doctor didn't make claims that that vitamin C would cure the patient. The doctor wasn't advertising with billboards, my vitamin C infusion will cure you. So there was not what we felt like was misinformation, disinformation, that sort of thing. On the other hand, we had a physician who believed, and I think we have to be real careful about using the word belief versus think, because I think that there's data and there's information and there are things that you can learn from reading and studying that actually become facts that you can think and know to be true. There are other things that we may, by our experience, believe to be true. This physician believed that high-dose Neurontin, gabapentin, I don't know if you're familiar with that, but it's a drug we use mostly for peripheral neuropathy. he believed that very high-dose Neurontin was a very good treatment for resistant asthma. And he was giving patients what I would consider a lethal dose of Neurontin for the treatment of that. It was certainly being given in dosages that were not conducive with a patient being able to be functional and drive, for instance, because it does have sedative effects. He had done a study in his office, and he had wonderful results from his study that he published on the internet that patients read and they believed. It was bogus. And there was potential harm and potential death even from patients being impaired taking this medication. We did sanction that physician severely. And so I think that's kind of where we are. I think we hold the doctor-patient relationship in utmost respect. We realize that that there are lots of things we negotiate with our patients. We're all physicians on the board, and we do our best to negotiate with patients every day. I truly have every confidence that our board, with the current system in place, would be a faithful administrator of our laws, and that the commitment we all have to patient safety on the board would have us approach any complaints appropriately, fairly, and with good reason to try to come to any adjudication of complaints we may have. And again, I'll say again, we have issued no sanctions with regard, no letters of caution, no nothing with regard to how physicians are treating patients with COVID at this time.
Thank you, Dr. Cook. Senator Verdon, Senator from Lawrence.
Thank you, Mr. Chairman.
I'm sorry, I wasn't finished. I'm sorry, is that okay? May I continue?
Ma'am.
May I continue?
Only if he wants to yield his question.
Okay.
I recognize, I mean.
Okay. Okay. I would, let's see. I do want to, because we're talking about treatments as well here today. And I am a practicing internist who has taken care of very sick patients in the hospital setting. Just got off of our surge team last week where we are just drowning in patients. I would reiterate what DHEC has said about the use of monoclonal antibodies and some of our frustrations that I heard from the testimony last week about the bottleneck with monoclonal antibody infusions. They are life-saving, and I think anything that can be done to, from your side to help alleviate that bottleneck would be wonderful. As far as some of the other treatments that are out there, you know, it has gotten so rabid and political, and everybody seems to be hunkering in on a various side. But what I would say is that if reason with me here a little bit and try to understand why it is that you may have the CDC and NIH and those saying things that are counter to what you're hearing these doctors testify to here today. Because doctors as well as lay people can be a little bamboozled at times by data that gets thrown at them. If you take 100 patients with COVID, just try to think through this with me. If you take 100 patients with COVID, 80% of them are going to do just fine. A lot of them get real sick at home. They're going to feel like they've had the worst flu they've ever had, and they're going to think they're dying, but their oxygen levels don't drop, and over time, they begin to get better. A certain percentage do not. 1 to 2% of people die. And even with our working as hard as we can in the hospital setting, the folks who get to us in the hospital are in that group of folks who are, many of them, not going to do well. But if 85 of those 100 people who get COVID are going to do okay anyway, then I can tell them, here, take this chocolate bar. I give those 100 people a chocolate bar, and 85 of them are going to think that chocolate bar made their COVID better. Those are the kinds of numbers we're dealing with when we're trying to figure out what works to improve the care of COVID patients. So it's not that one person's lying to you here and another person is trying to make money off of other medicine. It's that we're trying to get the science right. And that's not always easy to do. If I told you we had a drug that 70% of the time would prevent COVID, and almost always prevent death from COVID unless you had other underlying conditions, I think we'd jump all over that, wouldn't we? That's what the vaccine is. And so I get, we need to throw everything at this. I don't have a problem with people prescribing ivermectin. I don't have a problem with people trying all sorts of things. I've been taking vitamin D since this thing started. But my problem is that I have patients who say, I just want to do this. I just want to do, they're self-prescribing, they're self-treating, they just want me to come write their prescriptions for them. I just want to take ivermectin. I don't want to take that shot. And when you find that uses of these medications that are unproven get used in place of the vaccine with some sort of false security in them, then I think we're treading on dangerous ground. And so I would ask that we do whatever we can, and this is as a personal physician who has been just watching patients die in the hospital every day who tell me, I wish I'd have gotten that vaccine. 90% of our patients are unvaccinated in our hospital. Half of our hospital is filled with COVID patients now. Other patients can't get into the emergency room because of it. We need to do anything we can to get rid of vaccine hesitancy and get this behind us. We have never eradicated a virus in the world with the medication. That's never been done. It's only ever been done with vaccines. Why do we not have polio and smallpox? It's vaccines. And, the people who don't take the vaccine tell me, well, I'm not really going to get that sick. They don't seem to have bought into the responsibility side of things. And, who else they might make ill, their children, their grandparents, who else they might make ill by not taking care of themselves as well as they should. Every day we have laws in this country to enhance personal responsibility. We have laws against smoking indoors. We have laws against smoking on airplanes, all of those sorts of things. You have to wear seat belts. You have to obey stop signs. Those things are a matter of personal responsibility to each other. And so I ask that, please, let's quit getting around the edges with ivermectin and this and that and the other thing, and do what we know works, and do the best we can for the citizens of our state to put this darn thing in our rearview mirror. It's awful. It is gut-wrenching in the hospital every day. Gut-wrenching.
Thank you. I have one question for you before Senator from Lawrence. Would you treat a vaccinated patient any different than an unvaccinated patient as far as treatments go that you felt might help them?
No, sir.
Thank you. Senator Verdon.
Thank you so much for your commitment to your patients and your service to the state on the board. Your testimony is compelling, and it hit me just a few seconds ago that we must have a severe, I don't know the percentage, but we must have a severe dearth of actual doctor-patient relationships. It's the only thing I can gather, deduce. You're absolutely right. If I was a physician, I wouldn't want somebody who is prostrate or someone who's helpless coming to me and dictating the terms. That's not shared decision-making.
Right.
That's consumerism.
Right.
As bad as paternalism. But if I was in Anderson or anywhere else and you counseled me personally, I would embrace you with a strong grip as opposed to so much testimony I hear from my constituents is that they have a general resistance toward the current director of infectious disease and allergies. He's not real to them, you are. And to encourage that theme again for what we've been on, getting doctors and patients together. Thank you for your work. Let me just ask one follow-up question on the board. So the board has a well, you said all physicians. You do not have consumer advocacy?
We are supposed to. We have had a hard time filling those positions.
Okay.
And
I used to have an aversion to that.
Yeah.
Senator Hutto over there can tell you, we went round and round about this 20 years ago. But
I wish we did. The way the statute is written, people who fill that role can have no connection with any physician, which I'm sure made sense in writing the law, but it's also sort of hard to find somebody who's not a physician, who doesn't have physicians in the family or whatever, who's interested in serving on the board.
Yeah.
So it kind of gets a little bit of a catch-22.
LLR serves as your gatekeeper.
Mhm.
They winnow through, well, you have investigative processes,
Right.
and then you have the next step. Can you say definitively that LLR has not been in receipt of, you may not be able to, in receipt of complaint that has not made it back down?
It hasn't made it to me, and, they really, in general, part of that due process thing is that we don't hear about things
Right.
until they come to us. Unless, occasionally we have to do a temporary suspension of a doctor or something. I've done nothing along those lines.
Okay. Thank you, Mr. Chairman.
Thank you. Senator Hutto.
One thing thank you for being here. One thing I wanted to clarify is the doctor that you gave in the example, are you saying that the report he put on the internet was false, or the information in the report was false?
There's no way that his
He didn't do the
information was
study?
accurate. I think he did some study, but and of course it wasn't peer reviewed and that kind of thing. But the public doesn't discriminate. If it looks like you've got a good flashy looking article on nice paper, it looks like it's real.
All right, so I heard you say you haven't disciplined anybody yet for prescribing anything that they thought was effective for COVID. Have you threatened any doctors that if they do anything, that they're going to be disciplined?
Absolutely not.
Because we've heard this hearsay testimony that people have been saying, well, the doctors are scared to do it because they think they're going to get, y'all don't call it disbarred, but
Yeah.
get your license
Yeah.
taken away. But you're saying that has not happened. Y'all have not done that.
That has not happened. I do have a theory about, not all, because I know there have been some testimony here from doctors who would argue this, but sometimes in trying to maintain that doctor-patient relationship, I don't want to say that we're not totally straightforward, but for instance, when a patient comes to me demanding narcotics,
Well, it's easy to say the medical board won't let me do that.
Right, yes. Easier to say the medical board won't let me do that than to take the time it would take to say, or to get in the argument about ivermectin or whatever.
Right.
So I suspect that there's some of that out there in some of the stories that you're hearing.
All right, now let me ask you this next thing. We've heard some issues or complaints about pharmacists not filling doctors' orders. What is the proper role between a doctor and a pharmacist? If you determine that ivermectin or anything else is proper for your patient and you write that prescription, do you have an expectation that a pharmacist licensed in South Carolina will fill that?
I do. I also have an expectation that, and it's not unusual with these medications and others, that if they see something that doesn't look right to them, then they call to confirm.
Confirm, right.
But I don't know, and we have the representation from the pharmacy board here as well who may want to speak to that, but I can't say that I've ever had a prescription denied me, but I don't write for ivermectin either, but I don't know.
I understand. But your expectation is that if you write a prescription, or I guess now you e-prescribe for the most part, that when it goes to the pharmacy, one or two things will happen. It's going to be filled as prescribed, or you're going to get a phone call from the pharmacist questioning whether or not to fill it. And y'all have some discussion about
Right.
that, and you may change the dosage or something. But ultimately, as far as you know, they're getting
Right,
filled.
right.
Okay. Thank you.
Thank you. Let me just, I want to follow up to that, Senator Scott, and then I'll get to you. But real quick, a phone call could come, like a doctor, you could get in a hurry, you could type a number, you could type a 4 instead of a 2, maybe.
Right.
The pharmacist could call and say, wait a minute, this is a 27-year-old person, they should only get 200 milligrams instead of
Right.
400. And they pick up that's kind of a check and balance
Right,
too, right?
right.
So
It's a
if they call
safety.
you wouldn't be offended if they said, did you mean 400? Oh, gosh, no, I meant 200.
No, I say thank you.
But how many, that happens aside from the COVID debate, that happens on a regular basis, right? I mean, not a regular basis, but sometimes mistakes
Right.
or errors in the prescription could get maybe
Yeah.
in a new.
Less so now that we don't handwrite things that they can't read.
Right,
so.
but before, if somebody thought it was a 4, couldn't tell if it was a 4 or 3, I know they make fun of doctors' handwriting.
Right.
You know, I feel like I have the handwriting of a doctor. But anyway, I just wanted to check. So that wouldn't be uncommon to get a call like that?
No,
Okay,
no.
thank you. Senator from Richland, Senator Scott.
Well, thank you. I want to just kind of piggyback off what you had. Let's suppose the 4 is a 4, and the pharmacist refused to fill it. Is there recourse against the pharmacist?
Again, I might
I'll
need
wait
to,
on them.
I might want to
I'll wait
defer
on
to
them,
them
but-
on that, but in general, I can't say that I've ever had a situation where maybe it was a little out of normal prescribing that once I explained it to the pharmacist, they had a problem with it. Where you might see that most is in the setting of controlled substances,
Yes.
where they may see something on the database that worries them that maybe I didn't see or whatever.
Because I've heard the testimony too, and I'm trying to make sure the testimony was a true testimony, or somebody just said something, or it was incomplete, like the senator from Orangeburg
Right.
said, or the pharmacist took it upon himself or herself to decide what they were going to fill or not fulfill, and whether or not they violate the law in doing it. And if it is, what is the recourse against it? If you can't answer it, I'll wait till the
Yeah,
pharmacist
I
board
would
comes
defer
up
that to
and let
pharmacists.
them answer it. Thank you so much.
Thank you.
Thank you. And thank you, Dr. Cook, for
Thank
being
you.
here today.
All right.
Next up is Dr. John Ropp with the South Carolina Medical Association. I hope I didn't mess that up. I may have.
No, sir, that was perfect.
Oh, thank you.
Chairman Martin, Chairman Verdon, and members of the Senate Medical Affairs Committee, good afternoon, and thank you for allowing me to testify today. My name is Dr. John Ropp, and I'm a family medicine, hospice, and palliative care physician in Hartsville. I've been a South Carolina licensed physician for 20 years. I currently serve as the president of the South Carolina Medical Association. I've reviewed the public testimony from last week's Senate Medical Affairs meeting, and my remarks today are made as a practicing physician and on behalf of the South Carolina Medical Association.
Sir, did you say not on behalf or on behalf?
On behalf.
You're on behalf. Okay, thank you.
Yep. All physicians share in the grief and the frustration of the members of the public who testified last week. We send our condolences to those who have lost family members and whose lives have been forever changed because of this virus. In my own practice, even though I no longer see patients in a hospital, we care for many who have suffered greatly, and they look to me to help them make decisions about COVID prevention, treatment, and follow-up after some have become very ill and had to be admitted to the hospital. Our patients have real problems, and we want the best for them. Like us, they are looking for answers and hope that new treatments and new ways of dealing with COVID will help them and their families. 3 sentiments expressed in last week's testimony stood out to me, and I would like to address each of them briefly. First, I agree that physicians should be allowed to practice in the way that they believe is in their patients' best interest. What sets physicians apart from other providers, systems of health care, and oversight bodies is our knowledge, training, experience, and understanding of disease processes, therapies, and most importantly, patients themselves. No institution, including government boards, departments, regulatory bodies, associations, or others, should unnecessarily interfere with core tenets of the physician-patient relationship. Of course, there are necessary limits on this relationship that will be respected, such as the law, evidence-based guidelines, peer review, and lawsuits. However, no matter who employs a physician, the physician-patient relationship must allow for freedom of practice. A second issue raised last week concerned federal and state interference with specific treatments for COVID. This has not been an issue in my private practice, nor has the SCMA been contacted by any physician members that have either had their practice or license threatened for offering or prescribing any particular treatment for COVID. The prescribing of FDA-approved medications being used off-label is not new, and as evidence is gathered, changes in prescribing do and should occur as with any treatment for a given disease process. Guidance from oversight and regulatory bodies is helpful, but as evidence and provider experience grows, no guidelines ultimately dictate whether a physician does or does not prescribe a treatment. The actions of the physician, again, is determined by proper judgment exercised within an informed patient-physician relationship. Recently, DHEC issued guidance regarding the use of hydroxychloroquine and ivermectin for preventing or treating COVID-19, but nothing in their guidance prevents providers from prescribing either one of these. Whether certain hospital systems have protocols preventing their doctors or pharmacies from prescribing these or other drugs for treatment of COVID, I do not know. But as an independent physician, no limits have been placed on me and my practice and my ability to prescribe what I consider best for my patients. The third important issue raised last week is the notion that patients have the right to demand certain treatments. Thankfully, I have never had this type of interaction with my patients. Physicians, however, are ultimately responsible for the prescribed treatment. And if we do not follow the standard of care, we should expect harm to occur and adverse actions as a result. The physician-patient relationship is one of mutual respect, care, and concern. Physicians listen to patients, understand their fears, their own concerns and wishes, and then decide with them the best course of treatment. There is no demand on either side. I appreciate the committee's time today and for allowing me to speak on such an important topic. One other thing I have noticed mentioned here throughout the day so far has been that of independent practice and decision-making. The Medical Association would welcome further conversation concerning that and how we can help any legislative body grapple with that, because it's a huge issue, whether you're talking about CON, whether you're talking about different payment methods and contracting, sites of service reductions, or non-competes. So with those, I'll take any questions.
Thank you. Does anybody have any questions?
Chairman.
We'll strike that from the record. Senator from Orangeburg.
Doctor, how many members do y'all have?
In the Medical Association, about 5,000.
Okay. And to your knowledge, none of them have reported to you that they have had any restrictions placed on them as far as treating patients?
As of this time, no physician members have contacted the association with those concerns.
All right. Now, as to the fact that the difference between an independent practice and then working for a hospital system, sometimes there are protocols or guidelines placed on doctors within the hospital setting because that's just the rules of their employer, correct?
That would be in that case.
Yes. And there's nothing really wrong with that either. I mean, that's just the way that it's the doctors practice. Some doctors practice within a hospital setting and some practice independently. If you practice independently, you're your own boss. If you practice in the hospital setting, the hospital's your boss.
Certainly.
And if they have certain guidelines, they just do. And that there's nothing wrong with that. It's just different, right?
It's just different.
Okay. Thank you.
Thank you. Senator Verdon.
In all seriousness, Dr. Ropp, thank you. And whether it's CON or whether it's COVID, I want to make sure I'm not misunderstood today. The highest place I want the medical profession is on that pedestal right up there with the priest and the minister. And taking care of our constituency who is seeking to maintain collaboration. The term of collaboration. I've got a colleague right here who told me that if we don't see the genesis of the Medical Association working more cooperatively, more communication taking place, he's going to do it himself. So everyone is experiencing and feeling the exact same pressure points. And it's long, it's tedious, it's laborious. There's so many different perspectives in this room, so many different fields of service. But I truly believe you're president of the Medical Association. I told Dr. Cook that her trust and confidence building for me in a few minutes was compelling. The doctors that are aggressively operating in outside the lines, so to speak, of the position papers and the guidances, saving patients, we all are looking to you. I don't think we would be here if homegrown, trusted South Carolina medical professionals were in our frame as opposed to listening to a nationally directed, top-down, paternalistic, heavy hand that sometimes has just not been dependable or consistent. That doctor-patient relationship, if nothing comes of the work today, just to hear you and others, everyone that's been involved so far, echo the commitment to that principle and that guidance brings encouragement to me. So thank you, Mr. Chairman.
Thank you. Thank you for being here, sir.
Yes, thank you.
Next up, Mr. Thornton Kirby from the Hospital Association.
Thank you, Mr. Chairman, members of the committee and subcommittee. Appreciate the opportunity to be here. Members of this subcommittee had asked us to bring a number of people from across the state. We did that. We brought people from medicine, nursing, pharmacy, rural, urban, geographic spread, and we recognize you can't hear all those today. I'm going to suggest that I defer most of my time and let you hear from a couple of physicians and a pharmacist who can answer your questions that you've raised several times. With your permission, I'd like to make 2 points.
Yes, sir.
If I could. First of all, I want you all to know that the hospitals in this state are universally eager to administer as much of the monoclonal antibodies as we can get our hands on. We are frustrated, like all across the country, that the supply is interrupted. We're working closely with DHEC to try to make sure it's distributed where it's needed most. But there is no hesitation, despite what some have said on social media, from the hospital and physician community to administer monoclonals. They are very effective, and we want to do that. The second thing I want to point out, there have been a lot of comments made about the relationship between hospitals and doctors and whether hospitals are restricting the ability of physicians to order what they want. And I do want to make sure I clarify something. In my previous career, I was a hospital attorney. Practice law like several of you practice, and I gave advice to hospitals. And I want to make sure you understand that the fundamental legal tenets in this country are such that from the state and federal congressional bodies, state and federal regulatory bodies, and accrediting bodies, it is not the purview of administrators to determine the medical decisions that take place in a hospital. That is done by delegation to the medical staff. So when you hear a statement that that a hospital has a protocol about what drug should be used or what should be on the formulary, that is a true statement, but it is not the administrators, not the CEO, not the CFO, not anyone else who determine that. That is a committee of the medical staff that makes that decision. So it is a group of physicians who determine what should be the protocol. The other thing is protocols are not binding necessarily on physicians. They are guidance for physicians, and I hope you'll ask those questions of the physicians who will step up here. Those are the 2 points I wanted to make. The hospital, when we say hospital, there has to be some process in a hospital to make a decision, and medical decisions are made by physicians in the hospital, the medical staff.
Senator from Colleton has a question. I've got a quick question for you after her.
Just a quick one. About the monoclonal series, what has caused the shortage around in the U.S.?
I do not know that, and I don't want to speculate.
They haven't given a reason or anything like that?
I suspect it's the fact that we have a lot of people in the country who need it, and everyone is demanding it at the same time.
Okay, thank you.
Seems simple, but that's the answer.
One question. Do ventilator reimbursements for COVID patients versus non-COVID patients, do they differ in hospitals?
I do not know the answer to that. Generally speaking, reimbursement increases with the intensity of services that are provided to patients, but there are also what we refer to as diagnosis-related groupings, or DRGs, that have a flat payment for a particular type of care regardless of the resources used, and so I can't answer that question. I'll be happy to try to follow up.
If you could follow up on that, just with the committee staff, and nothing right now, but thank you. And who did you have next?
I was going to ask Dr. Cawley from MUSC to speak next, and then Dr. McLean from Roper St. Francis, and then Jenna Swindler, who is a PharmD, a pharmacist from McLeod. If you could give them a few minutes to make a few comments, you can ask them questions. I think they can address many of the things that have been discussed today.
Thank you.
Yes, sir. Thank you.
Mr. Chairman, members of the committee, Pat Cawley, CEO of MUSC Health. I'm also a physician, an internist, and actually a hospitalist. That's somebody who just sees people in the hospital. Just three quick comments, and then I'm happy to take any questions. And my comments are based on hearing what's going on today. Today's theme is therapeutic options. The one therapeutic option we have not talked about is hospitalization. some people need hospitalization. That's the only therapeutic option they have, and there's other things that we give them during that hospitalization. All the hospitals in the state are extremely busy right now, right? Extremely. Now, we're kind of hoping, we think we hit a peak, and maybe we're coming down the other side of that, but the other side of that is not steep. It's been very slow. I point this out because in June, May, June, when things got kind of quiet and I think we're all taking a big sigh, one of the things we saw at MUSC, we can genetic sequence COVID tests, and we started seeing at the end of May, right, the last week of May, there was a very small baseline level of COVID in the community, and then it upticked just a little bit at the end of May. And then almost every week until the end of June, it upticked, and it was the majority by the end of June. And by mid-July, so 6 weeks, that's all it took, 6 weeks, it was 90+%. This thing came in super fast, and the hospitals got hit almost in a way unexpected, because I don't think anybody thought this could come in that fast. Then all of a sudden, staffing, we had to upstaff within a week or two. So one of the things that we worry about is how do we hospitalize, how we staff. Those things are very important, and we'll continue to work on it, but my worry is that the next time this occurs, we'll have another problem just like it. It'll come in fast, and we're all going to be stressed again to provide that hospitalization. Second thing, monoclonal antibodies. I gave testimony in this actual room back in December of last year and talked about monoclonal antibodies. We thought at MUSC that this therapeutic option held great promise. And the use of monoclonal antibodies is increasing in medicine, and we're going to see it more and more in the coming years for all kinds of things. That's based upon years of research, but we saw monoclonals come in December. We started being available at the end of November, and we started using them ourselves in December. We said then, and I think it's still important to remember, what we got to get people to do first is when they have a positive COVID test, the first thing they need to do is they need to do an assessment on whether they need a monoclonal antibody. I think we finally got to that. We were fighting that up until probably last month or the last 2 months. People are coming and wanting monoclonals like we never saw before. I mean, we were pushing, even in May of this year when the numbers got real low. It was hard to get people to understand, but we're on the other side of that now. Our problem now is supply. Supply has been limited almost from the beginning. It got okay when things got real low in terms of numbers in May and June, but it started shooting up in July. The hospitals are, for the most part, very much behind monoclonal antibodies, getting these infusion centers going. It is a little tricky. We're trying to start an infusion center when we're getting hit in the hospital pretty hard. You need nurses to deliver these things, and it becomes a little bit of a catch-22. But we believe in them, and we know there's many across the state that have stepped up and done this. It's mostly the hospitals doing infusions. There are some other infusion centers doing it as well. The third thing I would mention here is therapeutic options. If you go back and look at the beginning of COVID and track things over time, things have changed. And they're going to continue to change. Monoclonal antibodies, what came out back in November, are different than what's available today. Doses are different. Its effectiveness is different. These are things we've learned over time. At MUSC, we take a somewhat similar approach to DHEC. We have our teams of specialty doctors, infectious disease doctors, pharmacists, all kinds, get together, review the data, and then we put out our own recommendations. And we want to encourage people, though, to get people in trials. I mean, there's a lot of discussions around ivermectin, but there's 2 good trials going on right now, and there's a lot of COVID. Be great to get people into trials so we can answer this question sooner rather than later. It's really the only way to answer this question. We got to get people into trials. We're running trials at MUSC. We're dedicated to try to run trials on all kinds of things. And so we would encourage, in order to answer some of these questions, that we get people into trials and get them in quick. The time to get them in trials is when we have these surges. When the surge goes down, then it takes forever to enroll people because you don't get enough numbers. So that's my final comment. I'm happy to take any other question.
I've got a couple questions, and one, this is what I get from constituents a lot, and I was waiting for the appropriate time to ask it, and I think you might be that person. If one of my constituents gets COVID, whether or not they go to the hospital, they're sick for a couple of days, maybe they get over it, they've had COVID, and they're better. What is the difference in them as far as being immune versus someone who just got vaccinated? What would be the difference in those two people?
Yeah, it's a great question in that it appears that if you've had COVID, right? And remember, this is data we're looking at almost every month. It appears that it's holding. Your immunity is holding and does hold. Now, then the question is, do you need a vaccine on top of that? Right? That's unclear. Does that actually make it better? There's really no data out there. At MUSC, and many of you know this, we have a required COVID vaccine policy. And we have two ways you don't have to get vaccinated. One is if you have a religious exemption or there are medical exemptions. And inside those medical exemptions, we do allow, if you've had COVID before, that's actually a medical exemption. So,
wow. Well, I'm glad you said that, because I think a lot of people out there aren't aware of that. And I'm glad I asked you.
If you look, and we've taken a very data-centric approach to this. If you look at the data, it appears if you've had COVID, your immunity is holding, right? Now, this could change next month. If all of a sudden data comes out next month and it turns out that at some point in time the data changes and you should get a vaccination, we'll make a determination at that point. But it appears to be holding.
Okay, and thank you. And my other question is, this is one I wrote down because I've heard this in some of the committee hearing we had, and then some emails that have been going around. Are patients diagnosed with COVID being discharged to home and told to wait and come to the emergency room only when they can't breathe? To your knowledge.
Yeah, I don't think that's an issue. I think it's probably common. I'm going out on a limb here. That if someone comes into your office, you diagnose them with COVID, and you're counseling them on where to go next, that may be maybe a oversimplification of something that's said to them.
Okay.
We think anybody with COVID needs to be monitored and checked in on, and particularly those that don't have family.
But the doctors could have said all that, but the takeaway from that person who said it could have been, well, they just told me to go home, and if I couldn't breathe, go to the emergency room. That could have been what they heard.
Yes.
Okay, thank you.
Yes, there's a lot that happens when a doctor's talking to a patient, and we know that patients don't hear it all. They just don't hear it all the time, and there's plenty of data to actually show that. So
right. It's like, well, I'm not going to say this because we're on camera, and I was going to pick on a family member, but then it will come back to bite me, so I'm going to leave that alone. Is it true that 80% of patients diagnosed with COVID who get placed on a ventilator end up dying and never come off that ventilator?
I don't know the exact number, but it is a fairly high number. I mean, when somebody has an organ failure, and if you need to be put on a ventilator, that's an organ failure. That means your lungs aren't working. When you have the second organ failure, so say you start having a heart problem, or you start having a bleeding problem, or something like that, every time you add one of these problems, your likelihood of dying significantly goes up, all right? And that's what we're seeing happen. We're seeing people have multiple problems. So it's not just that they need a ventilator because their lungs aren't working, but all of a sudden multiple other things are happening. It's mainly chronically ill patients of some degree who end up in the hospital and ventilated. And they're already starting with other issues. Now, that's not everybody, but that's in general what is occurring.
And I guess my final question is, I've had a lot of emails about, and again, I'm an engineer, I'm not a doctor, so I'm probably pronouncing this incorrectly, remdesivir, is that?
Remdesivir, yes.
Yes. I'm being told that is actually counterproductive, that it's causing some organ failures, that is causing patients to go on the ventilator, and maybe they wouldn't have without being given that drug. Do you
No,
have enough to comment on that?
Yeah, on the
Okay.
inpatient side, if you're sick enough to be admitted for COVID, remdesivir is clearly a therapeutic option that you should want and you should get. It does not exacerbate or cause other problems like you just mentioned.
Okay, thank you for that. Who was Senator from Orangeburg was, and thank you for answering my questions.
Sure.
Thank you for being here, Doctor. So I just want to talk, just to get the numbers that people can understand and I can understand. We've had hundreds of thousands, actually more than several million people get vaccinated in South Carolina, correct?
Yes.
But as far as monoclonal antibodies statewide, during the whole time they've been available, probably less than 25,000?
I think I heard Dr. Zimmer say 36,000.
36,000,
earlier
okay.
today.
So, and you can get vaccinated in about, even with the observation period, maybe a half hour?
Yes.
But if you have to be put on the IV for the antibodies, how long does that take?
Well, early on, it took longer. It was almost an hour infusion. The newer infusions can be done in a shorter period of time. But it's the hard part there is not actually giving it. It's actually finding a place that you can get to. You know, I probably have to deal with this myself 2 or 3 times a week. I get a call from a patient or somebody that's got COVID and they ask for help getting to a place. If we can get them in to MUSC, we'll get them in. But sometimes I have to call somebody else, got to call Roper across the street, and we just don't have capacity. And it only works if you get it within a certain period of time.
Right, and to get the infusion, you have to have a needle put in to your arm, or?
Yes, it can also be given as a subcutaneous injection.
Okay, but it's the idea that
It
somehow
involves a
the
needle.
vaccination involves putting a needle in you, so does monoclonal antibodies, right?
Yes, it involves a needle, yes.
Right, and the notion that the vaccine is a new concept, monoclonal antibodies is even newer. I mean, we haven't had those for the last few months, and the vaccine's been around since last November, right?
Monoclonal antibodies as a therapeutic option have been around, but for this indication, it has been around just less than a year.
Yeah, right. So, finally, on the monoclonal antibodies, if you get an infusion pre-COVID, does it have a prophylactic effect?
There is some data, and I can't speak to it fully, but there is some data. If you've had a significant exposure to COVID and you're at high risk, right, that getting a monoclonal infusion actually helps you, right? So, you know, and I suspect as the data continues to evolve in the next several months, I wouldn't be surprised if we find that you know, maybe if you're not as sick, that there may be some place for that. So I wouldn't be surprised. At the moment, we don't do that. We don't have a lot, so we try to give it to the people that need it the most. I can't emphasize enough, though, for people to try this. I have personally seen people who are really sick, and they get their monoclonal infusion, and you know, almost in 24 hours, they're much, much better. So we advocate for it. I tell you, the hospitals are on board about this. It's kind of in our sweet spot to do anyway, setting up infusion centers and nurses and things. We would just love to have more.
So what percentage of the patients that do come in with COVID to the hospital setting are getting the antibodies?
That actually, I can't answer that. I'll have to get that number to you. I'm just trying in my head. At MUSC, we've given, by the end of this week, we'll have given about 2,500 doses of monoclonal antibodies. We've admitted probably 4,500 people to our hospitals. I don't know if there's a correlation there or not, but it just kind of gives you some of the numbers to work with.
Thank you. Senator from Richland, Senator McLeod, then we'll get to Senator Scott.
Thank you, Mr. Chair. I thank you for your testimony.
Thank you.
I have what I think is a quick question about the monoclonal antibody treatments, because I remember when the governor got COVID and received it was reported that he received the monoclonal antibody treatment. If my memory serves me correctly, I think also included in that report was an issue with the actual with everyday people being able to access the monoclonal antibody treatments. And so I want to know why that is. I saw something recently, I saw something in that article when after he received the treatment that, you know, it wouldn't be accessible to most South Carolinians. And I wondered why. And nobody's been able to answer that for me. And now that it's become a little more common, I'm still concerned that people who test positive for COVID-19 and are good candidates for the monoclonal antibody treatment will not have access to it without a physician's referral. Or what are the stipulations around receiving that treatment, and why is it more difficult for everyday people to access?
I think there were two phases here, and I would agree. I think it's still difficult today to get it. I think the first phase was just getting everybody educated on it. And that's what I said early on. We were talking about, if you have a positive COVID test, think about monoclonals. Think about it. I mean, that took months. I mean, it was a new treatment. It's an IV treatment. I mean, it takes a lot of education. But eventually, I would say by end of January, I think most of the hospitals were well into it and getting their infusion centers up and running. And I think it happened, right? So I think we got over that hump of education. The hump now is that, and part of what happened here too was everybody ramped down their infusion centers when COVID kind of went away in May and June, and then they had to ramp them right back up. So, you know, that was a little bit of a blip at that time. But the problem right now is there's just not enough. There is no way is there enough. If we had more, you know, we could go out more and educate more. We try to make it as easy as possible. You know, if somebody has a positive COVID test, they just need to go to our website, and we sort of take it from there. But it's. I'm sorry.
May I ask you one more quick question? So, do you think, in terms of your medical knowledge and expertise, do you think that we are now at a point in South Carolina where the desire of South Carolinians is more towards getting the treatment than doing the prevention? So are we seeing more South Carolinians who want the monoclonal antibody treatments versus the vaccine or the safety?
There doesn't appear to be any polarization around monoclonal antibodies. In fact, I was just reading, and I think it was the Wall Street Journal this weekend about that. That it's the one thing where everybody seems to agree. So,
is a doctor's referral still required to receive it?
Yeah, most places, yes, or you have to have a positive test. I'd say most people are lowering the barrier. Like we've made it really, really easy to get it ourselves, and I think most other places are doing the same thing. But you know, I could get triple the amount that we get today, and I could use it all up. So it really is. It's supply at the moment. That's what's holding us back.
Thank you. Other senator from Richland, Senator Scott.
Thank you so much. Thank you, too, for coming and sharing.
Absolutely.
Of all the many multiple locations, and welcome to Richland again. We're glad to have you here.
Thank you. Glad to be here.
That you have hospital services. On the earlier testimony that we received, both by Zoom and also from last week, it appeared to me, unless you've got some in the locations that you're in, some of the statements that was made, it appeared to be more of isolated in a particular area. That conversation in terms of hospital practices and what doctors says they can do and cannot do, and inability to get prescription filled, and all those issues occurred. Have you seen in the multiple locations? Let me express that: Marion, Charleston, Mount Pleasant, Florence, you name it, that you've seen this happen? Because if it's isolated,
I'll answer that in two ways. I'll answer it on behalf of MUSC, and then I'll answer on behalf of multiple hospitals who I'm in touch with on a regular basis about what's going on. So from an MUSC perspective, we have not seen that.
Okay.
We don't restrict what our doctors can do. If our doctors want to order something, they can order something. We do give them data on recommendations and things like that. But if they feel for that particular patient they need to go somewhere or do something different, they're allowed to prescribe or do what they need to do. I have not personally heard about issues with pharmacists. I'm sure I would have heard it in my own hospital if that was an issue, but I haven't heard that. Haven't had physicians coming to me from an MUSC perspective. Right? The other thing I would answer is I'm on, just like Thornton mentioned earlier, I'm on the board, on the executive committee of the South Carolina Hospital Association. This is a question we've asked. I can't find anyone that deliberately restricts physicians from ordering what they want to order. Right? Now, I do think Thornton made a point that the medical staff may decide that someone should be treated in a certain way. The medical staff comes together and makes recommendations, but we're not restricting what the doctors do. So I just wanted to clear that up as well.
But if you had heard that there had been some restrictions in the multiple hospital location, would you not have heard that by now?
I have not heard that. Not heard that.
Because if it's an isolated, that means that there is an educational process that we need to make sure that we take care of. Like I mentioned the DHEC before, trying to bring those who are major participants in making sure that our healthcare system work, to be able to have dialogue and to make sure we clear the pathway so if there's misinformation out there, we get that cleaned up, we move forward. We're open to everything we can to try to take care of this pandemic that we're in, because if not, it's going to get worse. We thought we were out of it. We're in it worse than before. Thank you.
Thank you. Senator Verdon.
My apologies to everyone, including especially you, Dr. Cawley, for veering over to vaccine. But you made reference to MUSC's vaccination policy for employees. And we were talking about how vaccines polarizing and monoclonals not. And I believe that the future, if everyone gets healthy today, the polarization over vaccines not going away, even though we can be thankful everyone's healthy. But you are allowing a medical exemption, a religious exemption, or a test, I think you said a testing option.
We have not, we don't do that option. So the way it works at MUSC is.
And what I'm driving at is, I think won't be long before we're having legislative debates about your immunization status versus your vaccine status, because we're obviously finding out that the two are not equatable. There's plenty of people that are vaccinated that we're finding now are not immunized. So I'm kind of trying to look into the future about the status of someone who does have immunization and what their ability to maintain employment is going to be, even though they may not be vaccinated.
Well, in hospitals, right, prior to COVID, right, most hospitals these days, this really happened in the last 7 or 8 years, we've all had required vaccinations. We've had for a long time. 7 or 8 years ago, most hospitals started requiring influenza vaccines. And at this point, most hospitals require influenza vaccines. And there are religious and medical exemptions for those. They're very tiny every year. They're less than 1%.
Okay.
But if you don't elect an exemption or you don't get it, then you can't be employed. And we have in the past people who have not gotten the annual flu vaccine. We have terminated their employment. We're looking at COVID the same exact way, right? Now, I have to say, and we're a good experiment, what happened here in the last several months, right? So MUSC went through this policy requirement. Got to be careful. It's not a vaccine requirement. It's a policy requirement. What happened in MUSC, about 85% when we started, before we started, we couldn't get the vaccination rate up above 65, 67%. When we required compliance with the vaccine policy, we got up to about 86, 87%, right? That means 13% of people elected a religious or medical exemption, right? Now, I know a lot of those medical exemptions are people who had COVID before, right? But still, and it's been reported across the country that medical and religious exemptions have risen with COVID, right? But despite that, right, and we're not forcing that last, and that's fallen from about 13%, it's about 9% now.
And you're testing them?
No, what we're doing is those people have to fill out a pre-shift report on symptoms.
Okay.
So we have found that that's actually a little better. We force them to tell us what's going on, and then if they have a symptom, then they get tested. If they're not symptomatic, then they can go work the shift. But despite that, right, if you look at the number of employees we had out this summer, if you look at July and August, right, we never had more than 50 to 70 employees out. Now remember, we're about 17,000 people. We never had any, on any particular day. It was remarkably solid and steady out because of COVID, right? If you compare that to other health systems, that was about a fourth of what other health systems were seeing. So I do think, and we've reported on that, and there's a health system down in Texas that did the same thing. They're reporting very, very low numbers of employees out. When that allows us to keep going. That allows us, it goes back to my original comment about hospitalization being a therapeutic option. We did not have to stop elective procedures, got close, but we did not have to do that. We were able to keep the business going. So I do think, and that's why we started influenza vaccine, because during a bad flu season, the number of employees off was astronomical. And that's how it got started. And it's the same issue here. We're going through it gently. We're talking about why we do it. And at some point, though, I do think we're going to have to call the question like flu. Now, I don't know. Is that a month from now? Is that 2 years from now? I don't know. We'll see.
Thank you.
Thank you.
Thank you for being here, sir.
Thank you.
Was that it, Thornton, or you got one more? Okay. Thank you, sir.
Thank you, Senator. Thank you, Chairman. Distinguished guests. My name is Christopher McLean. I'm the Chief Physician Officer for Roper St. Francis Healthcare. I'm a traditional internal medicine specialist, which means I treat patients both in the hospital and out of the hospital. Have been doing so for the last nearly 20 years. My administrative role in the health system is to function as a dyad leader with the Chief Operating Officer, and we oversee all of operations for our health system. So our health system is very committed to physician leadership, and I just want to reiterate that's one of the reasons that I got into this leadership position was that commitment to having physicians involved in nearly every decision that's done in our health system. So I just want to reiterate the fact that was made earlier by Mr. Thornton that the decisions made about therapeutic options in our health system and nearly all health systems across the state are physician-led in large part. Certainly I can testify to that in our system. But I appreciate you having me here. Thank you for inviting us all to speak. Today, I want to bring into focus the current crisis in our healthcare system. I know that what we're here to talk about is treatment options, but I think you can't understand the actual delivery of that treatment unless you understand some of the obstacles that we're also facing in our system. Over the past 18 months, our system has experienced 3 significant surges in patient care. This most recent surge has been characterized by an increase in hospitalizations with younger patients, longer length of stay, increased morbidity, specifically in respiratory distress and the need for high-flow oxygen and mechanical ventilation. This has unfortunately coincided with a community resistant to social interventions that were shown to be beneficial in the first 2 surges in controlling the rate of spread, and as you've heard, an unprecedented increase in critical staffing turnover and burnout, resulting in exceeding reliance on temporary rapid hire staffing. The RN turnover rate that we've experienced, and this is bedside RNs, has been 66% increase over this surge, as well as respiratory therapy, which is seen as a 130% increase in turnover. And that's in a health system that was just awarded one of the top 30 places in the country to work. So it's not because of the condition pre-existing in our health system. I don't think it's because of the stress and the burden on these healthcare providers. I'm pleased to report that even with these challenges and the increased infectivity and transmission and morbidity that you've been hearing about with the Delta variant, we're able to perform in the top decile of the quality indicators that we monitor through this pandemic. And I think that's really important to understand, that the purpose of that physician-led treatment protocols is to guide that quality outcome. What we care about is quality outcome for our patients. So we're committed to continued improvement and agility in refining our treatment protocols based on emerging evidence and deploying the lessons that we learn. We have discontinued therapies that have shown to have no benefit, and we have increased the utilization of therapies that have demonstrated benefit, and we consistently counsel on the protection of social interventions and the unparalleled safety and efficacy of our best intervention, which is the vaccination. These outcomes have been achieved through heroic sacrifice, grace-filled team-based care delivery, and a commitment to excellence from a team who feels currently isolated, dismissed, and forgotten by much of the public. Our team has not been the only ones to sacrifice during this surge. We've been forced to delay surgical intervention that over 500 patients need in order to accommodate the emergent volume of COVID patients coming into our emergency departments. It's deeply concerning that while our health systems have been much closer to collapse than ever before in our history, the awareness of the crisis in general has been superficial at best. Daily, the tragic stories of young patients experiencing horrible diseases are still being met with disbelief and shock by the public. I cannot overestimate the impact of this ambivalence on the frontline provider. My colleagues are truly grieving at the bedside due to the gravity of the clinical situation, only to have their grief compounded by the political debates that they are thrust into as they leave the workplace and interact with the community. Being accused of withholding care for financial or ideological reasons is not just insulting, but it is truly harmful to our frontline workers. These effects on our staff are profound and will likely have ramifications for years to come. Again, I applaud the committee for their insight in holding this hearing to elevate awareness in the nature of this crisis, and I would ask that the same proactive spirit be used to dedicate our state resources to the following asks. Number one, advancing access to monoclonal antibody infusion. Number two, advancing the access to innovative approaches to patient care, such as hospital at home or hospital without walls endeavors that extends our ability to access patients. Improving feasibility of telehealth extension through payer stabilization and broadband access. Embedding liaisons of state health agencies into incident command structures of our state health systems at the onset of incidences. Improve predictive modeling to guide preparedness of our health systems earlier and allow us to earlier deploy social interventions and start the start of future diseases, such as, like we've seen with the monoclonal antibody infusions. Increase public awareness of the facts of this crisis and the indisputable evidence of the safety and effectiveness of this vaccine. Develop infrastructure to improve real-time visibility of statewide bed availability, to improve collaboration among healthcare systems and assets, and facilitate well-designed trials to answer the treatment questions which we've all been wrestling with today. So again, I thank you for your time and your consideration.
Thank you, Dr. McLean. Let me ask you this question. You mentioned hospital at home. What sort of regulatory or statutory changes would be necessary in order for you to optimize that particular option?
I'm not sure. I'm definitely the first person to answer that, as I don't have a legal background. However, what I do know is that there have been times when the regulations around who can enter into those programs have been allowed, and that specifically under state of emergency, but there's other options as well. And I think we've been reaching out to try to understand what those options are.
If you could provide the chair, perhaps, maybe some policy recommendations in that regard, because certainly if ICU space and bed space are issues, then we ought to optimize this hospital at home option.
Absolutely, and we've been working with DHEC to try to formalize what those recommendations might be.
Okay. Questions for Dr. McLean? Senator Hutto.
So the medical staff of each hospital sets the protocols for the doctors if there are any protocols to be set, correct?
Yes, sir.
So if a doctor wanted to prescribe something or recommend a treatment that had not been approved, there is a mechanism whereby that doctor could approach the medical staff for approval. Is that right?
Yes, sir.
So it's not just that it's completely my way or the highway. There is a process by which, and things evolve over time. I'm sure a lot of times doctors come forward and say, I went to this conference and this is what they're doing here, or I've been reading this study and this is what I think we ought to try.
it's not what we've been doing, but something new, and they approach the medical staff. Can you explain that process a little bit?
Absolutely. So yes, we do have that process, and it can go through the Therapeutics Committee, of each hospital. Most hospitals have those. Another way, and which has been especially useful in the pandemic, has been through clinical trial administration within the hospital. You heard Dr. Cawley talk about that. If you go through that process, I think the correct checks and balances are in place with maybe early detection of harm. If there's any harm, that's always our first concern, is do no harm. And certainly entering into a clinical trial puts in place some of the safety mechanisms that help us ensure, the desired outcome is kind of what we're moving towards and not actually harming people.
Thank you.
Thank you, sir. Any other questions? Thank you for being here.
Thank you.
Good afternoon.
Thank you, Mr. Chairman and members of the committee. I'm Jenna Swindler, and I'm a board-certified infectious diseases pharmacist and the Associate Vice President for Care Transformation at McLeod Health. You guys may know McLeod Health serves many counties across South Carolina, but we have acute care facilities in Chesterfield, Clarendon, Dillon, Florence, and Horry counties. Our remarkable teams have gone above and beyond and served over 15,000 inpatients with COVID since March of 2020. And we really appreciate being here today to share our experiences, most specifically as it relates to monoclonal antibody therapy. There's been a lot of discussion about that today, and so I'd like to make a few points, if you don't mind, about that. We've currently treated over 5,000 patients in our organization with monoclonal antibody therapy at this time. As we've mentioned earlier, these therapies have been used to treat various diseases for the last few decades, actually. But clinical trials have shown that patients who have mild to moderate COVID-19 actually have a less risk of progressing to severe disease or need for hospitalization or even death compared to patients who don't receive monoclonal antibodies. Due to these promising results, our hospital really decided, as soon as the FDA gave the emergency use authorization in early November, that we were going to look into the logistics of how we could offer that. You've heard many of us say that creating these infusion centers and having access to care was a barrier for us to try to get this started. We infused our first patient at McLeod Regional Medical Center on November the 26th, and we quickly identified that we needed to spread this to some of our other service areas like Clarendon and Horry County, which were hotspots at the time. We looked for ways to evolve because access to care was definitely a big concern that we had. We started by letting outpatient physicians send in referrals, but we saw that there were barriers to that for our patients. There were a lot of physicians who maybe didn't feel comfortable with this newer, novel therapy, and so patients were getting pushback from their providers about, I don't want to prescribe the monoclonal antibody therapy, I would rather give you azithromycin or hydroxychloroquine. That was creating delays for these patients to get what we knew was one of the newer effective therapies. Another thing that we noticed is that many of our patients struggled with maybe they didn't already have access to a primary care physician who would do that referral for them. So in early January, we created what we call our self-referral process, where patients can go to our website, submit their information, including their date of symptom onset, the date that they tested positive, and then answer a series of questions that denote to us whether or not they qualify for this therapy based on the restraints of the emergency use authorization that is set out by the FDA. One thing to note about that authorization is that patients who are sick enough to be hospitalized or who are on oxygen therapy are not candidates for this drug. So that really limits us and makes us have to work very hard to get them very early on in their disease course. So we didn't want to have any delays in that. Once patients go through that self-referral process, what we do is we do a telephone visit with them and a provider to discuss the therapy, if it's right for them, if they have questions or concerns about that, and we schedule them for the appointment so that we can get them in as quickly as possible. We've seen from the data that we have in our patients that if patients wait a day and a half longer, they're more likely to have to be hospitalized or progress to needing an ED visit than if we get them very early on in their disease course. So speed is important and access is very important in this therapy. Our efforts really have paid off in helping us with our hospital capacity because, as I've mentioned, these patients are less likely to progress to needing hospitalization or a visit to our emergency departments, which are also overwhelmed at this time. And we've been tracking data on these patients and comparing what their rate of hospitalization is compared to groups in the placebo of the controlled trials, which means they got no therapy at all. What we found, and as a previous presenter has mentioned, is that patients who received no therapy, their rate of needing hospitalization was around 15% versus the patients who did receive therapy. And what we've seen consistently is those patients who do receive therapy, only 5 to 7% of the time need hospitalization or an ED visit, at least within our system. One thing that has been really discouraging, as you can tell, to the healthcare community is the change in the allocation process and the distribution of monoclonal antibodies. There was a new indication that was approved for monoclonal antibody therapy just a couple of months ago for post-exposure prophylaxis, which means that if you're in close contact with a patient or with a person who has COVID and you are not vaccinated, then you could be eligible to receive monoclonal antibody therapy just because of that exposure. When the FDA added that, that really escalated monoclonal antibody supply issues across the nation. As you may have read, there have been 7 states that have been accounting for 70% of the supply over the last couple of weeks because they've gone out and created these post-exposure clinics for patients to go to. When our approach in South Carolina has primarily been that we need to treat the patients who are positive because this is a precious resource that's helping patients not progress to needing hospitalization and really conserving our hospital capacity. Because of this, our allocations have been decreased in comparison to what the state of South Carolina has needed previously. McLeod Health, for instance, had about a 20% decrease in the product that was allocated to us based on what we had used historically. We had to pause beginning to expand our offering in Chesterfield County, which is a county that has low vaccination rates, and so they could really use the help of having this as a treatment option. And we also had to cut off our self-referral process for quite a few days while we awaited to see what supply would do. This was really discouraging to us because we had been very proud of the rapid access and the equity that we were able to provide to our patients, and that's the reason that we've been able to touch so many lives and prevent so many hospitalizations. So I'm here today basically, asking that anything that our state can do to help increase our allocations so that the hospitals and the sites that have popped up these infusion centers for treatment can continue to prioritize this therapy for treatment of positive patients, instead of it being deployed to other areas who may be just using it for prophylaxis in a patient who may or may not ever actually contract COVID. Thank you for having me today.
Thank you. Senator from Orangeburg, Senator Hutto.
2 quick questions. One of the reasons I've heard people give for not wanting to take the vaccine is because it's new and but you just said the monoclonal antibodies is actually an emergency authorization itself, right?
These products are not fully FDA approved. They are under an emergency use authorization by the FDA and have been since we started giving them in November. It's very interesting to see the paradigm shift of when we first began offering the therapy, we were actually outbound reaching to patients who had come to our specimen collection unit and telling them, there's a new therapy, because you're over 65, you're eligible. Are you interested in this? We'd like to send you the information. And then they were signing up. And we had a lot of resistance and kind of had a hard time getting patients into those appointments.
It was new, it involved a needle.
Right. Absolutely. And so then fast forward to this current surge, and the demand for it is overwhelming. We actually began partnering with HHS, and we're the only site in South Carolina who has partnered with them to expand our offering of monoclonal antibodies so that we can treat more patients. And we escalated our operations to provide over 100 appointments per day until we had the supply issues last week.
All right, the other question I have for you is this. Are you aware of any pharmacists being sanctioned, threatened, or anything else that if they fill certain prescriptions that they're going to lose their license?
I am not aware of that. I am primarily an inpatient hospital pharmacist. I've definitely not heard that in the hospital circuit, and haven't heard that from many of my retail colleagues, but I do know that the Board of Pharmacy is here today, and they could probably answer that question better than I could.
Thank you.
Thank you. Any other questions? If not, thank you for being here. I want to thank everybody on the committee for being here and everybody in the room for their patience and getting through this issue. And as we said before, that's fine. Can we get one person from the pharmacy board to testify? Thank you.
Yeah, thank you. So my name is Mary Douglas Smith. I am a pharmacist. I am on the Board of Pharmacy, and I am the Director of Experiential Education and an Assistant Professor of Pharmacy Practice at Presbyterian College in Clinton. I remember that from this summer. And so I am happy to be here today. I really appreciate this opportunity to speak with y'all and hear the other testimonies. I do have an opening statement prepared. I'm going to reduce it very short. So we as pharmacists are guided by three principles: the law, the professional code of ethics, and evidence-based standard of practice. With every prescription order received from a prescriber, we balance the risk, benefit, and patient autonomy in being the dispenser of this medication. We are not simply vending machines that deliver medications to patients. We have received more than 6 years of education and training in medicinal chemistry, pathophysiology, pharmacokinetics, genomics, and therapeutics. Our clinical reasoning skills started in school and have been refined over years of practice, influenced by our experience, intuition, and knowledge. We look for guidance from many sources: the evidence-based literature, the FDA, the CDC, and even our state agencies like DHEC. The South Carolina Board of Pharmacy, by statute, relies on a pharmacist's professional judgment, and to date, there has been no board discipline against any South Carolina pharmacist related to the decision to dispense or not dispense an off-label treatment for COVID-19. Just as doctors have a physician-patient relationship, we pharmacists have the triad that includes the relationships between ourselves, the prescriber, and the patient. We value this triad to keep the open communication with each of the parts to make the best, most informed decisions for our patients. I'm happy to answer any questions.
So I do have one question. So if the doctor from Spartanburg, he writes a prescription for ivermectin, it comes to your pharmacy, how do you handle that?
So there was some guidance.
Excuse me. He writes a prescription for ivermectin to treat COVID-19.
Okay, thank you. I have not typically seen river blindness in my practice either, so I would assume it is for that. Earlier this year, throughout the pandemic, there were 39 boards of pharmacy, including our own here, who released guidance to pharmacists when receiving these types of prescriptions. Use professional judgment, consider the amount of medication dispensed, and verify a diagnosis prior to dispensing. That was not to prevent or inhibit, and this joint guidance was issued by both the Board of Medical Examiners as well as the Board of Pharmacy in March 2020, and has been rescinded effective of June 2021 when the state of emergency was lifted. So to answer your question more clearly, I would still follow a similar guidance from that. If I was a retail pharmacist and I saw that, and I am, and I saw that prescription come in, I would talk with the patient about why they received it. I would look at the quantity prescribed. I have seen some of these scripts have been very high quantities, 100, 200 tablets. Of course, that does deplete my supply on the shelf, and so I have to consider that as well. Dispensing to one patient means not giving it to another. And then I would also call the doctor and just verify the diagnosis. I have a corresponding liability as the dispenser of that medication. It's got my license number on it. And so I would want to make sure that I understood the diagnosis and the reasoning for that prescription.
So when you call the doctor and the doctor gives you the reasoning, whether it's 50 or 100, whatever,
Sure.
and the patient says, thank you, thanks for calling my doctor, thank you for talking to me, do you fill the bottle with 100 and hand it to them?
If I thought that it was the best course of treatment for that patient and I was able to supply their needs, I would make that decision.
Let's say you've got 400 million pills on there and you couldn't even you have too many pills and you're trying to give them away. Are you going to override that doctor after consultation with the doctor?
Override and not fill?
Yes. Could that happen?
It could happen, yes, sir. I can give you an example of that. When I was working in retail pharmacy full-time, this was like 2010 or so, I would often see prescriptions for oxycodone, 30 milligrams, more than 300 tablets. It was a valid prescription written by a valid doctor, but I felt very uncomfortable giving one patient that many oxycodone tablets. And so,
and why did you feel uncomfortable with that?
yeah, there was a high diversion of those medications, especially in the middle of the opiate epidemic. In many of those instances, it was not a patient or a prescriber known to me. And so the patient might be from Kentucky, the prescriber in Florida, and they're here in South Carolina to fill it. I felt like the risk of having 300 oxycodone tablets to that patient and in our community was not worth the benefit.
And is that based off of what you know that those pills have done to people over the years?
Absolutely. Experience and intuition.
All right, and based on the testimony from the doctor from Spartanburg who said it was either nationwide or worldwide, there was 500 contributed to Tylenol, 1 for ivermectin. What would give you pause to, if ivermectin, it seems, if one person dies from ivermectin and versus 500 from Tylenol, why would it give you pause to even fill that prescription?
I also have pause filling Tylenol. I know that sounds silly, but a lot of the preparations of pain medications historically had 500 milligrams of Tylenol in it and instructions to take 1 to 2 every 4 to 6 hours, which results in more than 4 grams of Tylenol, which is toxic to the liver. So I don't know that I feel more hesitancy towards ivermectin than Tylenol, but I think I have hesitancy for all prescriptions where my primary focus is patient safety.
Right, but we're talking about ivermectin today, and I believe I could stop at CVS on the way home and buy a bottle of Tylenol and take 30 of them if that was my choice without a prescription. But I'm trying to figure out, we understand the opioid thing, and I think the Senator from Beaufort's trying to get us a different avenue to that. That's probably going to hear from him in January that you may or may not be prescribing sooner than later. But I'm trying to figure out what would give you pause after talking to the doctor, talking to the patient. You said you still may not feel. What about ivermectin gives you pause to not fill that prescription when you've called the doctor and you've talked to the patient?
The doses that are being written right now are high. They are less evidence-based than what we normally see for river blindness, for example. I would still be worried about side effects and toxicity.
And when you say
And
dose,
it's totally hypothetical, so it's hard to answer, based on the patient, if it was an adult versus a younger person, if they were healthy, if they had diabetes. There's so many factors that would go with that.
okay.
But that I would look at it, and I would look at the patient as a whole.
And when you say dosage, I know you said like 100 or 200. I'm assuming that's the number of pills.
Total,
and I don't know if ivermectin comes in 1 size or 40 sizes or whatever else. When you say the dose, are you talking about the actual milligram of the pill?
Yeah.
Or are you talking about the number of pills?
Both. So what I've seen is 3 milligrams. So it's a 3 milligram tablet. Take 8 tablets twice a week. That would be an example prescription.
Okay. But then but do you have knowledge to, like, when you said you would talk to the physician and you would talk to the patient, do you have knowledge? Like for me, if you told me to take 3 milligrams 8 times in 2 weeks, okay. I don't understand with ivermectin if it was 12 milligrams 8 times a day. I don't know that. But if you've talked to the doctor and the patient, and like we talked to the other lady, it was Dr. Cook, I believe, that said sometimes they make a mistake. Maybe he meant 3 milligrams 8 times in a week, but he wrote it wrong. And you've consulted and fixed that issue. But once you've talked to them and feel comfortable, what would prevent you at that point from just saying, no, I'm not going to fill this? And I'm not picking on you. I'm just saying for any pharmacist, because you're representing them right now. What would prevent somebody from still going ahead and say, I talked to the doctor, I understand what they're doing, the patient's fine with it. What would stop you from, what makes you say, nope, I'm just not filling this at all?
So fortunately, pharmacists have a lot of access to really good databases and resources. So just like a prescriber would go in and look at the literature, we would as well. We use those same Cochrane reviews, PubMed, LexiComp, and the first thing I would go do is see the maximum safe dose of that medication, whether it be ivermectin, Tylenol, whatever. If I still thought that dose, or I saw that dose exceeded that maximum dose, that would probably be my biggest hesitancy.
Okay. Thank you.
Yeah, thank you.
Senator from Orangeburg.
Hey. I have not, and I'm fortunate that I have a wide network of pharmacists, especially in this state. I have reached out to several, and I have not. Yeah, that'd be right. Mm-hmm. There certainly could be limits, like with the opiate crisis, we saw limits on that. That there was a store policy, and so I am sure that those are out there. I don't know any specifics though.
Thank you. Senator from Lawrence.
Thank you, Mr. Chairman. Representing the 2nd Congressional District.
That's correct.
So Dr. Cook testified that BME has enough trouble that comes to them that they aren't aggressively pursuing. The board, are y'all meeting virtually? Are you meeting at all regularly? So
we actually met in person last week over 2 days. And so, yeah, we are meeting regularly.
I know you can't specifically or discuss specific cases. No pending cases regarding malpractice or disciplinary action on a pharmacist regarding any of these other off-label you've heard. No awareness of anything that the LLR gatekeepers, and I should have refamiliarized myself with the complaint process and then how it's winnowed.
Yeah,
I
same
believe
process
actually
as
an
Dr. Cook, yeah.
Yeah, okay.
And so nothing has reached my level at all.
Okay. Thank you. Go Blue Hose, yes.
Yeah, thank you.
Thank you. I really appreciate you answering all these questions because it's, you know, it helps us get an understanding of what we're dealing with and what we, you know, versus what we get told. And so I appreciate you answering all my questions and all the committee's questions. And
yeah, happy to answer any more as the days go forward. Thank you.
And thanks everybody for their time. I'm not yet sure if I'm going to call us back on the 29th, but I will let everybody know. And thank y'all for being here, and we'll stand adjourned.